Good morning. I'd like to call this meeting to order. Welcome, everyone. This is the 2024 PEB Board Retreat. Our meetings this year will continue to be hybrid. Our very capable, flexible, adaptable IT staff, the Healthcare Authority staff, are going to be on site, and board members and other attendees that have the option of attending on site or via Zoom. They are available as things might crop up. And again, in advance, we can't control for all the technological things that seem to surprise mankind every day. So let's hope they don't happen in this meeting, but we appreciate everybody's flexibility. For our Zoom attendees, our opening slide has information about how attendees can turn on closed captioning subtitles. All right, so what I'd like to do now is a roll call to identify the board members that are with us today. Michaela Dolman. Present. Thank you. John Comerford.
Aye, here.
Thank you. Kurt Spiegel.
Present.
Great. And Kurt, I think you're going to leave a little earlier this afternoon, so we'll just note in the record, as that happens. Harry Bossy.
Here.
Great. Elliot Weinstein.
Here.
Thank you. So note that Elliot is on virtually. And then Tom McRobert. Tom has not joined us yet.
We'll be here, I believe, closer to 10:30, 11. So we'll make sure to, Mackenzie, if you can make sure we know when Tom joins.
Great. And also I'd like to highlight that we have Michael Tunick from the Attorney General's office here.
Morning.
See you. And I'm Sue Birch. We have one new board member who's here today with us, Dr. Sharon Lang. Thank you. She's an associate professor in the School of Nursing and Healthcare Leadership at the University of Washington. And I'd love for you, Sharon, to share with us some few words in it. Can we skip to Sharon, or would you prefer to us to continue to refer to them?
No. Sharon. Thank you, Director Birch. It's my pleasure really to be here. One of the main reasons why I'm very interested in being on this board is research I'm doing to support our healthcare providers and community health centers. I'd love to be able to not only gain from your knowledge and expertise, but also share what I understand. So, serve on the board and be of assistance.
Wonderful. Thank you for that. And I'm sure as we all have time in breakout sessions and continue on our journey of getting to know each other, we're going to learn more about you. And those different perspectives are so critically important to our board and to the work that we do. With board members attending both in person and virtually, it's helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members, those of you that are attending virtually, will also watch in case you use your Zoom's raise hand feature to indicate if you have a question. It is a little tricky. We will try not to miss anybody. And if we do, you can jump in. We just try to ask people not interrupt and that we stick with that process. There are no scheduled issues for action today at today's meeting. And as this retreat has been before, it's typically educational for the board. The public will later today be able to provide general comments towards the end of the retreat during the public comment period. As a reminder, if the public has questions during a staff presentation, the presenter's contact information is included at the end of their presentation. You can always direct any kinds of questions or email to any staff member or myself. And then we do like you to try to capture things through email and written, just so that we can bring this into the record and have a written response after the meeting. So I'd like Dave Eisminger now to provide an overview of today's agenda. Dave, good morning.
Good morning, Chair Birch and members of the board. Today, our retreat typically is very educational oriented. I will say though, at the end of the meeting, we have a very important presentation that is very educational and maybe depending on how the board's interest is in that presentation could lead to potential action earlier in the board season on policy issues than you're typically used to. So there's if you feel a little bit that it's education plus, that's probably a good way to think of today. But we're going to start off in our traditional manner with a panel and discussion about equity and healthcare access. Dr. Schultz, our Assistant Medical Director for the Employee Retirement Benefits Division, will lead with panelists from our carriers that have plans in our program. And then we'll give you an update on some diversity, equity, and inclusion data work that the agency's been undergoing for the past couple of years and give you a progress update on where things stand in that regard. Then we'll have a discussion about network adequacy, specifically from the lens of behavioral health, and what different terms mean when we talk about timely access to care, network access, and network adequacy, all important terms and concepts that are kind of another layer of health literacy that we really want to help try to kind of permeate more both here and within the membership that we serve. And then we'll move into what I call the past, present, and future part of the agenda. We time travel back to the fall and talk about what happened during open enrollment and what the results are of open enrollment. What the governors, earlier this month, actually since it's February last month, we launched Benefits 24/7, that online enrollment platform, and we'll have an update for you about how that is going. And some legislative reports that were turned in the past 2 months, as well as the governor's supplemental budget and the first 25 days of the legislative session and what's happening. Then we'll move kind of more into the forward part, future of the agenda aspects, and talk about kind of that benefit planning cycle that happens every year and start to generate some more ideas to kind of get in the pipeline for the agency to be evaluating. And then the entire second half of the afternoon is about Medicare. UMP Classic Medicare, to be specific. I know that board members that have been on the board for a long time, and Sharon, you will quickly learn about many topics within UMP Classic Medicare, that the rising premiums in recent years have been of immense concern to everyone. And we have some information and an option that stems from the legislative report that we want to present to you and gauge your interest in further pursuit of that potential for possible implementation in as early as next January for the 2025 plan year. Then we'll have public comment and be done with our day, but it is a full packed day. Usually our meetings are more half days, but the first one's always has a lot more to do. Just a couple of other housekeeping pieces. Usually our retreat, we don't record, but you heard us start the recording. We're just, in a hybrid world, that's just a distinction that doesn't need to be made anymore. We just want to keep the record intact, especially with the importance of some of the conversation this afternoon on that UMP Classic Medicare presentation. Second, if you need the bathrooms, they're down the hall. If you see the elevators, turn left. If we have an emergency and need to evacuate, we cross the street to the visitor parking lot that I'm going to in my back left. And then last, I just wanted to highlight for the record that Sharon is joining the board. Monica left the board. Monica left the board to become the chair of the Health Benefit Exchange. So just wanted to give you an update on where Monica went. It's always, interesting whenever we have those transitions that aren't expected between board seasons. We're happy to have Sharon here and happy to have Monica move over to the exchange board and continue health policy for the state. And with that, I will hand it back to Chair Birch.
Thank you, Dave. You and your team have really set up a nice kind of current realities, looking a little bit at our past successes. I think the board will be thrilled about too the future direction issues, and I look forward to a good day. So with that, I'd like to move us into the first topic, which is our equity and healthcare access and outcomes panel discussion. And we are gonna just have an amazing educational panel. We have our very own Dr. Heather Schultz. She is our Associate Medical Director for the Employees and Retirees Benefits Division. For those of you that can't remember, this is the new Emily Transu. And we still work with Dr. Transu as well too. Now chairing our BRE collaborative. Anyways, this panel will be a verbal discussion, and there are no materials. And I'll let Heather kick it off, and then we will add in a few others that are going to be speaking. I think that's how we're starting off, right?
Yeah, and Heather will have questions teed up for the panel, but feel free to jump in and ask follow-ups and take us in other directions, and then Heather will always have a way to bring us back.
Yes. Good morning, everyone. I'm Heather Schultz, and we have a panel of clinicians. We have 2 in the room and 1 who is online. We'll be discussing health equity as it relates to access and outcomes. And I wanted to provide a framework as a definition. So by health equity, we mean a just and fair opportunity for everyone to be healthy. And we often measure our success in doing that with outcomes for patients. But farther upstream are access issues that are huge factors that determine outcomes. So we'll start off with a more general focus on some questions just about equity and data. And then as time allows, we're going to move into specific areas, including maternal health, behavioral health, diabetes, and vaccines. Before we get started, I'm going to let each of the clinicians introduce themselves and just provide a brief background on their clinical experience and their current role. I will start off by saying my clinical background is in pediatrics. I started off initially doing primary care and then spent the bulk of my career taking care of sick kids in the hospital, primarily at Mary Bridge.
I'm Quinn Huynh. I am the Health Equity Director for the Healthcare Authority. Prior to coming here, I still am a family nurse practitioner working primarily with immigrant and refugee populations in the greater Seattle area at an FQHC. For about a decade on and off, taught at University of Washington and Seattle University School of Nursing for a bit. And I used to run the doctoral program over at Seattle University for a couple of years.
Morning, everybody. I'm Jeff Ankeny. I'm a family medicine doctor here in Olympia, Washington. I trained here in Olympia at St. Peter Hospital years ago. I'm still seeing patients on an outpatient basis as well as an inpatient basis, to include this morning. So just fair warning, I could in fact get a call and need to step out, and I do apologize because I'm on call in the hospital this morning, scheduling snap. I work for Kaiser Permanente, and I am, in addition to my clinical work, I'm the medical director for commercial business and Medicaid. And that's why I'm sitting here. Thanks for having me.
Dr. St. Clair.
Yes, hello. I'm so sorry I wasn't able to join you in person today as planned. My son is homesick, and so I'm here with him. But really a pleasure to be here today. I'm Dr. Nicole St. Clair. I had the pleasure of also meeting with this group last year. I'm the executive medical director for Regents here in Washington. My clinical background is actually in OBGYN. I'm not currently in practice, but when I was, I practiced at the then Group Health for many years and really enjoyed that time in the Seattle area and Bellevue. So currently, in my role as executive medical director, I kind of am involved really in all things that you might imagine the clinical space touches in a health plan, and certainly areas of operations, case management, and thinking about some of our clinical programs that we'll be happy to discuss today. So great to be joining you.
Thank you. As Dave mentioned, I'm going to ask a question. We'll take turns having the panelists go first to answer that question. But after they've given their answers, if you have additional questions or follow-up, please let us know. So let's start off with our first question. It's known that socioeconomics and more broadly, all social determinants of health are main drivers of inequities in access to care and care outcomes. What is being done to address social determinants of health that are impacting access to care and healthcare outcomes?
Would you like me to answer this first?
Yeah, please. Thank you.
Sorry, I can only kind of see part of the room. So please, if anyone has other questions, just kind of raise a hand. I think this is really important. We talk a lot about social determinants of health being a real significant driver in just ultimate health outcomes, and a much greater driver than the clinical care oftentimes that a person receives. So we're constantly thinking about ways to really recognize and elevate it in our work to the status of impact that it has for most people. So one of the things that we've done very specifically is to develop what's called a social risk score. And this is really just an objective way of trying to assess what someone's needs might be and their challenges and barriers within the various different categories of social determinants of health. And this social risk score is really trying to take into account measures from kind of validated tools that's looking at access to, food, housing, transportation, some of these other factors that can obviously be the barrier to getting, the visits, filling your prescriptions, or the other care that you need. And really taking sure to be very specific in trying to identify targeted actions, connecting to community resources, and providing a solution in those specific categories when we are able to recognize those challenges. The social risk score that we're able to develop is something that we calculate internally based on a variety of different inputs. And so as members call in or are interacting with care management, that information is provided in front and center to them, the same that other medical information would be when we're trying to kind of figure out what's the next step or what are the needs that we need to do to help an individual member. Another way that we're thinking about and using that social risk score, though, is as we look at our own data and our own outcomes and the experience of members and information that we're taking in, trying to look at that information in different groups of members with different types of social risk scores to make sure that we're having a good understanding of the types of experiences that our members are having across the spectrum, and figuring out where we can see areas of specific need that rise up that are related to some of these social determinants.
Thank you. Dr. Nguyen?
Sure. So I'd love to talk a little bit more about what HCA is doing. And as many of you know, HCA oversees quite a few books of business, 7 PEB being one. There's also the Medicaid side. So I'd like to talk a little bit about all sides of it. We leverage our purchasing power to build contract-specific things that are going to address social determinants of health. So on the Medicaid side, one of the things that we try to do is we tie value to payment. Our goal is to have 90% of all payments be tied to quality. And currently we're at 79%, which is a really good start. We're getting there. The other thing that we're doing with different things is that we find ways to bill for health-related social needs. We're giving guidance to plans and providers on how to bill for things like Z codes that address specific social issues, because historically we haven't been able to bill for that, right? Like we've just not been looking at that as an item that has to be taken care of, and it impacts health. But now in the last few years, we've really been focusing on that and giving guidance to plans and providers to help bill for Z codes. We also place specific financial incentives in the Medicaid health plans, like I mentioned earlier. So we hold our health plans accountable for the quality of care, and also giving guidance to our providers so that they can also tie the health care that they provide to the quality and the outcomes of our patients. So I'm gonna stop there and let my other colleague continue with this conversation, because I know we have many questions today.
Just, updating my social media. Not true. The social determinants of health, well, interesting perspective. This was some research done by the California Endowment Center about just how important social determinants of health actually is. And the CEO of that organization a few years ago came out with a quote that kind of might have shocked the industry just a little bit. His quote is that 85% of what influences health has nothing to do with access to doctors. Now, I might have, as a doctor, of course, that's more shocking maybe to me than to some people, or at least initially. Although when I was in medical school, I remember sitting there working so diligently to understand all the finer details of medicine, and a professor came in who had a public health degree, and he said, if you want to help a person, definitely become a doctor. If you want to actually help people, you need to go into public health. And it's always stuck with me. And the study that the CEO was talking about was they did an evaluation of basically 2 patients who effectively had this, we'll call them close to the same background. So similar genders, similar physical condition, similar medical conditions, that sort of thing. He took one person and put her in an environment with fresh food, good schools, low crime, bike lanes, no litter, a good neighborhood, parks, sidewalks, parks, which are encouraging physical activity, and calculated the life expectancy of that patient. It was 82 years for that person, say that person. took that same person, same physical person, and put her in an environment with a long commute or public transportation access, no fresh food, a lot of fast food restaurants, high crime and violence, and poor air quality. Those were the two distinctive, take two of the same people effectively and put them in those environments. Any guesses on the calculated life expectancy from 82 years? I'm gonna guess you all figure it's lower, but I didn't really recognize how much lower. They estimated her life expectancy to be 71 years. It's over a decade that you lose just because of having nothing to do with doctors, but only just the environment themselves, that itself. In the United States, approximately 90 cents is spent for every dollar. 90 cents is spent on social health care or social care for every dollar that is spent on healthcare. In the rest of the developed world, that's flipped. It's almost $2 per $1 spent on healthcare, the individuals of healthcare. So here I am sitting as a doctor to tell you that my work is certainly not as important as the social determinants of health that actually basically put people on a launch pad for care. So for my group at Kaiser Permanente, what is it that we're doing? Well, there's a number of things, and it's a long discussion, like Dr. Sinclair said. A couple of things that jump to mind for me is I am happy about it's about every 2 to 3 years that a community health needs assessment is done by the Kaiser Permanente organization. This is done nationally, but then I mean it's a national initiative from KP National, but then it goes down to each of the states. In 2022, this is a formalized process to identify what are the community needs assessments. And it's a more formal approach rather than just kind of figuring, well, probably need this in this community and this in these communities. And it's a rigorous stepwise approach. They came up with 6 things that are most identified as needed in the state of Washington in the community. Medical access, mental health, housing, structural racism, addressing structural racism, income and employment, and food insecurity. Good job, found some problems. A lot of us can sit there and point out what the problems are. And I speak as if it wasn't me, even though I'm part of this organization, but really I'm pleased to see that those who did this or who do this then put out an implementation strategy, the IS. And this is basically a grid saying of those 6 things, what are we gonna try to do about it? And how are we gonna best address them? That's a public document. You can find it online, and that IS has some merit. It is meant to be actionable and data-driven. And I printed it out. It's a lot of words, but it's a lot of really good approaches trying to address each of these 6 things. And I'm appreciative of the fact that we've identified formally some of those 6 things. And then continuing to track that. Continuing to track those disparities, to identify which ones are still there, which ones are being fixed. Some of those approaches are very specific to the neighborhoods. I would think that might come up as we continue to talk. But the one thing that is foremost in my mind right now, because I've just been able to get more involved with them, is at least in Thurston County, is connection to the Thurston Thrives environment, or the Thurston Thrives program through the Chamber of Commerce. And the reason I'm thinking of that is because I'm involved with that. But the broader picture here is that as healthcare delivery systems better engage with the community, actually with community organizations that are on the ground in that community, we're better able to address, first to identify what the problems are, and then to better identify how to intervene in those problems, because working with people work with the community directly. And that's probably where the disconnect has been for a long time, is that the organization is able to kind of identify what they might think the problem is, but they're not really talking with the people who talk to the people, if that makes sense. So I'll stop there for now, but those are.
I will say, listening to everyone's responses, it feels good to hear that we're moving past just admiring the problem and actually starting to think about what do we do about it, and realizing that as clinicians, we play a huge role, obviously, in the health of our patients, but It's just a piece of a much broader group of people, and we're starting to make those connections with community organizations and realizing that there's many, many factors that are impacting our patients' health outside of that exam room. Our next question is gonna dive into primary care a little bit more specifically, and there's multiple questions in this question, so feel free to refer back to your notes as needed or ask for some clarification. Challenges in access to and utilization of primary care services are general concerns that are increased in rural and minority populations. What communications and systems exist in the provider and payer communities to address these challenges? Is this more a factor of socioeconomics, cultural and or ethnic norms, geographic or other challenges? What do you believe can be done to address these factors and improve access and utilization of primary care services? This time, we'll start with you.
Sure. This question reminds me of a situation this past year when I went to Yakima to visit with some of the community members there. And when I told them about HCA and about, you know, the different health plans we work with, these community members just looked at me with a blank face, like, what are you talking about? I don't know who HCA is. I don't care about my health plans. I really don't. I just know that my clinic is down the street. It's called La Familia, and that's where I go. And those are the only people I trust. And your government, why are you here? What's going on? And we got to talking a little further, and then they finally understood the impact that HCA and health plans have on their care on the back end when they didn't realize how much of an impact that is. And we started talking about access to care, and they talked about how there's just so many barriers, whether it be language, culturally appropriate services, or transportation. These are all things that our communities, especially in underserved and rural areas, are experiencing. And then when you add things like the pandemic, it really compounds all of those issues. And you know what, isolation, these areas are already in rural, remote areas, and you add the pandemic and the more barriers to the access, there's isolation and then worsening health outcomes. So we talked through a little bit, and you know, leading back, Sue and I had this conversation a few years ago prior to me coming to HCA. And I learned that HCA during the pandemic had been providing free cell phones to a lot of our members. That helped them to be able to access some of the care that they needed without having to leave their homes. We also looked into infrastructure building that includes, you know, internet access, that included working with plans and with providers to elevate telehealth. We had to pivot very, very quickly in terms of allowing telehealth to be a tool that we can help people access healthcare. Now, prior to the pandemic, I'm sure many of us would be like, ooh, telehealth. We're gonna take it slow, we're gonna find out what that's gonna be about. But that made us pivot so quickly that we were able to elevate telehealth in a way that has been successful. Things like mobile clinics. Many organizations and community health centers are utilizing mobile clinics to reach their patients and meet their patients where they're at. And we want to support that. Interpreter service is super important. I work at a community health center where my patients speak over 80 languages, and the majority of them need interpretation services. So any given day, if I'm seeing 26 patients that day, at least 20 would have to use an interpreter. And so providing care using those interpreters to break down language barriers is super important on the HCA side. Covering for those services is super important as well. So we have to make sure that at all level of our healthcare system that we address these things and support each other in addressing breaking down those barriers. Community liaisons, community health workers also are people that are trusted in the communities. They come from those communities. They talk like the community members. They understand the needs of these communities, and we need to also elevate those community liaisons, health workers, so that they can help build a bridge between the needs of the people we serve and the very westernized model medical of care. So those are some of the things that I would say that we are trying to do at HCA, working with our partners, with communities to break down these barriers to access to care. One of the things that I'm hoping HCA move more towards, and we're working towards it, is to be able to elevate community voices, bringing them into the conversation and having them help us build the programs and policies at all levels. And we're starting to work on that. So I'm super excited to see where that's leading us. We've done that historically, but we've done it in kind of different ways. And now we're learning, we're trying to come up with a process where we can do it in a standardized way. So yeah, I'll pause there and let my other colleagues have a chance to, otherwise I'll go on all day.
I think when I hear you talking, it's the phrase that's coming to mind is one that I think every big organization that's trying to meet health needs in communities needs to have, which is, I would call it organizational humility. It's the recognition that they're just, we really can't do this alone. And we can't do this with the organization that we have only. We've got to branch out and work with organizations that can better translate the needs of that specific community where we're trying to do good work. So a lot of times you can end up with an organization filled with a whole bunch of good people, filled with well-meaning intentions that are still missing the mark. And it's recognizing that that mark can be missed no matter how much you want to not, no matter how good a job you're going to do. And those partnerships that come from that kind of humility is, I think, where the real power is. So when we're talking about expanding primary care, it's a different problem if we're talking about a rural environment versus an urban multicultural environment, and or maybe additional problems that occur in a rural environment that you don't necessarily get in the urban environment. Thinking about technology specifically, because access has really been driven, for most organizations now, Kaiser Permanente being one of them, we're trying to expand access by better utilizing technology, which has been mentioned. Is there really was a lot of technology in the works prior to when COVID hit. Nobody would make the case that COVID was a good thing for anybody, but one thing that actually was a good that came out of it was that it pushed forward the technology that was already being implemented, or was already being worked on. I remember it was overnight for me as a provider. All of a sudden, I got a message saying, actually, I saw on my schedule I had a video visit with somebody, and I didn't even know that was. I'd never done one, never been trained in one, never really had any idea what that would be. And I clicked on it, and it told me to click over here, and I clicked over here, and the next thing I knew, I was looking at my patient through the the camera, and we proceeded with a video visit. And I remember getting done with that, thinking, there's very little that is missing from that encounter compared to if I had seen this patient in my clinic, that being the physical exam, but even portions of the physical exam you can do through video visits. So that does expand access. It does allow, in particular, the need for mental health and primary care, which are two of the most acute needs especially in a rural environment. It allows somebody with some time on their schedule in the middle of Seattle to see somebody out in far eastern Washington that would never have been able to be accessible there before, both in terms of primary care, mental health, and then even specialists and subspecialists who would never get all the way out there. Historically, those people needed the resources to get in to see that specialist. So technology is helping, but then fundamentally, I think partnerships with local organizations that help us identify the needs that are actually on the ground, and then address those needs fundamentally based on what we're hearing.
So, I would really agree with both of my colleagues on the panel. What you've both said really resonates with me and what we've tried to do at Regents and how we've been thinking about this as well. We also see that access is really challenging, in part because of pent-up demand, in part because of changes in producer availability and distribution. When we look in our data, we see that most practices that we work with are having the same or more patient visits occurring but they're still having a harder time even kind of getting all of the kind of routine screenings done and just some of the things that we expect to see, associated with that volume of visits, really just reflecting an ongoing pent-up demand that's just further challenging access and isn't really slowing down in terms of just, 1 year after COVID and things are back to normal. So thinking about how we can both expand the availability of providers and make sure that our members are actually getting to those providers, I think are two different things. Certainly trying to make sure that we're doing everything we can to be supportive of providers in more challenging areas, rural areas, independent practices, and thinking about ways that we can use our contracting is what was mentioned, and alternative payment models that really reward value and high quality to kind of supporting those practices in some of those locations, as well as was mentioned before, working with community-based organizations to make sure that we're thinking about some of the barriers and the needs in the community that are preventing folks from getting to the care that may be available. And then also thinking about ways that we can expand when there maybe aren't providers. And as has been mentioned before, a lot of that comes in virtual care. We've significantly expanded the number of providers in our virtual networks, as well as have tried to be very creative and flexible in just the types of the care that's coming in, certainly thinking about primary care, but wanting to make sure that we're having diversity and providers that members will feel comfortable with. And then to that end, we also see that there sometimes is just a mismatch of members who may be seeking care and having a hard time finding care that really resonates with them, providers that they feel comfortable with, care that feels socially or culturally appropriate to their situation. So one of the things that we've also done around that is really trying to enhance the way that we put together our provider search tools and the information that our customer service and care management has available when trying to help members find care. We've added a variety of different features, as well as have gathered demographic data about providers around their race, ethnicity, language, sexual orientation, gender identity, and areas of specialty care acumen, so that when you come on to like the app or the website and you're trying to find a primary care provider, you can add some of these additional filters to have a better chance of finding the provider that's really going to fit with you. And that may be a virtual provider, again, as we've expanded our network, just to try to have more variety in what's available. But I do think that over time, we're going to continue to have to be really flexible and innovative in this space, because the provider community itself is not growing and sustaining at a rate that's large enough for the need of our entire community. And that's much worse and much more greatly felt in smaller and more rural areas. It's just an area of continued focus and for us here at Regents.
And I also add to what Dr. Claire had just mentioned, and I want to talk a little bit about workforce. Prior to coming to HCI, I spent nearly a decade of my time really focusing on workforce, specifically creating training programs for nurse practitioners, physician assistants, and physicians to ensure that we build a healthy pipeline of workforce. Now, we can talk about infrastructure all day. We can talk about all of the tools that we can provide to help providers and patients have better access to each other. But if we don't have the strong workforce, we're not going to be able to deliver that care no matter what. And so one of the things that I think is super important, super crucial to this, all of this, is to invest in educating the next generation of providers who can provide linguistically, culturally appropriate, and socially, economically responsible care to all of our patients. Studies have shown over and over again that if a provider or a healthcare worker comes from the communities, are trained in the communities, they're more likely to stay in those communities. You're going to see in rural areas and underserved urban areas where there's large diversities, where there's more social, economically challenged folks, that the providers that take care of those patients tend to have certain challenges that other providers may not be in different communities. And therefore, their rate of burnout is much higher than your average provider in other communities. So how do we ensure that these healthcare workers are armed with the proper tools to help them take care of these patient populations in a way that's meaningful? We have to look at training. We have to look at supporting them. We have to look at providing and really building that workforce, that pipeline. And if that means that we have to go all the way back to middle school and high school to start advertising, I mean, talking about, hey, in Yakima, we have a huge healthcare, and I bring up Yakima, but there are many other areas in Washington state. There's a huge healthcare workforce shortage crisis. So what do? We have to go to those communities and say, let us help you build it. You tell us what you need, and you will be part of this building process. So it's a grassroots approach. I think that is the only way, or one of the best ways for us to really make sure that we decrease this barrier to access to care. That is to provide the supply that is in high demand.
You make me think of the idea that access to care is a phrase that is not precisely defined. And so it's something that it bears thinking about what does that actually mean? Access to care, I think in my mind means, there's not enough of whatever resource there is, there's not enough there. And that is one component of lack of access to care, but it's not the only one. So there are cultural barriers and language barriers that also create a lack of access to care. And these are questions that need to be better addressed, right? And to not just presume that if we do have enough people on site, in other words, we've got full FTE hired up in that clinic, well, then there's access to care, right? That doesn't necessarily mean there's access to care. So one fun thing that I was learning about was at Kaiser Permanente is culturally competent care training that occurs with the providers that are on site there, and the cultural team and the teams there, recognizing cultural competence and getting actual thorough training in that kind of thing. It used to be that it might have been a class online, but that's not how it works anymore. It's a long-standing, time-dedicated process that goes over the course of months for the providers. In particular, I know that because I've been through it, and it's rigorous, challenging. We're working with our recruiting teams to balance the languages and racial and ethnic backgrounds of the communities where we serve, and to put providers and teams actually hired into those positions, basically targeting language concordance and background concordance, getting back to what you said, that if people come from that community, or if they are fluent in the language of that community, it's more likely that that community will better respond to the care that's being provided. When we get back to what we talked about at the beginning, that clinical care is a small component of what healthcare really is. So all of those things I do think are contributing more so to addressing primary care needs in the community.
I just want to pick up the breadcrumb that you just dropped, because Andrea later this morning is going to try to define access to care. So I just wanted to say it's funny the way you describe that, because we will have some conversation and information for the board trying to give a technical definition of that phrase. So
I was a plan.
it's almost like you were here last week.
Perhaps.
For those of you, we had our sub-board meeting this time last week.
It sounds like we are starting to get more creative in the way that we think about solutions, right? Whether we're talking about using things like telehealth, or actually just starting to talk to our patients and figure out what they need instead of having that top-down, what's best for you. And then knowing that we don't have a workforce that's large enough to meet all the needs, and thinking about how else do we tap into different resources, whether it's community health workers or other community-based organizations. We know that clinicians can't do it all. So how else can we start thinking about things outside of that exam room? It sounds like at every level, whether at the state level or at the health plan level, folks are really starting to think outside of the box about how to do that. Our next question is going to focus in on reproductive health. I'm going to have Dr. St. Clair start. She is our subject matter expert as a OBGYN. Disparities in reproductive health in the areas of contraception access and abortion access suggest a multitude of factors need addressing, including social determinants of health, racism, residential segregation, culture, and socialization, for example. How are these being considered in care management, patient education, and clinical settings?
Well, that's a great question, and that's an interesting question because we spend a lot of time, recently, or it's certainly in my realm, talking about maternal health, and really also need to talk about reproductive health access as another, topic that's really bubbled up and not to be forgotten. I think this is always kind of top of mind, for us as well, recognizing some additional challenges, operating plans, not only in Washington, but in 4 states. And within our 4-state footprint, we have 2 states that are legislatively pretty, progressive and liberal around topics of contraception access, abortion access, and 2 states that are extremely conservative and restrictive. And so even thinking about how that comes into play in our operations to ensure that we are supporting everyone's needs, and not, and having practices that would still continue to provide access where appropriate and needed, and in a fair way is definitely a challenge, and something that, we just kind of constantly are adjusting around. I do think specific to care management, education is a really key role, especially for us, making sure that our care managers understand from the beginning, what resources are available. As I mentioned before, certainly any kind of regulatory issues, and understanding that these are really difficult and challenging discussions. We've talked about ways that we can even improve and optimize our ability to even have these really difficult conversations with members who are calling in, oftentimes, in a time of specific pressure. In terms of just operationally, as a plan, we certainly are mindful to not have any measures in place that would impede anyone's access to the full spectrum of reproductive health care. And so, I think that has become a little bit less of a challenge, again, than some other aspects of maternal health. I'll pause there, it just, to kind of give others a chance to weigh in as well. But this is indeed a tricky topic.
Dr. St. Clair, I'd love it if this impressed you, but it probably won't. When I was in family medicine residency here at St. Pete's, I delivered 98 babies. Very proud of myself at the time. But the reason I mention that is because what I found to be one of the most challenging things about that care process was the prenatal care, because it's a very persistent timeline up into the point of delivery. And so when I'm thinking about maternal outcomes, maternal care, what I'm really thinking about is prenatal care. I think that's where a lot of the power comes from in delivering good maternal outcomes medically. There's data to support that. And the reason I bring up how difficult it was is because I feel like in looking back, it kept me up at night, and I remember to do these certain tests at these certain times, that I remember to check on these certain things at these certain weeks of gestation for all of these different patients, and it was stressful. And what I could have used was better institutional or organizational support, so that it was a little bit easier to make sure that those things just occurred functionally. Back then we had paper charts, and so there was little check boxes that you had to make sure you put in there. So a lot of that was based on the providers just remembering to do it all. These days, that focus has been, there is a lot of institutional support. Kaiser Permanente, that's one of the big, that's where the focus really is on prenatal care. I just read a statistic recently that prenatal care in Kaiser is in the top 5% nationally, according to HEDIS measures for the different checkpoints that need to happen in the prenatal care environment. And I'll tell you just one quick story. I had part of my medical training occurred in Israel, of all places, because I was very interested in cross-cultural and international health. And that's what this program focused on. And my wife and I had 2 children in the Israeli medical system at the time, and at Soroka Medical Center with the third highest birth rate in the world. So we were seeing a very, very smooth, highly oiled machine, we'll call it. And one thing that was available to us by the state of Israel was something called tipat halav, which means drop of milk. And what it was prenatal care that was totally free. And it didn't matter what you looked like, where you came from, who you were. We were Americans that couldn't even speak the language that had access to all the prenatal care all the way until the delivery. And we never got billed, we never got charged. It was absolutely taken care of. And I think that's because care systems around the world recognize that prenatal care is where outcomes in maternal outcomes are best managed and taken care of. And we got really good care as a result of that. So the better we can focus on prenatal care in our systems and in our state and in our communities, I think the better outcomes we're going to see.
You know, something you said just reminded me. Thank you. Also, as you were talking about, you know, kind of prenatal, peripartum, you know, even thinking about postpartum care is what led me to this. You know, thinking about even just kind of access to reproductive health and family planning, contraception, and those types of issues. There is this subset of the captive audience who did just have a baby. So, you know, there's certainly the cohort who that's not in their plan, but the opportunity to then provide education and family planning about thinking about the timing of, you know, a next pregnancy, if that's the plan, you know, that postpartum time period and that postpartum visit, that's one of the key, you know, topics of discussion in that window. And where we see a significant disparity may have to do with access to care after your 6 weeks postpartum, depending on your insurance type. And expanding postpartum care and the time window for postpartum care can go a long way to bringing at least some increased equity in access to that care. Because oftentimes what I remember thinking when you were saying about training, thinking back to when we were residents, you know, and I trained in Oregon. So many of my patients had, you know, their care through the Oregon Health Plan. Either way, though, there was still a window of time where if you didn't catch that, you know, catch that woman before her 6 week time period, and maybe she lost her benefits, then your ability to even just enact a plan that you previously made that perhaps involved, you know, getting an implant or, you know, getting a prescription or something that would provide some long-term family planning, you know, they kind of drop off, and your ability to interact with them as well as their ability to have that same coverage for pharmacy becomes challenged. And certainly there are community resources in other places that one can go. But I think that thinking about more specifically that postpartum time period in this regard for reproductive health access is just one reason why there's a lot that could be done in that postpartum time period.
I'll add to what my colleagues have already said. I want to talk about 2 things: racism and trust when it comes to women's health, reproductive health. So this is 14 years ago, my first year of practice as a brand new family practice NP in the community health center in Seattle. I got a code blue on the intercom, and I grabbed the nurses and I said, "Bring the crash card." And we started running down to the parking lot. And I saw this woman just kind of leaning over like this, and she had a doll in her arm, kind of looking like a doll. And then there's this man standing over her with his jacket, trying to cover them like this because it was raining. Because guess what? It's Seattle. It rains all the time, apparently. And then the doll started moving, and this woman had this horrified look on her face. And I was like, "Oh shit, that's not a doll. That's a baby." And so I ran over and I tried to help them and pull the wheelchair, and they all sat down, and we pulled them up to the second floor where our clinic was, and, you know, realized that she had given birth in the parking lot, or at least partially out. So we helped deliver everything and deliver the placenta. And I don't do OB, I don't deliver babies, but the other docs in the clinic did, but I was part of the team that took care of baby and, you know, did all of that. But anyways, we asked the parents, said, why didn't you go to the hospital? On the phone, we told you to go to the hospital, and they said, we don't want to. We want to come here because you understand us. You've taken care of us. You know what we're going through. The hospital doesn't. And we're like, but the hospital has all the right equipment. And anyways, long story short, we're like, okay, we'll take care of you. Finally, we got them to the hospital, got everything taken care of. Mother and baby were happy. They came back and we, you know, continued to care for them for another decade. But that is to say that these families are willing to go to the clinics where they know there's not enough resources to deliver this baby as safely as in the hospitals because they trusted us. Now, you remember the story of Serena Williams, this awesome tennis player. I don't play tennis. I just know the Williams are really awesome. So when I heard about her story of really harrowing childbirth experience, I looked a little bit more into it and I had to question, you know, once you've adjusted for income and wealth and education and all of that, somebody like Serena Williams was still having negative outcomes, bad outcomes in perinatal care. So studies have shown that Black women are 3 to 4 times more likely to have bad health outcome, or that they are more likely 3 to 4 times more likely to experience maternal mortality than white women or white birthing people. So what is it about this that is causing these bad outcomes? It's a lot of it is racism. We have to name it. We have to be willing to say there's racism here. There are issues here. There are discriminations here. Until we can name the problem, if we dress it up with all of the other issues like, oh, you know, it was this, it was that, we're never going to get to the root of the problem. So even when you've adjusted for income, for wealth, for education, all of that, Black women are still more likely to experience these horrible outcomes. So we have to address the racism. And then the trust, we have to be able to build the trust. One of the things that HCA is doing, this past year, HCA was able to work with legislation and got a bill passed on allowing us to cover for doula services, which is fantastic because many of the communities that we serve, especially like we mentioned, rural and underserved populations, they come from different backgrounds and they need to have people who understand them in order to really bridge that gap between their healthcare needs and what we as the westernized medical culture provide. And so doula services have shown in multiple studies to really provide safe care and really elevate the care in a way that can decrease negative outcomes. So we're really proud to say that we're working on that at HCA. I'm looking forward to working more with community members and with community-based organizations to ensure that we meet the people who are giving birth, we meet where they are at, and to provide culturally, again, I keep saying this all day, you hear me say it all day, culturally, linguistically appropriate care to all of our patients.
So that contraception and reproductive health question clearly led us into a maternal health discussion as well, which makes sense. It's all a continuum. I have some additional maternal outcome questions that I want to ask. I'm going to kind of skip over our last general question. Some of these questions, answers have been provided by the panelists already, but if there's deeper dive that anyone wants to do on these topics, I'm gonna just kind of run through the several questions that I've got. Why do variations in preventable, avoidable maternal outcomes exist? Let's go to that already. Which are most concerning? What barriers exist that impede improvements in preventable, avoidable maternal outcomes in Washington State? What role does health literacy play in this area, and what's being done to address this factor and its impact on patient outcomes? Dr. St. Clair, did you want to start us off?
Yeah, sure. Yes, because this is very near and dear to my heart, right? But also too, because I think the maternal health outcomes disparity is really significant and really stands alone. When we talk a lot about a variety of different, you know, kind of racial or ethnic health outcome disparities, but really maternal health outcomes are kind of uniquely and specifically different. As Quinn said, when there have been enough studies now in the last, I would say 5 years, that I think there's kind of universal agreement that these disparities exist very consistently. But what's interesting is when they've taken studies where they've adjusted for income, for education, for type of benefit, for where you live, all of the factors that usually will drive some disparate outcomes, they can adjust for all of that and really compare completely like to like patients and still see that Black women will have this 3 to 4 times higher risk of, morbidity and mortality than their white counterparts. And that is really significant and remarkable. There have been studies done in the military system looking at on-base families that are going to the exact same providers with the exact same health benefits, the same jobs and resources, and they still also have the same disparate outcomes. So I think that there's really something significant about how consistent that is and how resistant and significant and poor those outcomes are. When you kind of dig into the weeds of what seems to be driving it, we oftentimes see that there is a delayed or missed significant diagnosis, oftentimes in the realm of cardiovascular diagnoses like hypertension, preeclampsia, and pregnancy. I think most people are familiar with that. But it's interesting that you would think there'd be different problems, not that we would say this is a high risk group. This is a group that has a disproportionately higher rate of hypertension, yet somehow that diagnosis continues to be missed or delayed. When you kind of get even more in the weeds and you look at like the Serena Williams story, you start to see themes of communication breakdown, which isn't really surprising because we know that for so many of our kind of where it all breaks down, when we think about, as Quinn was saying, culturally and linguistically appropriate care, it's communication. So I think that there's really a need to focus and look at how are we miscommunicating so significantly? How can someone like Serena Williams, who has a really known medical history, even to the public, to me as not her OBGYN, like I know her medical history, this woman had a blood clot in pregnancy, or a blood clot outside of pregnancy, which is super high risk, and then became pregnant and is even higher risk for having a blood clot during her pregnancy. And as she's voicing concerns about, at the hospital, I'm having the same symptoms that I had when I had my previous blood clot, she tells the story of being dismissed, pleasantly dismissed by her nurse, not rudely, but, oh, no, you're fine. Things are fine, which is bizarre because I think to any medical person, you'd say, well, hey, that woman sounds like she has a blood clot. So again, what is it in the nuance of that? How can we kind of get to the root of why the bedside nurse, who presumably was very well intending and knowledgeable of this person's health background, is still somehow not connecting the dots of I need to kind of escalate, I need to call this doctor. And it was only because of Serena Williams' knowledge and her fame and resources that she was able to call the doctor herself and kind of, drive her care. So I think that really sticks with me in terms of how we're approaching solutions, looking at specifically what are some ways that we can not only address these communication breakdowns, but have additional resources, which may be a doula, maybe another, kind of perinatal community health worker who can recognize when this problem is happening and help move this to the solution, help bridge that gap, bring in that communication, provide that advocacy or whatever's needed to help kind of move that needle. So that's an area of significant focus. I know I'm kind of talking long, so I'm going to wrap up. But the second area that is really important to me is also adding some accountability, I think, for all of us to outcomes. To your point, Dr. Schultz, I think we've moved past just observing the problem or confirming that it exists and really needing to take specific action and measure the results of our actions and make adjustments. So we've done a ton of work internally around maternal health equity in different work streams, taking a deep dive into ways that we can enhance and improve the postpartum care experience, since half of, the bad outcomes happen after, more than a week after delivery. We're also looking at ways that our care managers can be particularly attuned to these issues and keep this front of mind as they're going through their, interactions for high-risk pregnancy management, and even just kind of the materials that we have available. And then working to develop some alternative payment models for the provider community to bring awareness to any internal disparities one might have in their practice and reward the work that it takes to closing those. So I know I've probably gone over my time, so I'll stop.
There was something that this just reminded me of. And I think you said it last week. I don't think you said it today, so maybe you can reinforce it, because I will do a woefully inadequate job. But it was the concept of over the course of your career, a shift from doctors know best to that balance between patients know themselves and can help advocate or share. We all know our own body, so to speak, and how that had much more of a prominent role at this point in your career than it did in earlier stages of your career.
Yeah, I think what I had commented on last week is that in listening to the discussion, it was heartening to me to hear that we are really starting to think about listening to the patients and starting with them as the focus. It may seem surprising to folks, but that has not always been the case in healthcare. We, as clinicians, we're often trained as we are the experts, we know best, and we will tell you what you need. And that is clearly, now that we are looking at outcomes, it's inadequate. And so it is heartening for me to hear that we've got to go back to thinking about how do we build trust with our patients? How do we listen to them? And they will tell us what they need. And then we can use our expertise to provide that for them.
Thank you. That's exactly what I was remembering.
Makes me think of another story. I did relief work in Athens, Greece during, there was a big migration during the Syrian war. And I happened to be living in Europe at the time. And so I was working with mostly Afghan refugees that had just made it through Turkey and across the GNC, and they had just poured them, so they were all pouring into Athens, and I was doing a relief medical clinic there. And I remember after a couple of days that, I was very trained in the shared decision-making model of healthcare delivery. Well, let's talk about this, see what, you would like from this encounter. And I was told by the person leading the clinic, she said, she kind of pulled me aside and she said, the patients say that you're not a very good doctor. I was like, ouch. Like, okay, good to hear. Thank you for that. That feels so good. And I said, why? What should I change? What should I do? I'm just trying to help. And she said, well, they say you don't know what you're doing. And I said, but I mean, I do. I think I do. And they said, well, she said, one patient in particular said, when I walked into the door, and this is a traditional Afghan woman who just came from Afghanistan, traditional village in Afghanistan, she said, what I expect from my doctor is when I open the door before I even sit down, he knows exactly what's wrong with me and tells me what I need to do. And that's totally different from anything I know about practicing medicine. Everything about that makes me. And it was a perfect example of just a clash of cultures. It's not that what she believed was the right way to receive care was necessarily wrong. And it wasn't necessarily that what I was providing was bad care. It's that the two cultures were not meshing well. And it gets back to exactly what you said, Dr. Schultz, which is listening to your patients and figuring out what they need. This gets back to what I'm talking about, like the HCA's efforts to collaborate with community organizations that are on the ground in those communities. That's the essence on a public health level of listening to that community, listening to those patients, so that when you talk to somebody from, say, Elevate Health, they can tell me when you're working in Pierce County, particularly among these communities, this is what is expected for trust to be engendered between you as providers and the people that you purport to help. And so the trust component is so important, and it is fundamentally driven by listening. And I was able to raise my scores a little bit during the course of my time in this clinic, partly because I was listening and I was able to recognize that asking a traditional person who's just made it out of Afghanistan, what would you like to do? How do you feel about treating your blood pressure? Isn't the right approach in that particular environment, but in other environments, it's foundational to actually creating that trust between the patient and the provider. And then the flip side is, or the other side, I think, of a continental divide of these disparities. And on that other side is what you mentioned, which is the racism component. In the community needs assessment that Kaiser Permanente did in 2022, They flat out just named it. There's structural racism involved in the systems. And what that allows for is it's named, it's claimed now. So we can talk about it, we can try to address it. So the training system, the training programs that they've put in place are a lot more robust. The equity, inclusion, diversity programs that are in place have actual teeth, we'll call it. And we are looking at outcomes as a result of those trainings, and the depth of those trainings is much more than just a cursory approach. And it's, I think all of that starts with the idea that this really is an issue. We just need to call it what it is. We need to claim it. There are groups of people who flat out will say, there's certain people and people types that I don't like, or I don't care about. There's a much larger group of people, particularly in the helping and caring professions like medicine, who would say, I'm not racist at all. I have no biases. And that's a more insidious group to work with, because the fact is there are blind spots and there are racial tendencies. We see it in the data, like you've said. And so it's like, okay, so you're well-meaning. We're not accusing you individually, but we are talking about an institution that has racist components that have to be addressed. And so addressing that, putting it out there, actually naming it, claiming it, and then addressing it is I think where it works on the racism side. Listening as carefully as we can helps on the trust side. And between those two, you do see decreases in those disparities we're talking about.
I'd like to expand on that a little bit. One of the questions you asked is about health literacy and whether it plays a role in negative maternal health outcomes, and what are we doing to mitigate that? I have a question to that question. I would have to say, what is health literacy? Who's health literacy? Because humans have given birth for as long as we've been alive, as long as we've been in existence. And so the way we look at health literacy now is just the one way that we were trained in this westernized culture of medicine. So when we take care of patients from different cultures or different backgrounds, and we're like, oh, they don't have the health literacy necessary to understand how to take care of their health and their babies. Well, actually, is that true, or is it because we are only literate in one way of doing healthcare and maternal health? So I would say that one of the things that when I do a lot of training for residents, both medical NPs and NPAs as well, you have to talk about, that cultural humility and the ability to think beyond our own lens of what health literacy is, and imposing our own views onto others when our views may not necessarily be the best views. So I think it's really important to ask ourselves those questions. So it's not really an answer to your question. I think that the situation here is not that our patients who may not understand our literacy, a definition of literacy is, the issue. The issue is that there is a disconnect in where we see healthcare is, what it is, and how literate we can be to provide appropriate care and to make sure that we have good health outcomes. Something to think.
I agree. I heard in these responses this theme of, like, again, expanding the way we think about things, right? So acknowledging, first of all, that racism is impacting health outcomes, and that we are expanding our definition of what that means. It doesn't mean that individual providers or clinicians are setting out in their work each day to do racist things, but that it's deeply baked in to our culture in ways that it causes poor outcomes without us intentionally trying to do that, and expanding the definition of what it means to be literate about your healthcare, right? Not, again, coming from that top down, doctors know best, and just being a little bit more humble. I've heard that word mentioned several times during this discussion. That is heartening as well. We are coming up on our time, so I'm gonna switch gears and focus in for our last question on diabetes. Before my question, there's a little bit of background just to provide some context. There are significant variances in both the rate of diagnosis and complication of diabetes in minority populations. For example, 7.6% of non-Hispanic whites, 12.8% of Hispanics, 13.2% of non-Hispanic Blacks, and 15.9% of American Indian Alaskan Natives are diagnosed with diabetes. Compared to non-Hispanic white adults, the risk of diagnosed diabetes is 77% higher in non-Hispanic Blacks. After being diagnosed, non-Hispanic Blacks are 4 times more likely to undergo complications such as lower limb amputation and end-stage renal disease compared to non-Hispanic whites. What efforts are being made to address racial disparities in diabetes prevalence? And I would expand that to say, if you have any comments on interventions that are being done, that would be welcome. Dr.
Real quick, just wanted to note that board member Tom McRobert joined just a few moments ago.
Thank you. Dr. Ankeny, did you want to start us off with that one?
Well, in a sense, we're talking about the same problem. We have disparate outcomes in maternal health. We have disparate outcomes in mental health, disparate outcomes in general primary care. In looking at diabetes specifically, sometimes there's more culturally specific things that can be identified and more granular, detailed things like addressing, for example, what is a normal glomerular filtration rate? That's a measure of kidney function, and it has been for my entire career that there is one rate that is considered normal for everybody else, and there's another rate that is actually less stringent for African Americans. And I just want to talk about institutional racism. I just walked into that and thought, okay, well, somebody a lot smarter than me figured that out. It must be that that's true. And it took some real thought to actually say, well, is it? I mean, is it true? Because now we're having poorer outcomes. We're being less stringent about people's renal function, which is absolutely and totally influenced by A1C levels, blood sugar, average blood sugar levels. And we've taken a better and a closer look at that and brought that more in line so that there's a more stringent approach to that. So that would be a specific thing. Another one just came from that I learned about, and I know we're out of time. I don't want to go too long, but the idea that there was higher A1C within a community in Tacoma than everybody else around them in that community, we found with better questions, deeper questions, that it was a very homogenous, racially homogenous community of Hispanic people. And digging further in, using people who spoke Spanish well to actually look into it, there was a woman who was highly respected in that community who had received a prior authorization for her medicine. And as a result, she just lost faith in the whole system. And she was so influential in that community that the whole community followed suit. And there was a noticeable and sizable drop in, or a rise in A1C just as a result of that one thing. And it is not on the radar that prior authorization leads to poor health outcomes. And it's certainly not on the radar that prior auth would lead to poor outcomes among certain racial or ethnic or certain groups. And that came to light by asking questions more deeply, and was in that particular case was able to be rectified.
Well,
You know, oh, I'm sorry.
No, go ahead, and then we'll move to questions.
So I was just going to add, I do think, you know, what you hit on, Dr. Ankeny, with diabetes, there's so much that comes into social determinants of health, because diabetes is just like the highest maintenance condition to have and requires such a huge change for most people in their diet, activity, and just almost daily lifestyle. And I think the same way that we talk about how there are these racist barriers that are kind of built into the systems, the more steps that are involved to a disease management, the more opportunities, I think, for those barriers to accumulate. And we start to see them in these really tricky conditions like diabetes. You know, I think this is an area where there can probably be more opportunity for education because there could be, as you were mentioning, some kind of collectively held misperceptions, biases, or habits that can be counter to what you're trying to do with diabetes management. But then oftentimes the tools that we bring in to try to help may be ineffective. And I think a lot about, the number one tool that we go to when someone has a new diagnosis of diabetes is to send them to a nutritionist to talk about ways that they can modify their diet. But then, what we find there's not enough diversity and kind of breadth of perspective in what's presented oftentimes by a nutritionist. And so, one person may go in, with a very traditional, insert anything here, Pakistani diet. And then what the advice they're receiving from the nutritionist is really just based on a very kind of plain Western diet that has no correlation to what they're actually doing. So then I think patients are left with a solution that just feels kind of out of left field or doesn't resonate, and then nothing really in between. So I definitely think that for these conditions, there really are opportunity. That's where we all need all the help we can get, there are a variety of kind of community-based organizations that focus on just helping people get more active, places that are offering, healthy cooking classes. I think all of those nuggets in the community, but from the healthcare, delivery side, I definitely think we have to just be more thoughtful and mindful about this in particular as an area of where we have to bring in kind of cultural sensitivity and awareness.
Thank you for that. Heather, thank you to you and the panel. I think I'd like to see what questions or comments board members have. And I think I'll just frame this a little bit from my own perspective of hearing the very rich information you're bringing forward. I mean, clearly COVID was a pivotal point where people really started getting it that, wow, these social determinant issues and these inequities are really impacting all of us. And I want to just encourage the board, reflecting on their comments and your questions and comments putting forward. We have this opportunity once a year to get a little more educated and help staff, give staff direction about what policies or where are we going to go with this. And I remind you, and I want to thank the staff. I know Quinn has been really instrumental in pulling all parts of HCA together to lead more on this equity evolution, this journey we're on, helping with internal training, externally setting a lot of a leadership course with all of our partners as well. We have quite a movement here on person-centeredness, as you referred to earlier, really listening to understand people, not listening just to respond to I'm the doctor, nurse, I know best. So we have a movement, human-centered design, person-centeredness, new consumerism, call it what you want. We have that kind of moving now after post-COVID. Clearly, the cost board and all of you have been very thoughtful and persistent about affordability, because you will hear from a presenter in April through the cost board. Noam Levy is coming to Washington to speak about medical debt and how we actually, by providing health insurance, are now becoming a social determinant of health. 105 million Americans, those of us with health insurance, carry medical debt. That is staggering. So if we don't continue to put downward pressure on premiums and affordability, we're just worsening the problem. And for those of you that might be thinking too, well, this issue might be more of that Medicaid issue than our issue. We have quite a few crossover clients that are on Medicaid and or the CHIP Health Insurance Program, or our seniors that are on Medicare plans that can't afford as things keep outpacing. So this is our issue. It is our time to keep kind of minding this group. And I guess my first question is to you all. If you were on this board, what sort of actionable things beyond some of the lab values, beyond beating down more waste? There's some new information showing right now that those of us with insurance are getting over-tested, over-diagnosed, and unnecessary things. What would you encourage this board to think about as putting in for next steps on this journey in equity? What definitive actions, besides a policy statement, We have doulas in our benefit package. What more could this board be encouraging staff to look into in the years to come on this equity pursuit?
I can start. One of the things that we're doing on the equity front at HCA is looking at identifying specific equity infrastructure that we can build into our policies and programs. So in the next couple of years, we're working towards looking at the contract terms with our health plans and looking at how our health plan is delivering equitable care or creating an infrastructure in which they make it more easy for them and for the providers and other subcontractors to provide equitable care. So that is coming. We don't have all of the details that I can share yet today, but that's just, as a heads up to you that we will be reaching out, we'll be sharing some of that information in the next few months, going into the next few years to hold ourselves, all of us, accountable for this.
So that would play out through things like Dave's and where is your team? They're back there around contracting. How would we build that into contracts or create performance incentives? Okay, that's one very specific thing this board could delve deeper into in coming years with staff. What else? What else from you guys?
I would throw out that if board members could get out the word to all of the various different employer groups, how important it is to gain that trust from the members to share their race, ethnicity, language, SOGI data with us so that we can actually measure these things. That is another barrier that still exists, is that sometimes there isn't that trust for people to share that information because they don't know why it's being used or what's going to happen next with that. So just making it more widespread and understood. We are trying to gather this information so that we can provide equitable outcomes for everybody, not to use that information for ill.
Great one, because we know we have some real informatics and data challenges about how we get real, accurate, appropriate kinds of data.
Quick acronym, SOGI is sexual orientation and gender identity, for those who aren't aware.
Yeah,
I do that.
I'm curious if you have thoughts about that ratio. I too have heard that, and I've brought it to this board's attention many times, this notion of we're spending in the wrong categories. We're spending too much on the medical side of the care and not on social. Should this board start thinking about, how do we in the future years, how do we measure that, or how do we start flipping that to make sure our members, especially those that are not in a livable wage category, and Michaela, I'm not gonna, I like to think all state employees are in livable wage categories, but they're not. And how do you want to comment on that, or you got any ideas about how we could? You guys are front runners in the country with what we do on this issue. Is there something that we should be building in about livable wage households and better understanding?
Just so you know that.
And then Elliot, you're next, but Michaela, or Jeff, you want to respond? Do you have any thoughts about that?
Yeah, I'll fix it.
With
right
KP?
here.
Fix that with KP,
Yeah.
please.
What comes to mind is I was sitting in a Thurston Thrives meeting just yesterday, working on a pilot program to unite 8 different community organizations under one umbrella using technology that allows them to have internal referencing to each other and referrals to each other. So they're actually communicating in a way that they never did before. And what comes to mind is that there are a whole bunch of really, really heartfelt approaches, well-meaning people out there that are trying to fix these things, and they're siloed, much more so than they want to be. And so I would say for the board, be aware of the resources that you do have available. We are using, like Dr. St. Clair said, we need all the help we can get. It's true in the medical system, but we also have a lot of help out there, but nobody's really talking. So, or they're talking, but a lot of times it's just, again, well-meaning, but there's just not a lot of integration. So the better you are aware of the community resources that are available to you, the better you can direct your members, especially as they're trying to understand how best to access Kaiser Permanente health, for example.
So you're going to hear board members later today about some of the modernizations that Dave and his team have been doing around eligibility and enrollment. We're also very proud in Washington. We are going to be the first state in the country to close the loop on an electronic health record as a service for the state, but you're referring also to a community information exchange system. which was approved in our federal waiver, so that'll be coming back to us, but again, data and closed loop referrals and, use of, yeah, we're a long ways away from digitizing our community resources, and that'll help us not over medicalize where we're paying the very expensive medical system to do these things, but to have more resources shift towards food banks and the community entities. That's a great suggestion, John. And then
Yeah, I'd like
Elliot's
to,
next.
sorry,
Sorry.
Ellis next.
Actually, it's Michaela
Okay, sorry.
and then Elliot and then John. Go ahead.
Okay, and so this is mainly for Dr. Anthony and sorry, I'm running names, Nicole St. Clair, Dr. St. Clair. Regarding kind of the idea of culturally relevant care and providing kind of more access to people, like I love the idea of what you all are doing and acknowledging that racism is existing in the system. And like my background is in HR. So like I can say that, through experience, you cannot train your way out of bias and racism, especially when you're dealing with people who don't want to learn and who don't think you're part of the problem. Like you were saying earlier, that middle group is kind of the insidious group who think like, I'm not racist or I'm not part of the problem. So what are you all doing at a systems level within both of your insurance groups to kind of have systems of accountability? And I specifically think about, when you brought up the Serena Williams example, that idea of people from marginalized communities are not going to speak up or not going to be heard because their adverse experience is that idea of I wasn't heard in the moment. So how am I going to be heard if I go explain that there was a problem later on? And so it's not just putting in kind of the system of we'll hear you like a suggestion box type of thing, but accounting for the fact that you have to overcome the fact that many people from that community are feeling like they're not going to be heard in general.
My answer to that would be one word, which is outcomes. We are tracking outcomes. And again, it's not an answer, but I'm saying that the one that comes to mind is we need to look at outcomes. So people can say whatever they want. I'm not racist. I am racist. I don't care. I do care. The words are actually a lot less important than the outcome and the data that we get. And this seems like, wow, we're only able to do this now, but it really is only recently that we've developed the capability, at least at Kaiser Permanente, to drill down. We can now track the data through a database that we can narrow it down to a city, we can narrow it down to a community, we can narrow it down to an individual clinic, and as uncomfortable as this makes all of us providers feel, we can narrow it down to individual providers. So we can go and find any provider who has a disproportionately high number of A1Cs on their patient panel. And the approach so far, and I would continue to support it, is one that it's not a fault finding type of approach, because then you end up with defensive providers and defensive clinics. Defensiveness, which often doesn't lead to solutions. It is more about, we've noticed this, we found this, and let's problem solve about what that might be. So that would be my thought on
Well, I pose the question of like, when I hear outcomes, like my immediate reaction is, do I or my child have to die before we start to recognize that the outcome is too late?
Well, no, certainly, I mean, of course, ideally not, right? And by outcomes, what I'm talking about is the measurements of things that we, here would be something that could easily slip through, is slightly elevated blood pressure. We'll say 20% higher blood pressures at the Steel Street Clinic compared to the Capitol Hill Clinic at Kaiser Permanente, right? It's 20% higher. I mean, did anybody notice that? Well, they would eventually, right? By poor outcomes, by death, right? But that's a long-standing problem. So if the outcomes are being measured regularly, particularly the primary preventive outcomes, those outcomes can also be described as outcomes. So it's not a definitive final outcome. It's a preemptory outcome, recognizing you guys are 20% higher in this clinic. What's the story? Let's look into this. Let's ask some questions. And that gets back to, are we looking at the data with a true commitment to solving the problems before the outcomes are actually definitive?
There will be more to come in months about the making care primary work and drilling down and understanding so that you can pick up like some of these biases or practice style differences that are not acceptable. Elliot and then John, and then we're gonna have to move on. So Elliot, go ahead.
Thank you. My concern is, and I really admire what all you people are doing. You have the overlay now of accountable care organizations. My provider, regardless of whether she wanted to or not, became part of a accountable care organization. And so the last time I saw her, and I'll make this brief, I came in for a problem. She said, I can't do that. My company wants, and I'm not naming companies, my company says I have 10 minutes and that I have to test you for this, this, and this. And I said, I'm not having a problem with that. Can you please listen to what my issues are? She said, no, I have only 10 minutes. I've known this person for 10 years. I was able, because I am part of a white coastal elite, and I admit it, and I'm Jewish, and I don't want to generalize, but I come from a rather vocal New York City culture. And I said, this is what I want you to do for me. This is what I need. Had I been a person, and it struck me, had I been a person from another background, would I be able to get what I needed? I don't think so. And the accountable care organization could care less. They're looking at the bottom line. What are you, so my question is, what can we do about this? And I admit that the corporate structure of my accountable care organization is biased toward white coastal elites like me. I'm one, and I know that I am an unconscious racist or whatever. I went to school on the East Coast during the 60s and had a lot of African-American students that I've roomed with one, and it caused a riot. So what
Thank you,
are
Elliot.
you guys going to do about the accountable care organizations?
Gentlemen,
so,
does anybody want to take that? Go ahead, Dr. Sinclair.
Oh, but, I would just comment that that's unfortunate, and I'm sorry that you had that experience, because that's certainly not the goal and the way that it is intended when there are these, oftentimes to have a target for like a value, a quality outcome, or, making sure that everyone's having certain screenings, that should never be interpreted as being the primary, goal of that encounter. And so I think that's where member satisfaction surveys, I know that may sound kind of like a small thing, but having accountability though, and transparency to the feedback that we are getting. So when members are telling us, I'm not getting my needs met, my provider's not listening to me, we're not communicating well, that we take that and that is weighted and evaluated in the overall contract and outcome, not just did everyone, who falls into this box get this lab test or get this box checked.
And I would also add, Elliot, it's really important that as we keep bringing people up on their health literacy journey and their roles and responsibilities, people need to speak up. You need to register a complaint about that provider, even if you've known them 10 years, you need to give that feedback so the system can follow up, because we hear a lot of other things about ACOs, good and bad, but unless we know about it and if we can't measure it, we can't manage it. So we do have some major work through our communications and our member engagement work about that engaged part of decision-making and whatnot. John, last question to you, and then we just need to thank
I'll try to be very brief, but this is specific. I spent most of my career dealing with employers on employee benefits and pensions. And a lot of things we've talked about today are things that have come up over the years, particularly with the military, when I consult with them. But I've been at the University of Washington now 8 months, and I found a segment of the population, and we talked about language earlier. People from Eritrea, Philippines, Somalia, and Ethiopia have really difficult times trying to get through to the HCA or trying to get through the Department of Retirement Services. And I find they're not getting services that they deserve. The same thing at the university. And when you ask for an interpreter, very seldom can you find someone that was from Eritrea. If we have a disproportionate number of employees, particularly in the lower level positions, custodian, food service workers. And now some of these people have been here 30, 40 years and are retiring. So I've been working with them on the transition from employee to retiree. And it's really quite difficult for them. 24/7 doesn't help because they're not computer literate. So they have to call into HCA. And they aren't able to express their issues as succinctly as you'd like. So I call in with them and we talk to the person and we resolve the issue. But that can't happen on as large a scale as we have. I think it's really important that we recognize linguistic issues and how important it is. I will say minority language, just language where you don't have a lot. There's a concentration in Seattle of Eritreans, Somalians, Ethiopians, and they all speak different languages.
Thank you for that comment. I will say that Washington is one of only 10 states that has probably the highest per population interpreter, folks that are unionized. Dave, I know, has some other services, but it's an unending challenge because we even get quite a few of calls where the dialects, we might have that language person, but now we don't have the right dialect. So it is not something that is unknown to us. It's just forever we're scrambling to find that right translator, that right interpreter with the medical acumen and whatnot. But Dave, I don't know if you were.
Just like to finish one thing. This is all anecdotal, not, I don't really have the empirical data to show it. But I'm seeing people retire without health benefits because they didn't understand what they had to do. They had 60 days to apply. They missed that.
One good thing is when we get to our next presentation, we talk about gathering different data pieces. One of those data elements that we don't have here at HCA or the program is preferred language. We don't even have that as a data point to jump off from. So getting that type of data point will then allow us to not just admire a problem or try to find anecdotes, but have actual data of preferred home language usage to be able to start to kind of triage more systemically language access issues.
Thank you to our panel presenters, Heather, for facilitating. We're going to continue the richness of this conversation as we move into our next topic of diversity, equity, and inclusion data collection. Missy Yates is our stakeholder engagement coordinator in the Employees and Retirees Benefits Division, and she's going to update us on the work being done in the work group focusing on increasing equitable access to healthcare created from the 2020 bargaining session with our school employee labor partners. And tab 3 is where you can find our materials. Welcome to both of you. And Kate's joining. Over to you.
Chair Bursch. Morning. I am Missy Yates. I am the new stakeholder engagement coordinator for the IRB division. I'm here to give you an overview of the work we've been doing with our sub-programs, equitable access to healthcare work group, and as it's related to collecting race, ethnicity, and language data. And although the initial energy for this work began with the sub-program, we are working on this with both programs as we continue to strive for program alignment between the 7 PEB programs that we do. So while this presentation may seem to focus a lot on the SEB program and its members, the concepts and activities that I'm going to review with you will be applicable and beneficial to the PEB program and its members as well. We want you to know about this information and these efforts that we're making and the impact that they can have on the PEB program and its members. Next slide. So to give you a little background, in September 2020, the state of Washington and the School Employees Labor Coalition signed a memorandum of understanding regarding equitable healthcare access. The MOU essentially provided a space for the HCA and Labor Coalition to meet and discuss global issues around inequitable access and treatment in healthcare relative to the sub-specific information and to review benefit eligibility and data by district or employer. This also includes eligibility by job type or classification, which was the subject of a 2021 report by the Joint Legislative Audit and Review Committee. The MOU resulted in the formation of a work group in which members of the Labor Coalition and HCA have been collaborating together on a strategy to collect race, ethnicity, language, and other social determinants of health data to help with doing the things that you see on this slide, gaining a better insight into possible healthcare disparities, confirming whether there are inconsistencies in our benefits eligibility, and if there are considerable consistencies, to consider policies or other guidance that would bring greater consistency in the application of those eligibility standards across the state. And after months of meetings, in March of 2023, we created a strategy for collecting data. Next slide. So on this slide, you'll see several key milestones or key elements we feel that will help us with our data collection strategy. First is the passing of Senate Bill 5421, which passed in legislature last session. And it essentially provides protection on the data that we collect through HCA, through our enrollment forms. And it protects it from public disclosure and essentially exempts benefit eligibility, enrollment information, and anything that's collected by the enrollment forms and maintained by the HCA is protected from public inspection and is not able to be copied under the public act tool. Next is the use of benefits 24/7. As you know, it went live in January. And since this new enrollment system is used by both PEB and SEB, we want to be able to use this as the primary tool to collect and store the member data. We already planned on using this for the new requirements for CMS for the Medicare Advantage program. So some of this work has already been begun. The timeline for expanding it to collect new data for all members is still tentative. But it was because it was important to make sure that we launched successfully and had stabilized the system. We did not want to put anything else into it until the stabilization of the system was complete. Third, we wanted to establish a joint communications work group that would be able to build an engagement strategy for engaging with the members to ensure that we have an understanding of how to engage those folks. Once we begin collecting the data, we want to make sure we're collecting meaningful data, and I'll discuss this on another slide. Then we wanted to make sure we are seeing how people are engaging and actually providing that using data analytics, and then based on that analytics, of course, adjust communications as needed. Next slide.
I just want to drive home one point with benefits 24/7. When we are able to move to the point of collecting the data, I just want everyone to be aware, we built the infrastructure within benefits 24/7. If you go into benefits 24/7 right now, there's not the ability to input that data. But one of my directives for the project was, while you're building the house, build this room, and then we'll open the door and turn on the light switch to that room when we're ready. And so the core infrastructure exists. And so this project the strategy doesn't require building in addition to the house. The infrastructure is already there. Knowing that this day would come, we were building that even before there was a Public Records Act exemption bill in the legislature, so that we would take advantage of those efficiencies of building a system that would have this capability.
So back in July, in 2022, the Labor Coalition Work Group set some guidelines for what we consider to be meaningful data. You'll see on this slide, there's a difference between quality and quantity, of course. The quality of the data, we want to make sure the data is connecting race and ethnicity with job type and benefit eligibility, and also be able to connect that data with the eligibility by employer. But we also want to make sure we have enough data to be able to analyze it effectively. And the data needs to represent the populations that we serve. So we need to have enough from as many members as possible to show that demographic variance. It's important to note here that this data is going to be given by our members voluntarily. So it's going to be a key thing to ensure strong participation from our members by engaging them through community engagement and open communications and building trust with them in order to ensure that they participate. Next slide. Some of this work has become more internal for HCA. We just developed a work group, an internal work group, to begin working on a project to meet the needs of that data collection strategy that the SEB Coalition and HCA worked on already. The first 3 bullet points on this slide will talk about that meaningful data that we just looked at. Next item on the list is about the community engagement strategy, and the last is about the continual improvement of the strategy as we move forward. For meaningful data to be captured, we want to make sure we have clearly defined categories to reflect our member populations, but also be able to adhere to HCA standards and other data reporting standards like federal standards, things like that. So finding a way to have that ability would be very important to be able to go across multiple reporting requirements. The methodology that we use needs to be scalable because our demographics are going to change and our reporting needs are going to change depending on what we're trying to solve, what kind of questions we have to look into. And then also we need to have reports that will be contextualized with the demographics we're reporting on and be able to share with partner organizations so that they too can use the data to meet the needs of their constituents. We also will want to have an engagement strategy. An engagement strategy that will provide transparency about the data collection and build a trusting rapport with our members and that'll encourage participation from members. Promotional campaigns will explain the what's in it for them kind of thing. We want to be able to show them that we're using the data to close the gaps and break down the barriers that they're experiencing and not using it against them. We also want to create training programs for our benefits administrators and those who are working on the front lines with people, with members directly, so that they too can help them go through this process of providing that data, explain to them what's going to help them and providing this data. And then finally, our continuous improvement strategy, as we collect this data, we need a process that we are constantly looking at data to see, is it meeting the needs that we intended it to meet? If not, is there a way we can tweak the process to make sure we are meeting our needs? And so that's a constant check-in and making sure that we are doing what we're setting out to do. Next slide. So for the community engagement strategy, the goal for this, the timeline on it is very tentative, but we want to make sure that we identify concerns that the employees have providing the data. So we want to make sure we have a chance to engage with the communities, with the populations that we're going to be talking to, and find a way to instill confidence in the employees that will voluntarily then provide this data. We want to create communication tactics that will address the concerns that we hear from those members and create key messaging that will relay to the members, to the employees, that as we continue to collect the data from them. The key participation, the key to participation again will be that community engagement, building trust, building a relationship with those members, and continually engaging with that process. Deliverables identified for engaging the SEB members and most likely the PEB members as well. The messaging that we use will probably be pretty much the same, but it will vary. So again, that messaging will be very key to making sure that people understand what we're doing with it and why. Next slide. So as I mentioned, the timeline is tentative at this point, but like I said before, stabilizing benefits 24/7 was our #1 priority, making sure the functionality of that system is up and running and doing as well as it possibly can before we add to it. We also want to build that trust with members, and that is going to take time. It's not just a send a message out, have everybody believe us. It's going to take time for us to sit and talk with people and really listen to what they're saying about their concerns and actually focusing those comments and responses with those concerns in mind. We also need time to collect the data. It's not going to be everybody jump in the system and provide the data on day one. It's going to take time for people to go in, be trusting enough to provide the data, and it'll take time to do that. We want to make sure we're doing this right as opposed to doing it fast. And if any of you are basketball fans, I know we're still a month away from March Madness. I chose John Wooden here. He had a great line here. It takes time to create excellence. If it could be done quickly, more people would do it. So I think that's a really good way of saying it. This is not something that's going to be done in a day kind of. So, do you have any questions for me?
I have a comment, or I don't know if you have any question, but I don't really know Senate Bill 121. When I saw on one of your charts, shareable with partner organization, comprehensive report you might interest with me. I so many global information, business agreements with those organizations that you share data with, kind of like you had to go through with PEBB, you know, like.
Absolutely. Any data sharing that would be done with any of our data that we would collect under our enrollment information would absolutely have to go through all of the, we've got a lot of internal processes before any data is shared with any of our external process or external partners. And even what we would use it for internally, we have our we call it, I think, the DUC, the Data Utilization Committee. That is a fantastic and very, I would say an arduous process, but it's a very deliberate process to make sure we're looking smart about what we're doing with that data. From both a utility and a benefit aspect and a ethical aspect, and making sure we're in compliance with laws and other things like that, both on the state side and the federal side. So while the legislation was merely was an expansion of the exemptions of the Public Disclosure Act, saying all of the enrollment information collected by the PEB and SEP programs, whether it's for active employees or retirees, all that's exempt from disclosure. It was a bit of a gray area as to whether that existed or not before that legislation was passed, but we had an opportunity to get legislation passed that said, without question, everything collected, and this was just last year, so it was pretty convenient. It was a great time for us to have that, so we could have that protection. Anything that would be leaving in any format that would have to be in compliance with all federal and state regulations, all appropriate legal agreements would have to be in place for the use of that information, including data sharing agreements and business associated agreements would have to be in place for anything to be shared.
Also, Tom has his hand raised, just so you know.
John, you're next, then
Yeah.
Tom, you're on deck.
In doing my master's degrees and my doctoral dissertation, I had to defend against data bias all the time. And one of the problems I found in research was that people at the lower end of the income spectrum, people of color, are far less likely to respond when it's an active participation as opposed to something that's passive. I just hope that we can adjust for that.
Yeah, that is the hope with the community engagement, to, get in the room with folks and talk with them and hopefully build some rapport and trust with them to be able to.
The nice thing is we're not engaging in this in a silo just within our division. The nice thing that we have a lot of support within the agency currently. Quinn Wynn, our director for health equity, the pro-equity anti-racism work that she is leading for the agency includes a work stream that is solely focused on health equity data collection and the use of that data. And that is something that this work is part of, that we're working very closely with that team of really smart and savvy data folks, health equity data folks, general data folks, health people, all the people you would possibly want on the team looking at data collection from all the different angles of health equity, of healthcare, of purchasing, of just data in general, are in the room in those conversations. And that's when, this work started in 2020. And now we're looking at in 5 years, we'll be actually being able to answer the questions that were posed in 2020 in the memorandum of understanding. And that's because we're doing it right. And we're being able to address those things like data bias and being able to get meaningful data and have the protections of that data and know the questions that we're asking and wanting to get data that we're collecting and not just collecting data for the sake of collecting data and having that starting point of everything. So we are having that done really effectively. And not only that, but it's likely going to be first in the nation as well. We've been working closely with the National Academy of State Health Policy. I wrote it down because I want to say it right. Of course, I messed up. National Academy for State Health Policy, NASHP. And we've been working with them, and they brought to the table who they identified as the best in state health equity data collection. And they scoured all of the nation. They said, okay, who is doing this the best out there of all the states in the union? They brought to us 2 states. They brought Utah and Indiana. And Indiana has legislation that passed a few years ago that said you can't use the term equity in any of your official government documents. Can't use it. So all the presentations that Indiana has given it to us, they have to dance around not using the term equity, which is the purpose of a lot of the work that we're doing. And then Utah said, this is what we're doing, and it's all based on stuff from 20 years ago. And they have, the data they were collecting used the term Asian to describe 2/3 of the world's population. And so we look at that and we thought, okay, this is good for us to know a starting point of where some folks are at. And then we're looking at where we're gonna be at. And by next year, we're gonna have eclipsed where they're at and be just leading the nation in this work, which is really exciting. I think a lot of that is due to the leadership of Quinn, of Dave's vision of making sure we've got just having the room built, so to speak, and benefits 24/7 is really fantastic. So and our leadership from our agency has really been great. The legislature in supporting things. So all that to say, there's a lot of thought that's been going in, and a lot of things making sure that we're avoiding bias, that we're getting this done right, because we really have one shot to get this done as best as possible the first time we go around, because if we mess it up, it's going to be really hard to recover from it. And so we're working as diligently as we can to get that as accurate and as put together as properly as we possibly can to get it right the first time, so that people see the value of it, so we can just build on it for future years.
Thanks, Missy.
Tom, I think you've got the last question for this presentation. Go ahead, Tom.
Yes, can you hear me?
Yes.
Okay, I think what John pointed out about the lack of trust is going to be one of the defining issues as you try to move forward with this. I want to highlight a couple of things that I have recently, within the last 4 years. I watched an interview with Dr. Fauci by Marshawn Lynch, and he brought up the lack of trust in the Black community of, in this particular case, referring to vaccines, but he went through that kind of whole history. And he said there is a really, at that point, a very, very lack of trust in the greater society and what they want to do with medical. Yesterday, I watched the Senate hearing. I don't know if any of you saw any of it, where the big tech, Meta, TikTok, Google, were grilled by the Senate, members of the Senate, and there were parents whose families have been devastated by what has happened on those communities and the sharing of data, which is one of the things that it spreads from point to point. So when you identify concerns that employees may have in providing the data we request, identify how to instill confidence for employees to voluntarily provide the data, I think that is really going to be the critical challenge that you will face, because I know people on a micro level that if I were to tell them, hey, when you sign up for benefits 24/7, that data that you put in is going to be collected, they would freak out over that. That's how great the discomfort is with the whole concept of data collecting and data sharing is.
Thank you, Tom. This work I know will continue on, but I think it's fabulous that you all are taking us down this path, because data is being collected about everybody all the time in other ways. And so I think I just really support that we have this ongoing evolving work. So thanks to both of you. I think at this point, we'd like to take a 10-minute break. We might shorten it just a little because we're running behind. Maybe are we okay on? Head into our well, everybody do a stretch break, bio break, get some goodies, and we'll be back in 10 minutes. His sound was.
Tom, you might want to know why your mute button seems to not be working. We have to keep muting you because we get feedback and echo in the room. So just wanted you to be aware of that. Back on you.
Thank you.
We're green up there on this. All right. Are we live again? All right. Hello, everybody. Welcome back. If you're just beginning to join us, this is the PEB board retreat. And I'm Sue Birch. I'm going to continue moving us along. We are next going to move to our next agenda item, the Behavioral Health Network Adequacy discussion. And Andrea Vilhauer is our fully insured team manager in the Employees and Retirees Benefits Division. And you met earlier Dr. Heather Schultz, our Associate Medical Director for the IRB Division. They are coming together to bring us some insights about our behavioral health network adequacy. They have materials behind tab 4. And over to you, Andrea. Welcome. Over to Heather, who's starting us.
Start us off.
Okay.
By just providing an overview of what we'll be discussing. So as Dave alluded to in our earlier discussion, there is not always a good understanding of what the specific terms mean when we talk about adequacy for access. So we're going to dive into that today. Andrew's going to start us off with providing some of the historical context behind how we came to those definitions, what they mean in the state of Washington, and what's required of plans in order to be meeting those requirements. And then I will pick up after she finishes to dive a little bit more deeper into how Regents and Kaiser are approaching improving access to behavioral health services to their members. And then we'll finish up with just a quick overview of where members would go to identify what services are available to them.
Good morning. It would be, I could do 3 days on Washington's network access rules. They are very complicated and there are a lot of them. So we're necessarily going to stay extremely high level with this conversation. To begin a conversation about Washington's network access rules, you really have to talk historically, because before the Affordable Care Act, they looked extremely different than they do now post Affordable Care Act. Before the Affordable Care Act, they were sort of aspirational, very vague, and impossible to enforce because there were no yardsticks by which we could measure networks and say, this network is falling short in this area and prove it to a court. After the Affordable Care Act, carriers were required to offer a defined set of essential health benefits, and they had to do it within certain defined actuarial values. Actuarial values very roughly means the proportion of the premium dollar that is spent on actual healthcare versus what would be considered overhead. And the actuarial values are what we know and love as our metal levels, gold, silver, bronze. So the carriers in 2010 and forward, after the Affordable Care Act was enacted, had to determine how to comply with all of those new requirements and still remain profitable. And the method that most of them chose was to try to control provider costs, because provider costs, of course, are by far the most expensive part of any health plan. And they did things like introducing very narrow networks to limit access to the lower cost providers. They tiered providers differently to steer members toward lower cost providers. And they also introduced new referral processes to control access to specialists who are traditionally more expensive. And the use of those methods was extremely common, and regulators noticed that there were some concerning elements to some of the early network structures. So the whole country learned at the same time that the network access rules we had were not going to work. We really needed increased oversight of network practices. Next slide, please. So as a result, the Washington State Office of the Insurance Commissioner, the OIC, did 2 things. First thing they did was to rewrite Washington's network access laws. They created Chapter 284-170 of the Washington Administrative Code, the WAC, which became a bellwether for other states to follow. There are a lot of rules in that chapter. They're very detailed, but there's a certain flexibility that's built into them that we're going to talk about. What's important for me to draw your attention to this morning is that not all of those rules apply to self-insured plans, self-insured employer plans. So please be aware that some of the rules may not apply to our UMP plans, but only to our fully insured plans. And all of the rules do apply to our fully insured plans. As I said, the requirements are very detailed, they're specific, and now they're enforceable. For example, there are time and distance standards. The requirements say that members need to have some providers within X minutes or X miles of where they live or work. An example of that is primary care providers. 80% of members within the service area must have a sufficient number of in-network primary care providers within 30 miles in a urban area or 60 miles in a rural area. And that's measured by from where they live or where they work. Geography is also taken into account. In Washington, you really have to do that. The measurement is not strictly as the crow flies. So if the member is required to take a ferry or cross a mountain range to get to care, that's taken into account. The second thing that the OIC did as a result of the ACA and the need for stricter oversight of networks is to establish the nation's first ever standalone network access unit. That unit analyzes networks in detail for their compliance with these requirements. And they require the plans to file a lot of documentation with them, including copies of the provider contracts themselves. And this unit also reviews and approves requests for alternative methods of meeting these requirements, which we're going to talk about later. This presentation is concerned only with behavioral health, but these requirements that I've talked about so far are applicable across the board to all different types of healthcare. There is one requirement I want to talk about that is specific to coverage of behavioral health services, and that's the Mental Health Parity and Addiction Equity Act, which has the unfortunate acronym of MAPIA. MAPIA pre-existed the ACA, but it was expanded by the ACA, and it's a crucial part of network access when it comes to behavioral health. Generally, what it does is to prevent group medical plans from imposing less favorable benefit limitations on behavioral health than those that are placed upon medical surgical benefits. For example, cost sharing or waiting periods. Next slide, please. So this is the slide that Dave promised, and I think Sue promised as well. We often hear the terms network adequacy, network access, and timely access to care. And you may have wondered what the difference is. We often hear them used interchangeably, but they really do refer to three distinct concepts. In the middle here, we've placed timely access to care because that's the whole point of a health plan, right? When you buy a health plan, you're purchasing access to a defined set of services when you need them. And we're going to look at the measurement of timeliness under the rules in a little bit. Then we have network access. Network access refers to specific characteristics of providers that affect whether a member truly does have timely access to covered services. It's not enough for a plan to say we have the correct number of X specialists. They really need to show that the member can actually get a timely appointment and get the care that they need. In the next slide, we're going to discuss some very more specific aspects of network access. Then we move to network adequacy. Network adequacy refers to the numbers. It's the requirement for the number and types of providers that need to be included in a network to ensure that all covered services are available in a timely manner. That is things like time and distance standards. Plans need to submit to the OIC mapping that shows the location of their network providers with respect to their members. And it includes things like member choice. For example, the rules require every category of provider for covered services. An example of that would be for primary care, that can be provided by an MD or an advanced practice registered nurse, a physician assistant, a naturopath, and all of those licensed providers need to be part of the network so that the member has a choice. So we conceptualize network adequacy, network access, and timely access to care as concentric circles. We can sort of debate about how that really works, but what's important to recognize is that there are three distinct concepts that are very much intertwined. Timely access to care is getting those covered services when you need them. Network access is the characteristics that determine whether a provider is truly accessible. And network adequacy is the minimum numbers and types of providers needed to meet the requirements.
And Andrea, I'm just gonna say that in another plain talk way that I try to think of it, and you're gonna correct me when I'm wrong. But network adequacy, I go, oh, I see that I have 10 primary care providers within 5 miles. Network access is how many of those providers is actually accepting a new patient? And timely access is it 1 day or 2 weeks or a month?
That is absolutely correct.
That's why we got to the concentric circles the way we did.
That is. Next slide, please. So I said that I would talk a little bit in more detail about network access. One of the aspects of network access is provider directories. These are part of network access because it's how the member knows who is in the network. But they also include more information than that. There are requirements for the specific information that the directories have to include about each provider. For example, are they accepting new patients? And cultural information, like what languages do they speak? And the purpose of that information is so that a member can find a provider who meets their needs. Dave mentioned a couple of the examples. Another one is the building accessible to those with mobility? So the requirements require that the network directories, provider directories be current because they're only useful if they're current, and they are a snapshot in time of information that changes very rapidly. So there are requirements for how often they need to be updated. Design of planned service areas is also a part of network access. The service areas cannot be designed in a way that is discriminatory and leaves economically disadvantaged members without options. For example, service areas need to include entire counties rather than only certain zip codes, which would allow a plan to cherry pick healthier members. Referral processes are also part of network access because referral is an area where delay and barriers to access can and do happen. The regulations, as we talked about, are designed to prevent delays. So they do speak to making sure that requirements are not overly burdensome. Network structure refers to things like tiers of providers where there's different cost sharing for the different tiers. Tiering is allowed, but the member has to be able to get all covered services at the lowest cost sharing level. And an example of an early issue that we have there was that some plans had all behavioral healthcare providers named on the specialist tier, so the highest cost sharing tier. That's not allowed under the new rules. I say new, they're not that new anymore, but they're new since the ACA. Requirements for handling a lack of in-network providers. We're going to talk about this in a little more detail later. Sometimes there simply aren't enough providers to meet the access standards for a certain service, and behavioral healthcare is absolutely one of those areas. But even with a significant shortage of available providers, plans are not excused from these requirements. There is simply a method by which they find a way to meet requirements and then submit their proposal to the OIC. OIC then looks at the method that they're planning to use and will approve it or not approve it. Next slide, please. I wanted to show you the network access general standard actual language because it really illustrates some principles underlying the network access rules. They are detailed, they're very prescriptive, but there is flexibility built in to address realities like provider availability and geography. The first word that I have bolded here is maintain. And that's because regulations require that the networks start compliant and remain compliant at all times. They cannot be allowed to deteriorate, which means that if a carrier loses a contract with a hospital or a health system, that carrier needs to show that the network is still compliant, or the carrier needs to show how they're going to get back into compliance without that network or without that provider or provider network. Then I highlighted in a manner that is sufficient because that is a kind of a broad term and there's room for innovation there and alternative delivery methods when necessary. To the extent feasible is also highlighted because the rules recognize that sometimes there simply aren't enough of a particular type of provider or that the providers will not contract with the networks. So the regulations include specific steps that the plans can take to address that situation. In a timely manner appropriate for the enrollee's condition, I highlighted that because where appropriate, the requirements are flexible based on whether the member's need is emergent or not emergent. And then without unreasonable delay is the bottom line. The bottom line is timely access to care. And there's certain flexibility in the word unreasonable that allow for the realities of healthcare. Next slide, please. So what happens when a plan can't meet those standards? This is what I've been talking about, this alternative access delivery request. That is a form that is filed with the network access unit and the OIC. The rules are flexible where they have to be, but plans are not excused from the requirements. So if they are unable to contract with the right number of providers or a certain type of provider, ER doctors, radiologists, and anesthesiologists are sort of historically types of providers that don't like to contract with plans. The plan can suggest a different method of meeting that requirement. For example, single case agreements or telehealth to show that they can ensure access to the covered service from a provider within a reasonable proximity and at no greater cost to the enrollee than if the service were obtained from network providers and facilities. So the carriers are not allowed to just meet these requirements however they want. There does need to be approval from OIC if there is an alternative method of meeting the requirements. And the carriers can't just submit this request. They do have to show that there are really not enough providers to meet the standards, or if the providers are there but they won't contract with the plan needs to show that they made good faith efforts to contract with those providers. There are a certain list of providers who are specialized and rare enough that plans can use facilities in neighboring service areas to meet the requirements. You have a list of those. I'm not going to read that to you, but you will see that it's very specialized providers. Next slide, please. So we talked about requirements that are applicable to all services. I wanted to talk about a couple of requirements specifically for covered behavioral health services. And one of those is Brennan's Law. Brennan's Law is in addition to all of the other requirements for network access, and it's also in line with them. It's intended to prevent undue delay in behavioral health services for members by requiring that certain information be prominently displayed on plan websites. The required information includes tools to help members find available behavioral health care providers, the number of business days in which the plan must ensure that members get access to the covered behavioral health treatment, information about what the member can do if they're unable to access behavioral treatment within the time frame, and resources for people who are experiencing a behavioral health crisis at the time. For example, someone at risk for suicide or who is having a need for immediate help. Next slide, please. Then I wanted to talk about the network access rules that apply to PEB. They're not specific to PEB, and Medicare is different, but for illustration purposes, the WACs require for our PEB fully insured plans that a member must be able to get an appointment for non-urgent covered treatment within 10 business days of their request, or 15 business days if the member needs a referral or the service is covered as specialty care. And here's what's important about that. We gave this presentation to the sub-board last week, and one of the questions was, are there statistics to show that plans are meeting these requirements? Because it doesn't feel like they are. And what's interesting about that is when I checked with the OIC, what I learned is that I was reading this requirement optimistically. It requires that the member get an appointment within 10 or 15 days, but not that the appointment happen within 10 or 15 days. So there's an opportunity for advocacy. I showed you in the on the slide the particular location of those requirements, and I kind of did that to cite the requirements, but also to show how detailed these rules are. Slide just asks what questions.
I have one for you. So there was a headline a while ago about Unite and sanction. Was it in this realm? Was it Mafia or Mafia? It's kind of set up.
I don't know the answer to that question, so I should, but I don't.
Was
I'll
it
get back
pertinent
to you though.
to our retirees?
I can generally answer that question. That was related to the PEB, but I don't believe it was related specifically to network adequacy standards. I think, as Andrea highlighted earlier, the Mental Health Parity Act has a variety of different aspects about, for example, cost share differences, and making sure that there are not treatment limitations that are in place that are applicable in the behavioral health setting versus the non-behavioral health setting. I think it was more on that side of MAPIA, but we will follow up and make sure to bring it back. But I don't, I guess I should say, I don't believe it was on the access side. I think it was some other part of MAPIA.
Thank you, Dave. I think it would be wise. I understand that it is one of the performance improvement plans that are coming out of that sanction. It's my understanding that they're really helping kind of spotlight and improve kind of system weaknesses. So I just want to make sure if it's got crossover into our work, we're aware of it. Thank you. Questions from the board?
So we'll do have Heather as part of the presentation.
So I will tell you guys a little bit more about how Regents and Kaiser actually gets into those inner parts of the circle, the access and timely access to care. Next slide. So we'll start off by talking about Regents, their behavioral health strategy. They have implemented a multi-year plan. Those three different areas on that slide start off in 2022. Where they were really focused on access and how they could increase the number of providers they had. So within Washington State, both in person and virtual, they expanded that network by several hundred providers. Moving on into 2023, although still focused on that foundational aspect of having enough providers to provide the work, they wanted to make sure that members actually knew how to connect with those providers, particularly as it relates to telehealth. Because when they look at their numbers, they're seeing that there is availability for telehealth visits in a short time period, within 2 weeks or so, but they're not seeing as much uptake as they would like. So that's a work in progress for them. And then in 2024, what they're focusing on is quality. So once you've gotten, you have enough providers, you've gotten your members connected to those providers, then you really want to focus on the outcomes. That's what you really care about, not just that someone has seen a provider, but that their concern has been addressed and that they are getting the help they need. And this is sort of an emerging area in behavioral health in terms of tracking their quality outcomes. They are having a bit more success with their virtual providers, but the goal is for in-person or virtual for those providers to start measuring screening tests that they're using, comparing outcomes based on the screening test results. And that's something that they will continue to focus on. Next slide. Kaiser, they have a similar approach of wanting to expand their virtual care options. They have a online chat person available to connect you during Monday through Friday and workday hours, and they have 24/7 phone connection to do screening with a clinician and referral as appropriate to a psychiatrist. They are also making available digital mental health tools for all of their members. So they have apps and different online tools that you can use that are broad, like meditation-based apps, and ones that are a little bit more specific to behavioral health, like emotional support coaching one-on-one, as well as a app that actually provides specific goal setting around depression, anxiety, and some of the more other common mental health issues. One thing I forgot to mention with the virtual care expansion, as I'm thinking about it, is in addition to those virtual options, they are also expanding their provider network by growing their pipeline. So they have a program where they're bringing in clinicians who finished their master's training. They're still awaiting licensure. They're having the opportunity to see patients under the supervision of a licensed clinician. And then using those people to feed into behavioral health services and addiction services that are offered through Kaiser. And then the last area that they're focused on is collaborative care. And that's not something that's specific to Kaiser. That's a model of care that started at University of Washington, utilized throughout the country and the state. And that's embedding behavioral health resources into a primary care clinic or a subspecialty clinic so that there's additional support in those clinics without needing to have a separate visit for the psychiatrist. So what that typically looks like is you have your primary care provider or your specialist provider, and then there is a behavioral health care manager that helps coordinate and communicate with a psychiatrist who's available to do virtual consultation and provide that greater support for the primary care. Next slide.
We ask Kaiser Permanente to give us a visual representation of all the different digital mental health tools they have, like if it's MySpace or Calm or whatever. I just think it would be good for us to have that in the future.
Thank you. This slide is inadvertently carried over from our set presentation. And this is just listing out where we can go to figure out what services are available to them. So if you go to Regents or Kaiser plan webpage, you click through services, there is a specific behavioral health service link that will take you to these services that I described. For new employees, there is information in the enrollment guide. There is also a newsletter that goes out to PEB program members, several types of people. Each of those newsletters doesn't have a specific behavioral health focus, but we do have a cadence where that comes around and we highlight services that are available. And then for PEB NSEP members, ACA is working on a news page that will be rolled out soon and will also feature behavioral health topics.
We have smart health tiles for behavioral health. I feel like we do.
Yeah.
So I want to go back to your earlier question. I pulled up the press release from OIC just to make sure, and I was correct. The specific things that were part of that finding from OIC were about a disparity in the medical necessity and denial rate of inpatient mental health substance use treatment versus inpatient medical treatment. So that's one of those things where you can't have a disparity. And so there was a disparity in the denial medical necessity review process, as well as the reimbursement rates, which is another part of PEBB. So it was that side of PEBB, it wasn't the access side of PEBB.
The one thing I've psychologists certainly
Have you project just a little bit more. Just that our microphone's way over there, so.
I'm still not projecting.
Oh, thank you.
I'll probably need that. I was just saying, training as a psychologist, it's quite interesting to me. The behavioral health piece, when you're speaking about digital mental health, the one thing that I am concerned about is for older adults, 65 years of age and older, who receive more and more cases of mental health. Of course, we know that we need to coerce in some degree. They're well trained as these tools. And so in terms of the availability, is there anything that's being done to ensure that they're able to use this tool to even screen and assess whether they stand forward treatment? What is the appropriate training?
That's an excellent question. I don't have an answer if there's specific programs that either Kaiser or have that they're doing to address older populations interacting with digital health, but I'm happy to follow up.
One other question, if I may, you did measure, spoke about the plan that we should have in place, that we're measuring it was measuring scoring test results, which was one way, I guess, in terms of tracking. But this is tracking more on the diagnostic side, right, the screening test, but in terms of the outcome, is there a
Yeah,
tracking?
there's- It's definitely, I think in all of healthcare, not just behavioral health, but physical health as well. Getting to outcomes instead of just process measures is a work in progress. But so there are things like just doing basic process things. Are you getting HQ9? But then there are also some quality measures that are coming out from NCQA, like HEDIS measures that look at response to treatment. So looking at your score when you're screened and then expecting to see a follow-up score documented and then not just documented, but did your score drop so that you're now considered that you're in remission or that you had a response? So the goal is to, I think it's baby steps. The initial goals are just to really start getting people to track that they're anything so that we can compare between groups. But ultimately, there are some outcome measures that people are interested in getting to. And those are a bit trickier to get at because it takes multiple pieces of information. It often requires access to the actual medical record for the patients, which sometimes plans don't have. So that requires partnership with the providers as well. And then for folks who are still on paper, that's a whole other challenge to make sure that you get that information.
And you're right, the baseline is actually very important. So we start.
So just a quick comment, maybe a question. So you had mentioned in the beginning that SEB members were saying, you know, they didn't necessarily see or know that there were behavioral health providers that were available. I think our state employees are expressing that as well too. So if there's any way to partner with you all to, I know we have Smart Health, but any way to like come to some of our business resource group meetings or other ways. We hold a lot of listening sessions, especially after kind of an acute event, and we're hearing that our EAP isn't sufficient, like they're looking for the healthcare providers. So having the accessibility of how to navigate the system and find them is where we're seeing the gap. So I'd love to partner with you all on that.
Andrea, Heather, thank you for this information, and we look forward to, as you keep evolving the metrics and the outcomes, hearing back from you. Great. We're gonna make up some time, Dave.
We will.
We are moving on to our next topic, which is the plan year 2024 open enrollment summary. So Elisa Richards, our benefits account section manager, and Stacy Graftiza, our customer service manager. I'm sure I butchered your name. I'm sorry. Both in the herb division are going to present on the agency's efforts during this open enrollment and the results of the PEB program plan year-end 2024 open enrollment. Your materials, I think, are under page 5. Take it away.
Well, thank you. Good morning, Chair Birch and members of the board. For the record, my name is Melissa Richards, and I'm the benefits account section manager. Today, Stacy and I are here to talk about open enrollment. So next slide. So the two primary units involved in open enrollment within the benefits account section is our customer service and outreach and training. The customer service unit is the first line of contact for our retirees and continuation population. Staff in our customer service unit perform 3 primary functions, which is answering a toll-free line and responding to HCA support requests, providing in-person lobby services for walk-in members, and reviewing members' retiree or continuation coverage eligibility as they process enrollment forms. The outreach and training unit provides training and support to agencies and organizations for both the PEB and SEB programs, who in turn act as the first line of customer service for their employees. So outreach and training provides training to our benefit administrators of these entities regarding program plan options, covered benefits, eligibility, rules, and enrollment processes. When these agencies or organizations need additional assistance, they'll reach out to the outreach and training team through a dedicated 1-800 line or through a secure online correspondence tool called HCA Support. The outreach and training unit also supports the in-person benefits fairs across the state of Washington during open enrollment. And benefits fairs are a scheduled in-person event where an employee or a retiree can learn more about health plans and benefits.
The dates, times, locations are always advertised in our October newsletter as well as on our HCA. Customer service and outreach and training units work with other HCA divisions on open enrollment activities all year round. Some examples are preparing our PEB My Account and Pay One system for open enrollment readiness to include available plans by county, premium amounts, messaging, etc. The outreach and training unit secures vendors' locations for the scheduled in-person benefit fairs. We offered a pre-open enrollment training for benefit administrators in October to prepare them for open enrollment. And we also continue to work on the virtual benefits fair. So VBF is an online website created with the same goal in mind as our in-person benefits fairs. And some of the features are that members can learn about their benefits from their home. It's available anytime, day or night, and it can be accessed via computer, tablet, or smartphone. And some carriers provide direct interactive webinars, pre-recorded webinars, and teleconferences to share plan-specific information.
I would say the BBF is designed to have the same experience except for lip balm. The swag that you might get at a table.
Increased communications during open enrollment based on the changes to premiums and benefits for the 2024 plan year. We sent out weekly notifications to members to remind them to review upcoming changes. Our first mailing was a postcard, which was sent at the end of September to all members to alert them that there were changes to benefits and premiums. Our communications continued through open enrollment to include a premium increase letter, 4 postcards, and a benefits fair mailer. And then some additional communication strategies were increasing our social media posts, forwardable email messages shared with employers for them to in turn send those out to their employees with important information. There was also an alert banner in PEB My Account, as well as the open enrollment web pages. We had a website alert on the front of the HCA website, helping members easily find those open enrollment pages. And this year, we actually had an open enrollment web page for retirees specific, which was based on some feedback we received during the listening sessions and such last year. And then the the October newsletter included call out information members need to be aware of when considering plans.
I will say that I think our communication strategy was pretty effective. I think board members might remember at the end of last year, it's like we're going into a year where there's a lot of premium increases that we need to get people on high alert. I will say there were anecdotally many conversations where people said, yeah, Dave, I hear PEB is having an open enrollment this year, much more than I've ever heard in my tenure with the program. Some people were like, am I getting a postcard or a letter this week? And I was glad that people were getting used to getting something once a week. I think we had something once a week for 7 weeks for almost everybody. And so, the proof is in the pudding at the end of the day, though. I don't remember if this is on one of the later slides or not, but the level of engagement in the system and changes was higher, very much higher than usual. If I remember correctly, our typical high water mark for average engagement in past years has been around 8,000 to 9,000 subscribers and active in the system, and we had 3 times as many. So we were in the 25,000 range engaging with the system. You might ask, well, how are appeals going? People who missed that opportunity. We are right smack in the middle of the beginning. So the beginning of that process, because the time in which people realize they didn't engage is when they see that deduction in their pension payment for the first time, or they see it in their pay stubs. School employees, for the most part, got paid for the first time yesterday in 2024. Retirees' pension payments went out from DRS yesterday. And so that pension deduct is, or that amount that's hitting their bank accounts is coming right now. And for state employees, we get paid for the most part twice a month, but for some reason, January 10th just flies by for a lot of state employees. And the first time they really look at their paycheck is the 25th. So we are just starting to see kind of that appeals volume. I did a check-in yesterday, and the appeals volume we have is lower than this time last year. So cautious optimism, cautious optimism.
I would agree with job well done on the communication this round. Noticeable difference.
and I think very needed. I got a lot of feedback from our members about that. In fact, some of it, a little bit, was humorous about, I'm tired of it. Leave me alone. Can they put that money into my benefits instead of these letters every week? So I was a little comical. Very good job.
Sorry, I'm looking there, sorry.
Yeah, Kurt, move that slide.
So last year was the first year that we offered in-person benefits fairs since fall of 2019. We received a lot of member feedback, which we used to plan for the fairs this year. So based on member feedback, we increased the number of fairs from 8 last year to 15 this year. And the locations for this year's fairs were selected based on member enrollment data. So during the earlier fairs last year, we did have printed materials. We didn't have printed materials available by November 1st. So based on feedback, we worked with our communications team to have those materials available for our first benefits fairs and then also on our website mid-October. We increased our staffing at the fairs to help support the needs of our members. And we started planning earlier for more of our program staff to attend to address the member questions. And similar to last year, the benefits fairs were heavily attended by retirees versus employees. And then this year we continue to offer virtual benefits fairs, which we had 12,997 visits to the virtual benefits fairs. So it still appears to be a preferred method. So now I'll pass it over to Stacy so she can talk about how it went with our customer service team.
Good morning or afternoon now, Chair Birch and members of the board. For the record, my name is Stacy Graftiza and I'm the Customer Service Operations Manager. On this slide, I wanted to provide a visual of our phone trends for 2022 and 2023. The top graph represents the number of calls we answered each month in 2022. The number at the top of each month in that graph represents the total number of calls for that month. The number along the black line represents the average wait time to speak to a customer service representative for that month. So for example, if we look at the first column for the month of January in 2022, there were 5,404 calls with an average wait time for callers of 13 minutes. And there are some differences between these 2 years. In January and February of 2023, there was a higher higher wait times. And those can be attributed to the lower number of fully trained staff available to take calls, along with dedicating more staff time to processing the increase in open enrollment forms received during the 2022 open enrollment. You can see as we continue through 2023, we were able to make improvements in our wait times, and this was primarily due to filling more vacant positions and more staff fully trained for the full customer service duties. We saw a significant increase in calls in October in 2023 compared to 2022. I believe this is primarily related to an increase in communications that we started mailing at the end of September, as well as open enrollment information that was posted on our website in mid-October. While we started 2023 with longer wait times, we made some great improvements as the year went on. We answered more calls in 2023 compared to 2022, with a decrease in the yearly average wait time, going from 21.3 minutes to 14.4. And I'll discuss more open enrollment details related to the phones on a later slide.
Yeah, I'm wondering, do you actually add more folks to the call center during open enrollment? Or is it the same number that you have all year?
Well, we have a certain number of full-time employees, and depending upon where we're at in the hiring process, or where they're at in training, it really is dependent upon how many staff we have available during.
Working at home, or do they work in a call center?
We have both. We have some folks here on site and some at home.
The reason I'm asking is, first of all, the people that you hire are great, and they're very helpful. They resolve issues. and they're just very well trained. But the problem is I've gotten so many complaints for people waiting, they can claim up to 2 hours sometimes. And I know that this is an average, of course. But I'm just wondering if there are times that we should tell people not to call? Are there anything?
You know, I don't really.
Oh, yeah, that's.
Well, yeah, I do wanna say, like, thinking about open enrollment, and there are always improvements that can be made, but there really is a lot of success in 2023. And some of it is because of how we tried to stagger and make sure that we were fully staffed on July 1st. I remember it was the first time in years where Alyssa or Renee, her predecessor, said, "We are fully staffed," and I said, "You just jinxed yourself." But we made it to open enrollment, and that fully staffing on July 1st had a rollover effect of being able to process the volume of K-12 forms that comes in the summer, which allowed us to get ahead on that, so we weren't behind on form processing as we went into the fall. So there is some deliberate hiring patterns that we're trying to focus on, targeting that summer month. But if you look right here in October, twice the number of calls, but 1/6 the wait time and average wait time. That is a huge success story right there. And while in the month of November, 37 minutes on average is still a really long time, I can tell you that one of the expectations that I have for Alyssa is that Alyssa alert Jean and I anytime that we hit 60 or 90 minutes in a wait time. And historically, I used to get a lot more notifications. This year, I know that I think it was more than 5, but it was less than 10. But in the past, it's been more than 2 hands per county. And so there are definitely strides and improvements that we've been making. We know that it needs to be even better, but we really are trying to celebrate the success of the huge shift that has happened in this past 2023. But we do have one limitation, which is there is a finite number of funded positions. And, in my tenure, we expanded and added a third team. We sought that from the legislature, making that jump from an additional team because you have to hire a lead and a supervisor. And so it's kind of like a big investment. We were able to do that 2 or 3 years ago. And so, but part of the challenge is there is an ebb and flow to the cycle. And when you look at staffing patterns, yes, we could always use more people in the months of October and November. But that staffing model isn't supported for necessarily 9 other months of the year. So there is this delicate balance of trying to get more staff. We do actually over hire by a couple of positions, knowing that there will be some turnover, so that we actually, we're funded for 25 positions, we're hiring for 28, knowing that we're gonna lose a couple, and on average, we're gonna actually have 25. So we do things like that. We didn't historically used to do that as well. We also have continuous recruitment. We used to have to start a new recruitment every time. Now we do pooled recruitment, and whenever we have some vacancies, the kind of jump starts the recruitment process. So those are some of the strategies that we've really been putting in place to kind of help get to the results we have today for this most recent open enrollment and continue that downward trend.
These numbers represent PEB and SEB?
This represents retirees who come from both state agencies and K-12.
Last point. Is there any thought, has been any thought given to doing retirees in October, employees in November? Just to spread that out a little bit.
The call center doesn't support employees. It is a retiree only call center.
I call the same number and I get.
People who are transitioning, they're currently an employee, but transitioning, it's a transition to retirement. As an employee, when I have, I guess pretend I'm not the director of the PEB program, but if I work at DRS and I'm an employee, my first line of questions is to my HR department at the Department of Retirement Systems, at which point, if that person has a question, they reach out to the outreach and training unit, which is not the call center. The call center is designed for when I'm transitioning into retirement and I'm moving from employee status to retiree status, or I'm already retiree. So separating that wouldn't help these call volumes. And I think I'd solve a Kyla and then.
Just have you all explored like the callback feature where people can just leave a number and have them call you back?
Yeah, and I actually will discuss that in a later slide.
You do that now, don't you? Yeah, that's what I was
You do
gonna
that in a limited fashion, right now.
Yeah.
Okay, so we'll cover that, but here.
I had 2 things. One, great work. Well, that's actually about 3. One, great work. But when I look at the chart, I see that the time spent to answer went up in November compared to October. I would have expected the opposite, but I think it probably has to do with that time when you actually are, a retiree is actually wanting to enroll. Because, you know, to spend 6 minutes on, we had 1,000 more calls, but it took a half an hour less to answer, just doesn't seem right. I think it has to do with the need
nature
for
of the call.
information.
Yeah.
And yet, do you have any feedback on call abandonment?
We do capture that information. I don't have that available with me right now.
Is it maybe in your mind, is it significant? Is it what you would normally think?
I mean, it does happen, obviously, when we have higher call volumes, there's more abandoned rates as well.
Well, it would seem to me if you had the callback, most people abandon, think about it.
We'll bring back call abandonment details, so
Yeah.
we're not guessing, but we'll rate that as a piece.
Okay, let's see, next slide. Okay, writing documents. So our business cycle pattern is similar year to year. And really knowing the ups and downs of it throughout the year helps us plan work and activities to meet those changing workload demands. In 2022, we received 35,544 documents. And in 2023, we received 31,636 documents. So there was a slight decrease in the total number of documents in 2023, but a very similar pattern we see month to month. As you can see on the slide in November, it continues to be our highest number of documents received, and that's due to open enrollment forms. And for a quick reference, just in 2021, which I don't have here, but we received 2,751 open enrollment forms in 2021. And so the last 2 years, which you do have here on the slide, we've seen a significant increase in those open enrollment forms received. And that is primarily due to the premium increases.
And when we were able to expand to a third team, that's what we call fortuitous luck. That expansion happened just before the fivefold increase in forms.
Likely. We resumed in-lobby services, in-person lobby services in March of 2023. So there's no data for January and February of 2022. But taking those months into account, we still saw an increase in the lobby visits in 2023 compared to 2022. Knowing we had a significant increase in lobby visits during open enrollment in 2022, we were proactive in preparing for 2023 by temporarily setting up an additional lobby office and increasing staff dedicated to assisting guests in the lobby. We recognize that it is a very important service that we offer our members. Next slide. So on this slide, I included a matrix from 2021 to 2023, specific to customer service data at open enrollment. The column on the left includes the interactive voice response, which is a self-service option where members can check their enrollment status, request open enrollment packets and retiree guides, as well as check to see if their forms have been received. The next item is calls to speak to a customer service representative. You can see that we had an increase in the calls answered by a representative. The matrix also lists the wait time average, which is the time it takes to reach a representative. We saw a significant decrease in our average wait time in November of 2023 compared to 2022. You can see that the average wait time in November of 23 was 36.7 minutes versus 58 minutes in November of 2022. And I will note that those are averages, that there may have been times throughout open enrollment that our wait times were higher, mentioned. And so next is the callback feature utilization, which allows the callers the option to hold their place in line and receive a call back when they're next to speak to a representative. We have the number of lobby visits, open enrollment forms received, and the number of HCA support tickets received. And really, one of the toughest challenges we face is processing open enrollment changes timely when we have those high call volumes. Similarly to 2022, we had a significant increase in forms during open enrollment, than at other times during the year. We were able to dedicate more time to processing documents from the start of open enrollment, which really allowed changes to be processed more timely. Because we were able to start processing changes sooner, the confirmation letters were sent out daily to subscribers as we processed those changes. It also included the number of fully trained staff at open enrollment for full customer service duties. We had 20 fully trained staff and 6 staff in various stages in their training. And based on their training, those 6 staff are assigned to work different workflows based on their skill set during open enrollment. Having those 20 fully trained staff during open enrollment made a significant difference this year than in past years that aided in a successful open enrollment. Customer service was able to answer more calls with lower average wait times, assist more members in the lobby, and process forms more timely, which resulted in members being notified of their changes prior to the start of the new 2024 plan year.
I'll just add that I'm really excited about the statement I'm about to make, which is this is the last enrollment that is entirely paper-based for retirees and our customer support center. And I'm cautiously optimistic that there will be more uptake of electronic enrollment. We will still have paper-based enrollment that is an option for people. But one of the hallmarks of the self-service of benefits 24/7 for those retirees who use it is instantaneous confirmation that their form has been received. And then it will get to the customer support team faster because it doesn't have to go through our imaging process. It uploaded into an imaging system, and if there is any backlog, because that imaging team supports the entire agency, not just the PEB and SEB program, it will allow just a faster, smoother process. And the more that individuals leverage and use that online system, it will help contribute to lower wait times on the phone. But they will also not necessarily have to call in and say, "Did you get my form?" Because they will see, "Congratulations, your enrollment was received," right when they do it. So I'm really hopeful for that positive feedback loop and to see what the numbers look like and how much of that can be attributed to uptake based on electronic enrollment.
Just a quick question. What's the time frame from hire to fully trained?
It's about 5 months.
Michaela, if you had asked that question 5 years ago, the answer was more 7 to 9 months. So we've also made strides there.
Yeah, I'm gonna go back to you. All right, next slide, please. All right, so now I'll go over some of the data from the net changes made by members during open enrollment. On this slide, you'll see the list of medical plans for each PEB employees and non-Medicare retirees, the total number of enrollments in each plan in 2023, which is a snapshot in October of 2023, just prior to open enrollment. And then there's the 2024 column. You can see the total number of members enrolled as of 2024. The 4th column, you'll see the change from enrollment from 23 to 24. I've highlighted in red the enrollment changes in each plan that had a decrease in enrollment from 23 to 24. You can see some plans had significant changes, such as Kaiser Raw Value, which saw a decrease of 13,379, or a 56.3% decrease in their overall enrollment. As a reminder, we do publish these open enrollment switching reports on our website each week during open enrollment. And then there is a final switching report that is posted that anyone can view if they.
I do want to emphasize that this is net changes. So that when you look at this is not able to capture, and there's more data that Alyssa will go through, but it doesn't reflect internal switching within a carrier. It's just net in and out of the plan at the end of the day. I do want to, Tom raised his hand, and so I want to see if his question's on this or was on the prior slide, but I don't. Tom, what's your question?
You're talking, we're not hearing you.
Tom, you're unmuted, but you're not audible yet. Okay, we'll try to come back to you, but also write your question down so that we can circle back to you as we get further in the presentation.
Next slide.
Oh, sure.
Maybe you alluded to it, but I was very interested to see, based on the premium increases, how many folks actually left, especially Kaiser Northwest, and then how that's going to impact the next season of rates. And you said this is change, so do we know? And I see there's a graph and a couple of pages here that I might have to have a engineer decipher for me, but
So Kurt, slide 11 is employee and non-Medicare. So if you wanted to know net movement from Kaiser Northwest, you'd add up minus 250, minus 1781. There was a net loss of 2,000 individuals, and the starting point was about 3,900 individuals. So there was that gets you the total volume of individuals from the employee non-Medicare side. The next slide, slide 12, will end up being the Medicare portfolio. Okay. This is, you for Kaiser Washington, for example, you do the additive amount of 4 rows between 116 and minus 13,379. So we see that we had roughly a 13,000 covered life loss from the Kaiser system elsewhere, and most of that was picked up in UMB. Oh, perfect, thank you.
On this slide, you'll see the changes for Medicare retirees. We did see a big increase in enrollment in the United Healthcare PEB Complete Plan from 2023 to 2024. As I mentioned on the previous slide, you can see the decreases for each plan in red. And you may notice the net change in total members of 508. So this net loss is a result of retirees leaving the program for whatever reason. So this could be death, it could be going back to employment, or going to a non-PEB plan under a spouse. And those are just a few examples of where they may.
Some historical context on that, you go, oh, 500 people, is that a big number or a small number? I remember looking at this closer last year and remember thinking that 700 to 800 was a low number. And so 500 is less than those numbers. We've had numbers that reach into the 4 digits in the past historically in recent years when I look at this. So that is a relatively small net covered lives lost in this portfolio.
And just as a reminder, Plan F has been closed to new enrollment since 2020, so we'll only see decreases in that.
Going back to Uniform Medical Plan Classic for 2000 and the previous year, what was that number? Do you know offhand?
For 2022?
Yeah, was it a high number? Because that's when we.
It was closer to 50,000. I know that for sure. I believe it was just over 50,000.
So we probably lost another 6,000, 7,000 or so.
We can definitely circle back with that.
It's no big deal. I just
But it
wanted
is
to-
close. It is close to that. Yep. Oh, real quick, Tom thinks he's fixed his mic. So Tom, let's check with you.
Yeah, well, first, can you hear me?
You can. You did.
Okay. So those numbers that the PEB employee and non-Medicare retiree numbers, is that in a way reflective of that conversation we had last June and July about the rates that Kaiser was charging, the migration away from the Kaiser plans? Is that kind of reflective of those significant subscriber charges that they put into effect?
We don't have, specific polling data, if you will, but that is the presumption that the increases and people looking at their choices, that these numbers are directly related to the premium increases last year. Yes.
And I think you already answered this, but I'll ask it anyway. Have you attempted to determine where those roughly 16,000 people went from the plans that they were enrolled in?
Yes, we actually, in the weekly switching reports that are produced, there is a grand matrix where you can see exactly the total number of people who switched from Plan A to Plan B. It's a massive spreadsheet that has all permutations of the options, and you can see exactly, we just rolled up to show the net piece here. We found over time that trying to walk through that spreadsheet in various forms just has not proven to be particularly fruitful, that people want the bigger picture, but we can certainly send out to the board the full spreadsheet and you can see the exact number of lives that moved from plan A to plan B.
Okay, thank you.
Maybe for a future meeting, if there's a way recognizing that gathering demographic data is a challenge. If there's a way to try and understand both like demographic data of people who switched as well as appeals to try and understand if there's any disparity there.
Thank you for flagging that.
Another question on this chart. The very top box on the left, Kaiser Permanente Northwest Classic, it has one line, only one line that then goes down to Uniform Medical Plan Classic. Is that because that's the only choice they had, or just doesn't show?
No, it's not the only choice they had. It's just this, so on this slide, it's just showing you where they actually went from those plans. So they started on the plans on the left and then they made their change during open enrollment to the plan.
Right, that's, I figured that, but it only shows one line. So
So you could, if you had literally every permutation, it would be a ball of yarn that you would be like, I have no idea where that goes. So we set the scale so that it had at least a certain number.
200, it was a minimum of 200 so that we could make it.
you could say
This is
most of them-
manageable.
Yeah.
most of them, this was their choice, or the highest number, this was their choice.
Yeah.
Okay.
Yeah, this represents any line over 200, but there are many, many more lines.
All right, thank you.
Skip some of these talking points then. So I'll just, you can see that Kaiser Value had 2,388 members, switched to Uniform Medical Plan Classic. In the green bar, you can see 1,444 members that switched from the Kaiser Classic plan to Uniform Medical Plan Classic. And then the thin orange bar shows 840 Uniform Medical Plan Classic members switched to the Primera Medicare Supplement Plan G. And 3,682 Uniform Medical Plan Classic members switched to the United Healthcare PEB plan. And then just as another mention on the bottom of this slide, I did include the link to those weekly switching reports so that anyone who's interested can take a look at those reports too.
I applaud you all for first off the yarn ball diagram and all this movement. I'm just wondering, Dave and team, if you have thought about as we get more sophisticated and as you invest into the modern era with 24/7, and we'll be hearing about that in a little bit. Are we able, or are we considering in the future this movement and what it means for disruption in care? Loss of a consistent primary care provider, and some of those kinds of care delivery impacts that we think might not be so good for someone's overall health. So I'm sure I want an answer other than,
Yes.
yes, you are.
Other than yes, okay, yes.
Because that's that we are, as we keep evolving, you know, and certainly as we have a workforce that's more representative of our diverse members. Are they moving, you know, are some of our strategies around more appropriate care and equity hang off? Hopefully we will be able to maneuver more of these variables in the future to monitor. Great job on
Thank you.
another successful open enrollment and all the communications you guys did. I have received just a huge number of compliments saying, wow, you really got our attention and we paid attention this year. So I do think that
There's a
The
little,
board could have
I was
more
in
PM.
any meeting with other state agencies, there was like, anybody have anything for the go to the order? I'd be like, don't forget open enrollment is happening. And then as we got further into November, other agencies started to say that on my behalf. So I was like, yes, we've achieved psyche.
Dave presented to the full cabinet and just did a great job too, stressing the importance of them serving as ambassadors to get their employees involved. So, John.
I hate to stand in the way of lunch, but quick question. When will we start to get some employee satisfaction surveys back based on the changes that took place this year? mid-year next year?
I've got to really think about that part and where we are surveying people about that. I'm gonna have to,
I'd just be curious to see how happy people are making the change from complete to another plan with United Healthcare, from Kaiser to complete. Just be curious to see how happy they are.
We'll report back on that. I know anecdotally, we hear things, and again, most of this year has been fairly favorable, and quite honestly, I was a little surprised. I think the board had heard out Kaiser about kind of what they were predicting, and they certainly didn't lose as many members as I think they initially thought. But I think we'll get more information as the year goes on. We'll get back to you, John. I don't think those CAP scores and some of that satisfaction stuff comes out till mid to late year.
Yeah, that's what I figured. But I was curious when we start getting some idea of how people received their healthcare.
Let's take another quick break. During this break, meals will be passed out to board members and participating staff, and we will begin to they'll get us ready for our working lunch presentation directly after the break. So we're
right
gonna
at 12:45, we'll have made up 10 minutes.
12:45.
We got 15 to go.
All right, are we on? We so apologize if you see us chewing and eating on camera. Our mothers would not be happy, but we are back at our PEB retreat board meeting. Next today, we are going to hear from Katrina Pitch. Katrina's going to talk to us about our benefits 24/7 update. Katrina's our IT project manager in the enterprise service division. She's going to give us some information regarding the benefits 24/7 application that launched earlier this month. And her materials are behind tab 6. Katrina, sorry to make you watch us eat while we listen. Over to you.
Coverage. Thank you, members of the board, for having me today. We're happy to present on benefits 24/7 and the successful launch. I am Katrina Pitch. I work for ETS, Enterprise Technology Services Division, and I have been lucky enough to be the project director for the application. Next slide. So why did we have a modernization effort? So we really wanted to pursue a more user-friendly interface for both our subscribers and our benefit administrators and even our own employees that are working within the system. We wanted to have additional self-service functionality for subscribers. That modern interface for benefit administrators is a pretty big improvement over what we've had in the past. You'll see an illustration of that to come. We also wanted to align with the most recent security standards. So secure platform that not only is more secure in the way we access it, but how we store the data. We wanted to have reduced reliance on K1, our mainframe system. That system is aging. The population that maintains that system is also aging. It is not a, it is written in COBOL, so it is not a language that is taught any longer, and it is also very difficult to make adjustments to it. So things that might take the front end web-based application approximately a month to make a big change in functionality could take 6 months on the back end in the mainframe system due to all of the changes that need to happen. So it definitely will provide us some eventual cost savings in replacement of Pay One over contracted resources that we currently utilize. Having a singular platform is really important. It allows us to, again, concentrate our resources into maintenance and operations of the singular platform, and also then the opportunity to really continue to improve and add new functionality as we exercise the system and find out where people want to see changes. Next slide.
And I say we had a modernization goal because it's the 21st century, not 1980s.
There is that.
Whatever.
And I'm not supposed to call down.
Healthcare Authority. So we maintain it, we
Created it.
create, yeah.
But
It's been around for.
we didn't. It predates us.
Yeah, I know
Those
that.
two were not born when A one was implemented.
But the healthcare authority doesn't pay people, separate
No.
system to actually pay.
So the payment portion, so
Earnings, yeah.
Oh,
That's average, yes.
that's,
The OFM.
that's Michaela.
It's not me, but.
And it doesn't have a benefits component attached to it, correct? Thanks.
Whole different project. One Washington, modernization, okay.
So we did launch benefits 24/7 on January 16th. From that time, we had, in that first week, we had approximately 1,500 subscribers that logged in and over 800 benefit administrators. So many people logged in more than once. Hopefully, many of the people here in this room have logged in to the application and been able to see how it get the, maybe a bit of the look and feel and see what your current benefits are. There's certainly opportunities that we'll cover here in a second about the additional functionality that's available now that wasn't in PEB My Account. So there have been a number of calls, and really this was, again, just the first week. So over 260 calls requesting support for logging into the system. We do utilize Secure Access Washington. So we have been providing support for folks that are utilizing that. To gain access, it does require the additional security of multi-factor authentication. And one of the beauties of Secure Access Washington is that it is a single sign-on solution for the state. So I myself can log into my benefits 24/7 record, and then I can also navigate from there to Department of Licensing to look at my information there, or even Employment Security Department for different reasons. So as long as you use the same SAW account to log in to each one of those applications, then those are linked and it allows for easier transitioning back and forth. Next slide. So benefits 24/7, what kinds of issues did we hear within the first week? We definitely had some issues with the representation of tobacco and spousal surcharges. They presented to some folks that would indicate that they would have to pay, though that was not accurate. And it was a small population, but we were able to get that resolved pretty quickly. And it certainly didn't impact billing. We did also provide a link for retiree premiums, made that more prominently displayed and added messaging around that. As we talk about enhanced functionality to come, we will have that premiums more prominently displayed and folks will be able to see exactly what they are paying on a monthly basis and as they go ahead and make elections for new benefits. One of the outstanding issues at the time I created this presentation was University of Washington. University of Washington sends us the enrollment updates from their system. It is a custom interface. It has approximately 50,000 employees. So it's pretty significant lift to make sure that we have both that functioning properly and then also with the regular enrollment from the front end of benefits 24/7 into P1. So we had a couple issues that presented with that interface and we were very close to the University of Washington and we have resolved the majority of those. So we're continuing to chip away at that to ensure that the enrollments are processing through and we're seeing things appropriately and getting into the carriers. We have also had a few onesie twosie issues reported and we continue to investigate those to make sure they aren't widespread issues. So as many of those come in, we address them, respond, and triage them as appropriate. These were the most significant, larger spread issues. A lot of the rest of them tend to be very small issues related to data migration of 40 years worth of, in some cases, 40-year-old data. So next slide. So what has changed for subscribers? You can see the most significant impact was certainly for the PEB subscribers versus the SEB subscribers. We utilized a lot of what was working well in SEB My Account when we created benefits 24/7. And so the opportunity for enhanced functionality for the PEB members was certainly more significant. So you can see the red column on the left was PEB My Account. And so the functionality on the right for the green areas was really for SEB My Account and for benefits 24/7. Next slide. So what were really some of the big enhancements for self-service for subscribers? Really being able to complete your initial enrollment online. Newly eligible subscribers are able to use the web-based application in lieu of a paper form. You can make changes to dependent coverages or even your dependent demographics. You can provide verification documents through the front end, make changes to long-term disability, and then request special open enrollments throughout the year as appropriate. Certainly have the enhanced security, and we have the opportunity to view not just current but future coverage elections. And then additionally, we now have the opportunity for continuation coverage for retirees to initiate applications, the application for coverage within benefits 24/7. Oh, please.
Can you fill out most of Form A on this?
Yes.
Do, and how far in advance can you do the initial enrollment or actual retirement date?
You actually, there isn't a limitation of how far in advance you can come.
So you can just say, do it in November, effective February 1st?
Yeah.
You do both of those.
Great. And the current functionality is closely aligned with the experience you would have if you filled out the form. So we kind of made the application mirror the form. The next iteration is many people had ideas for how to improve the form. And rather than actually, that's being worked on right now, but this first iteration is the form, but in an electronic format.
Leah also has to get that.
Okay, go ahead.
Yes, my question is, I want to make sure I understand what's changed for subscribers. Do we still have to access this new program through SAW, Secure Access Washington?
Yes. Secure access, and that is part of the requirements of the our governing body of the OCIO, the Office of Chief Information Officer. So it is one of the requirements for security that we utilize SAW. And it does have the benefit of being able to navigate to different applications for the state. But yes, we are required to utilize that for access to benefits 24/7.
Then my follow-up question from personal experience is if we're having trouble navigating SAW, is there anyone who can help us?
Yes, so there is certainly some help available through SAW. And then we also have a 1-800 number for folks to call and get assistance. We have tip sheets available, and we have folks that can help walk through some of those challenges that you might be experiencing.
Thank you.
Next slide. So we definitely have easier navigation to be able to walk through the application, to walk through the steps that you need to take when you first become eligible for benefits. This is what the screen looks like here. So we certainly have opportunities to navigate in a multiple different ways.
Just for the record, this is a test environment. You see like words like welcome to Sprint 61. That's kind of an internal screenshot. That's like the IT development thing. That's not a word that a subscriber would see. And this illustrative example happens to be a school district, but insert your favorite state agency's name.
Yes, promise all of the data is mock data. Okay, next slide. So this is what the difference between the last slide and this slide kind of shows a newly eligible subscriber that has not yet made elections to now I am a subscriber, I have made elections or I have current coverage. So you can see that there are a lot more options available. My dashboard looks different. I also now have the opportunity to navigate to the bottom there where we have the continuation retiree coverage widget. So that would be where folks would go to initiate an application for that coverage. There is a little bit of a nuance there. The retiree availability to submit that application is available without a constraint on timeframe. However, if somebody wanted to submit continuation coverage, they would have to have had a termination date entered into the system. So it's not there all of the time to create confusion between which form should be utilized. So we do have a good amount of checks and balances in the system to help people navigate through. Okay, next slide. This is where we get into what does it look like for benefit administrators. Now, benefit administrators and HCA employees were utilizing Pay-1 in that, as you see displayed. So this was the system they were working in day out. It's a very old technology. And we, definitely appreciate the more user-friendly opportunity now for benefits 24/7. So let's go to the next slide. So the improvements there, we certainly have the better user interface. Certainly it should help reduce some of the churn on training into the system. Subscribers now can complete their initial enrollment. Benefit administrators are not required to key everything in for them initially. Dual enrollment, by having both PEB and SEB subscribers in the same system, we can remedy a lot of that immediately and keep some of those collisions from happening. Subscriber enrollment history is available, which is helpful. It's provided on a specific report. We'll actually get to that in a second. We also have verification documentation that can be received through the system. So a lot easier to process, view. Visibility of the wellness program participants is now available. We have opportunity to be able to ship data sets to PEB and SEB benefit administrators through our data depot. It allows us to kind of streamline some of that communication in lieu of sending everything out through different secure messaging channels. Definitely have opportunities for reduced paper, reduced errors on those enrollment forms with a lot of the enforced logic that gets applied. And then really the opportunity to continue making enhancements in a more rapid fashion than we ever. So this is what the benefit administrator dashboard looks like. I think we can all agree it's a big improvement over Pay-1. They have different notifications that are available, such as like pending verification requests or dependents. Next slide. The subscriber history. This is a great opportunity. They can see when subscribers last logged into the system, who made changes to different records. It gives you more of a complete history than the limited visibility of what was in Pay-1. Next slide. So this is a snapshot of the data depot. we have the opportunity to upload singular files to organizations, or we can do it in a more automated fashion if we have a good deal of information that needs to go out to different areas. So definitely a time savings for our outreach and training folks, be able to disseminate some information, and then it keeps it more of a consistent portal to pick that up. Next slide. What stayed the same? Many of the existing reports and delivery methods are the same. Billing files are provided in the same way they are now. Cycles did not change. A1 continues to be the system of record for the accounting functions. We do receive information in an automated way from higher ed and HRMS. We have the UW enrollment interface, so A1 is not adjusting it. We kept the interface much the same. HCA support channel for communication remains the same, as well as additional the training that we are receiving from outreach and training. But without training, there has been a good deal of training provided in preparation for benefits 24/7. We have user manuals posted, instructional videos, webinars have been recorded and posted. We had a pre-launch webinar in December of 2023, and then additional webinars that are upcoming. I think those dates, the dates on the bottom were postponed. So we'll be, I think they were pushed out for 2 weeks. Yeah, so, and that was to gather information from folks and make sure that we had a really healthy Q&A session and address any concerns or training issues that might have arisen. Next slide. So communications, we have information posted on our webpage, quick start guides. We have information coming in the February newsletter. Benefit administrators have their own web pages for specific information and support. We certainly are going to be providing additional training and project updates in the spring to January timeframe. And then benefits 24/7 launch webinars. I think I said that on the last slide, but they have been posted or available on our website. One of the beautiful things that we were able to take part in is more user-centric design. So human-centered design. We really took an opportunity with a retiree workshop to work on have some feedback received on the prototype that we had created, and also just really open it up to brainstorming what could we do to make things more user-friendly. And we definitely took some of that feedback. We were able to make some incremental changes for this initial launch, and then take some of the larger desired functionality and incorporate that into a future launch. So we really want to continue to improve and receive that feedback. So we will have additional feedback loops on that so that we can continue investing in the application. We have a great, healthy maintenance and operations team. The majority of the team that built the application will be staying on for maintenance and operations. So that consistency is going to be really helpful. And we really do look forward to hearing your feedback on what's working well and what would make things easier. Next slide. So some of the upcoming additional functionality is for a retiree enrollment wizard. As Dave had mentioned, we have more of a digitized form currently for retirees. We really want to make that more user-friendly. Vision election is vision carve out will be coming and available through the application. We do expect there to be a pretty heavy use in the next open enrollment period. And then notifications to subscribers about changes in dependent verification status. Currently, if the status changes, you can log back in and see what that looks like, but more of a push on that would be helpful. And then benefit administrator facing, currently we have a few requests for some additional reports. And we'll continue taking in some of that feedback and adding additional desired functionality to basically a list. And then prioritize that. And we'll be working through some additional focus groups to gain additional information. That concludes the presentation. Any questions?
I just want to again say how much of a quantum leap forward this is in a pivot point for the program. It's really the way that this came about was the success of the launch of Set My Account. When the SEP program was launched, I've said this many times, you were probably tired of hearing it. We knew that we couldn't do 140,000 forms at once. We had to have an electronic solution, and the success, I think we had over 98% of school employees who did online registration, and with fairly minimal issues, widespread issues that were experienced. And so that gave credibility to saying, for me, turning to folks and saying, can we please keep the same team and do this on PEB? We really need to do this on PEB. And now here we are. So a lot of times I would sit at SEP board meetings and say, you can learn this from PEB, you can learn this from PEB. And this is a great example of PEB learning from SEP, or being able to leverage something in the reverse direction. And so I couldn't be happier and prouder of where we are. I remember reaching out to people after the first couple of days in government. It was like, did you remember we switched this on? And they were like, no. I said, well, that means you're not getting great complaints. So overall, we aren't seeing issues and you're not hearing issues. That's the mark of a good IT project, unfortunately. So we're really proud of where we are at this point. It's not all, there are some issues that get resolved and worked on, and every day there's going to be something, and that's just part of this world. But systemic big problems, we avoided all of those, and we're really happy with the opportunity to keep an iterative process, so that we're not in 2040 talking about replacing the 2020 system. We'll be incrementally getting better and better and better.
So of our nearly 300,000 folks now, 400,000
Are you the employees or the subscribers or?
subscribers, how many have started setting up? Are we doing the temperature check of like how many are establishing accounts? I got in mine actually just a minute ago. I did get through, saw a different way. I think, how many people are going in? Do we monitor that, or? how many
We have been monitoring it, and then it's funny because, yeah, some people, we looked at different metrics. One is kind of distinct to like who's ever logged in between launch and now. The other is how many people are logging in per day. There's a lot of people that log in multiple times per day, certainly benefit administrators, but I want to say it's around 2,500. We were just looking at these numbers yesterday, and I apologize for not having it readily available.
It's okay. It would be good to report back to the board though, like, we get halfway there as we climb up in use and adoption.
Yeah, and I certainly expect there to be a big balloon for that when we get closer to OE, with folks needing to make that vision election for PEB.
Right.
So that will be interesting.
Other questions from board members?
Working fine for us.
Great. Well, thank you so much for your work in continuing to modernize us. It's a great achievement, Dave. I mean, really, I do remember 6 years ago when I began and getting all the paper forms going, wait, we are on paper. It really brought this forward. So congratulations, guys.
Very much.
All right. We are going to move on to our next agenda topics, which is the study on contracting for administration of UMP. Ryan Ramsdell is here. He is our team manager in ERB, and he's here to give us a debrief on the legislative report regarding the study on contracting for administration of the Uniform Medical Plan. Brian's materials are behind tab 7, and Brian, welcome.
Thank you. So just for clarity, when we reference TPA, we're referring to Regions Blue Cross Blue Shield in regards to the Uniform Medical Plan. So
TPA being
a third-party administrator.
Yep.
So next slide. So this is a result of Substitute Senate Bill 5693 that was from 2022, directed the Healthcare Authority to study and report on options for the possibility of transferring administrative functions for the UMP plan from its current contract to TPA regions back to HCA. In that report, we were asked to provide several pieces of information, including providing information about the contract and where it was prior to 2010, what the processing through HCA was like, the efforts to procure through the third-party administration contract since, and what elements of those services could be provided either directly or through discrete provider contracts, and the resources the authority would need to administer these functions. Next slide. The report also had to include and compare the cost of the administration and components before and after the transition. So assumptions about impacts on claims, description of the performance guarantees, which I'll explain in a minute, implementation plan to enable the healthcare authority to resume self-administration for some or all of the administrative services at the end of the contract. Next slide. So pre-2011, HCA administered the provider network contracting in-house. That meant that our staff were involved in communicating with providers, hospitals, and so forth to establish the means and the contract terms in order for them to provide services to our members. We directly contracted with them, but we did use a TPA known, which was UMR, United Healthcare Company, to perform some of the other TPA obligations. And I'll kind of go through a list of what some of those would entail. Next slide. So from 2011 to current, in 2011, the UMP TPA contract consolidated all UMP medical administrative services into a single contract, which was awarded to Regents Blue Cross Blue Shield of Washington. When the 2011 UMP TPA contract was set to expire at the end of 2019, a competitive procurement was conducted, and Regents was once again awarded that TPA contract for an initial term of 2020 through 2029, with a possible 7-year extension after 2029. I want to remind you that in 2020, we also took on the SEP population, so those kind of came hand in hand. Next slide.
I do want to highlight real quick a little bit on timing, because some people will be curious, why was the legislative report due in 2023 if a contract goes through the end of this decade? It seems a little early. When we started the procurement that resulted in the 2020 contract actually began internal work in 2015, almost a full 5 years in advance. The complexity of UMP Plus with our high deductible plan and the number of employers we have, it just the security reviews that are necessary now for those data exchanges is more robust. I don't believe in the original iteration there was a necessarily an OCIO in the mix. Office of Chief Information Office and security design standards for IT have definitely enhanced. And so it really is a very long runway. And so when the legislature was looking at asking for a report, it was, well, if we wanted to change direction, when would we need to do that? Or when would we need to give you insight? And the answer was, well, during the 2025 legislative session would be the time to tell the agency we want to go in a different direction, because if we were going in a different direction for 2030, that's right around the point when we would need to start and avoid duplicative work. And so that backed up to a report that was due last month. So that it seems early, but unfortunately it's not.
So let's go to the next slide. This one, that's right. What does the current TPA manage right now? So the current TPA contract for UMP consists of the following administrative services, and then we just kind of block them out here. Provider network contracting, as I mentioned before, claims administration and appeals, utilization, complex case, chronic condition, and quality management improvement, and that's a lot. And I can go over that a little bit more when we see sort of a pie chart coming up. Additionally, it's responsible for, next slide, medical drug management, member services, member communication and online services, fraud, waste, and abuse detection, operations and data reporting. Next slide. Thank you. So scaling these efforts. The current TPA contract for UMP consists of basically administrative costs for UMP that represent 3% of the total annual cost of UMP, compared to the approximately 1.8 billion in medical claims costs each year. The UMP TPA contract's administrative costs are paid on a per subscriber per month basis, meaning that the UMP TPA contractor is paid a monthly amount for each subscriber. And as of December, at the point at which this was released for 2023, more than half of all PEB and SEP members are enrolled in a UMP plan, about 387,000 out of 675,000. I think the next slide is helpful, and I know this is pretty dense, but when you're trying to explain what the magnitude of a transition like this would entail, looking at sort of where those services are residing within that just small administrative section of 3%, the pie chart on the right explains that to you. Utilization management's a big one, and I don't know that a lot of people know what that is, but that is sort of your prospective, concurrent, or retrospective review. Those are the things where you have medical specialists, you have potentially billing specialists, policy specialists within the arrangement, ensuring that things such as pre-authorizations, appropriate care management, potentially cost containment, appropriate level of care and service are occurring throughout that entire spectrum as the individual goes in and the claims begin to be received, case management starts. And so that's a hefty chunk. Many of those individuals are licensed, they're nurses or doctors. So that is why that is of that magnitude. And of course, we're mostly familiar with a lot of what goes on with member services. When you call customer service, when you're seeking advice or assistance, the P search engine or the provider search online, that's that large chunk there. Next slide. So returning, the feasibility of returning the provider contracting to HCA. To assess the feasibility of HCA providing some or all of the UMP TPA administrative services, HCA contracted with Mercer Health and Benefits LLC, provide insights into current self-insurance industry practices and to analyze potential cost impacts. Mercer concluded that of the 8 administrative services in the current UMP TPA contract, and granted these are large buckets, provider network contracting and disabled dependent certification, which is a smaller chunk of one of those categories, might reasonably be administered by HCA. Mercer concluded that the remaining administrative services best be done by a TPA due to the high startup costs and efficiencies of scale. Next slide. So what are some considerations for bringing this back? In 2011, HCA transferred its existing provider contracts that it arranged to regions to use in its provider network services on behalf of UMP. Due to the contractual terms, state procurement rules, and other legal barriers, the legacy HCA provider contracts and their terms likely cannot be transferred back to HCA. That would mean that we would most likely have to execute new provider contracts to build or rebuild the UMP network. New contracts may not be able to secure the same historical preferred discounts UMP experiences today, which could increase claims costs. Significant hospital and provider network consolidation, we're reading a lot about this in the news, including regional and several large national systems entering the state since 2011 and the consolidations emerged there within, have come with large providers who take up more of the market space, and in turn, there's less market competition. It also provides a different leveraging point for negotiations. Also to be considered, the UMP TPA contract contains numerous performance standards and guarantees that put more than a third of that total administrative cost at risk, with the specific performance guarantee tied to provider network contracting as an example being the largest component. So I'll stop here and say that performance guarantees are a component of most of our contracts now. They are typically they are driven by a target or a marker or an expectation on behalf of the agency or the contract, the contract generally, stating that you have to meet or abide by certain thresholds, and if you do not, something is put at stake. Often in relation to this TPA contract, it would be a portion of the administrative dollars we send to them every month. So that could be anything from the time that we expect them to respond to call centers, the process in which they generate or process appeals. We have one that's very important related to this whole question of mergers and leveraging, which is a trend guarantee, which kind of ties into looking at the average costs across national and state providers generally and trying to have our costs and our contracts negotiated within that arrangement so that we don't exceed that trend if we can help it. And that's a big one that we are able to leverage through having a TPA contract. It is also assumed that HCA taking direct contracting in-house would have a disadvantage compared to a TPA due to market share. Regions isn't just negotiating contracts on our behalf. They have their own internal insurance products that they negotiate, and they often negotiate them simultaneously. Region staffing structure is also, it benefits from an economy of scale as employees are assuming the roles can potentially work across benefit contracts and various areas of the arrangement, whereas HCA may not be able to benefit from a comparable economy of scale, and that could result in an increased need for staffing costs and FTEs compared to the current arrangement. So the conclusion of the report, and I should caveat that by stating we were not asked our position or our opinions. We were strictly asked to report on our findings and what we thought it might take and what it might cost. The report concluded that HCA could assume some UMP administrative services that are currently provided by Regents. However, the likely increase in claims costs could far exceed any potential administrative cost savings. Maintaining that current UMP TPA contracted services and the established provider network contracting terms could continue to have substantial claims savings to the state and reasonable premiums for UMP members compared to an alternative approach. The marketplace of third-party administrators already has the existing infrastructure that allows it to scale with the emerging innovations and established partnerships that offer competitive advantages. You can see that some of the new benefits we roll out, often those are apps and programs that are being navigated on behalf of Regents that bring them to us for consideration for introduction into the UMP. This also provides that they have greater combined purchasing powers. They have to ensure cost-effective compliance with federal and state insurance regulations around licensure, provider directory, credentialing, and certification requirements. So with all of that said, there's a pretty significant consideration that this report calls out. And it is that if HCA did more took on more administrative services of UMP, increased costs to the state might be offset as a broader health policy reform that can make accepting the claims increase an acceptable trade-off. If an overall systemic change was implemented, such as a regulatory reform around provider participation or contracting, it might be acceptable for HCA to leverage new in-house responsibilities to consider how providing contracting incentives and structure could help reinforce things such as value-based purchasing concepts and payment models within the commercial market. I know that's a lot, but I think Dave likes to speak on this component.
I do like to the plain talk way I think about this is many people know there are a lot of conversations going on in our state about some sort of, I'll just say broadly, universal single payer type system. And anything in that direction might have a bigger shakeup of how the care delivery system, how insurance works, how we all experience healthcare in our state. And so what we're saying in this report is if you just look at the silo of PEB and SEB, that cost benefit analysis might not make sense to bring services back into healthcare authority. But as part of a bigger piece of the puzzle, it might make sense that there's a policy trade-off there. And that's really what this is trying to highlight is make sure you don't just put on your PEB and SEB lenses, come to a conclusion, take those blinders off and make sure to look at a bigger picture in there. Just because it may cost more here, there may be a grander equation that it is a subset of.
In the appendix, you'll find an extraction of just the executive summary of the report. The report can also be found on the HCA Law and Government website. Got the link there. It's not a hefty report, but it is dense. So take that with a grain of salt.
Any questions? Does our current contract with Regents allow us to rebid in 2029?
There are caveats within it that allow various scenarios where we would proceed with a different arrangement. But yes, typically we would initiate procurement activity at the end of the initial term if we did not choose to execute extension rights.
And in reality, many of our contracts in the PEB and SEB programs run longer than 10 years. But if there is reason to go out, we always have the right to start a new procurement and look at our termination provisions and end a contract even before the initial term. Typically, we're not looking at that as part of an initial, during that initial term of a contract. We're usually looking at it at renewal times, but there isn't anything that would prohibit going out for procurement at really any point.
I was just thinking about what you said, and I've been thinking about this for a long time. Is the whole world of healthcare is going to change. It has to. So the question is, do we just go along with the wave, or do we be proactive, as you're possibly suggesting?
There's flexibility.
Ryan, thank you for this presentation. Can you speak to something we heard this morning? Quinn Wynn, our equity director, talked about kind of this notion of bringing in more PGs with equity. How how does our current arrangement and or does the report speak to the adaptability or flexibility of how we can shift or mature our PGs?
I don't know that it went so into detail within this particular report related to performance guarantees. I can tell you that they have become more and more a focus of future contract arrangements. There's always stuff in play, but there has been a significant amount of social determinants of health and equity discussion focused within the entire agency. I was just have just concluded an RFP approach on a accountable care program, and that was one of our most significant areas of refocus from the previous iterations, looking at how we could influence social determinants of health, equity, data, transparency. It's very topical. So I know all of these arrangements are looking at how we can influence that.
Other questions? Any board members that are on virtually? Any final questions for Ryan? All right, thank you very much for the presentation. All right, we are now going to move on to the governor's supplemental budget and the legislative update. We have our very own Tanya Newell. She is our finance manager in the Human Services Division. We also have Kate Walker. He's back there, I see. Our policy rules and compliance section manager in the IRB division. They are going to give us an update on the governor's budget, supplemental budget, and the legislative session so far. Their materials are behind tab 8. And welcome. I'm gonna start. I'm starting.
Money first.
Money first, yeah. All right, good afternoon, everybody. It's been a long 6 months since we've been here. So I'm gonna just give a quick update on the governor's supplemental budget. As a reminder, the supplemental budget is gonna take care of mostly things within that second year of the biennium. So the biennium will cover fiscal years 24 and 25. We're in the first year. We're gonna address things for that second year primarily. For us, what is important to the board is that's primarily calendar 2025 benefits. Since the board already took action last year on calendar year 25, most things for 24, we're gonna talk about things for calendar year 25. All right, so first up is the first set of decision packages that were funded. This fiscal year, the agency leadership really decided to focus on kind of 2 decision package themes for the PEB program. The first one was around alignment, meaning either alignment between a self-insured and fully insured product or alignment between a PEB and SEB program benefit where things were different. So in this first decision package, all 3 items were funded for the PEB program. The first up being a virtual diabetes management program. Currently, the PEB program has a diabetes prevention program, but this would be a diabetes management program for those who are already diagnosed with diabetes and meet certain criteria. This is at $612,000 for 6 months. So because a calendar year is worth half of a fiscal year, start things January 1st and the fiscal year goes through June 30th, you can double this item to see the full annualized impact of this. The reason this is on the list for alignment is this exists within the SEB program currently, but not within the PEB program. This was something that was funded starting January 1st for the SEB program. So we're working on aligning that with the PEB program. Next up is diagnostic and supplemental breast screenings to cover those exams at $0 member cost share. This relates to Senate Bill 5396, which was passed last legislative session and impacted our fully insured carriers, so our Kaiser plans within the program, but not the uniform medical plan. So this would be requesting funding to align that $0 cost share within the uniform medical plan as well. And again, this would start January 1st, 2025. And the last item that was picked up within this decision package and funded was a vision hardware increase. Just to step back 1 year, you'll remember that we did a decision package to request carving the vision benefits out for employees and our non-Medicare retirees from the medical benefit, and there will be a standalone vision product. This was funded and we're working towards that implementation. This is in addition to it to increase that hardware allowance every 2 years from $150 to $200.
effective
January
January
1st.
of 2025.
2025. All right, and then the next decision package that was funded was a request for staffing, primarily to support our Medicare program. There were 4 FTEs requested, plus some additional dollars to support these FTEs, and all 4 FTEs were funded. Those were for FTEs within our outreach and training program, our portfolio management and monitoring, as well as in our communications. And you'll see here, 590,000. This, however, is a full 12 months because these would start on July 1st. This year, July 1st. Keeping these dates straight is a challenge. All right, and then on the next slide, here's the funding rates that were included within the governor's budget. A reminder of what the funding rate is. So the funding rate is the amount that is paid by each agency or higher education institution for each eligible employee to cover their benefits. This amount covers medical, dental, vision, life, AD&D, admin, surplus, basically the costs to run the program. And these are set on a fiscal year basis. We are currently in fiscal year 24, so that $1,145 you see will not change. And then the number for fiscal year 25 in the governor's budget is at $1,158 per eligible employee per month. And this number could and might likely change. So this is for the governor's budget. We produce modeling here at HCA that's delivered to both OFM for the governor's budget as well as legislative staff for the conference budget for consideration. When we delivered our modeling for the governor's budget, it was based on a certain quarter's experience, enrollment, and a ton of assumptions. This version that we're delivering actually later this week will inform the conference budget, which will have 3 additional months of claims experience. It will have the updated results of enrollment from the switching that happened this fall. And so there will likely be a change to this number. But like Dave usually reminds the board, there's no real magic number here. We can see this number swing quite a bit based on the amount that the program spends each year, that this number can swing a little bit and not cause any. So no real magic number here that makes us, we're good with everything in this. Next up, there were some changes that were funded within the governor's proposed budget regarding the Medicare explicit subsidy. So there are 2 components to the Medicare explicit subsidy. And the Medicare explicit subsidy is the amount provided by the state to lower Medicare retiree premiums. Currently, it's set at $183 or 50% of the premium, whichever is less. There was funding in the budget to increase this to $193 and 60%. So it's still an or, but both of those levers were increased within the governor's budget. There's a little nuance here is that the 193 is within the actual appropriations bill. 2104, while the 60% lives in statute. And so there is a separate bill that addresses the 60%. So you won't see them both in the same place within it. And next up, there was new proviso language that was included within the governor's budget. And it allows the board to forego the federal retiree drug subsidy or RDS revenue that's collected for the Uniform Medical Plan Medicare, in order to leverage federal subsidies via the adoption of a Medicare Part D employer group waiver plan, known as EGWP, to reduce Medicare retiree premiums for the Uniform Medical Plan Classic. Now, this proposal relates to something we will talk about here coming up shortly in the agenda with Ellen, Molly, and Luke. And they're going to talk about the Medicare portfolio analysis that was done. And this language allows the board, if they were to pursue a change in the pharmacy structure of UMP, the state would essentially be walking away from that RDS revenue that is collected for the Uniform Medical. You might remember from last year, we talked a lot about the retiree drug subsidy and where those funds go. Those funds go directly into the state general fund that we collect. They do not go to HCA.
So this language was included in the governor's budget to basically acknowledge that the board has permission to make this type of change, because typically the board would not have the authority to make a change to the state general fund budget that was that significant. So there's one other piece to this that is new and I thought would be important to talk about. And since the budget language has came out, we did work on finalizing our actuarial analysis regarding the retiree drug subsidy projections for the upcoming calendar year starting in 25. And we learned that due to the significant rising pharmacy costs within UMP, that UMP will likely not qualify for RDS regardless. So if the board chose to make a structural plan to UMP Classic Medicare pharmacy or not, we will likely not qualify any longer for the retiree drug subsidy revenue, starting with plan year 2025. For a little bit of context, that's about $20 million of the total $26 million that we receive in retiree drug subsidy, as compared to the approximate $200 million that the state pays out in explicit subsidy costs.
So just to reiterate, if the board pursues the option that we'll talk about later this afternoon, the state would be giving up the RDS. If the board doesn't pursue, the state's still probably going to lose the RDS. That's a development, sets the budget language.
Question, the new budget language on here, when does that become official or approved?
Yeah, so this is still this is the governor's proposed budget. This language would have to make it through a final conference budget that was agreed to by both the House and the Senate. And that is expected to come out early in March. I think first week in March, we should see the final conference budget. So if that language would be in there, I would assume it would be either July 1st or starting calendar year 2024.
Is that something that could get run out? So it's due in March, but because of some other things that are going on, they can't, I don't know, adjourn, they come, call a special, come back, could it get all caught up in that so that we did look at something to do in April? We didn't have the approval to do it until, it was being held hostage in something else.
Well, that's where
That makes sense.
Oddly, what Tanya described as the most recent development on the RDS, in some ways, this language may not ultimately be necessary anymore because the state's going to lose it anyway. So regardless of board action, that general fund revenue will evaporate. And so in some ways, the importance of this language is a little less today than it was in December.
Has his hand up. Go ahead, Tom. You're unmuted.
Yeah, I actually think your what Dave just said answered my question. Thank you.
Other questions?
I will be back after the March final conference budget and give you all the updates to the final numbers.
Okay, and we'll have more on this conversation here
Absolutely.
in just a little bit.
Okay, I'm gonna try and go really quick. How much time to try and make up here?
Don't go long, is the request.
No pressure.
Every page has an indicator for me to go faster. All right. I'm not going to talk too much about the legislative report because Ryan just went over that, so I get to skip that page. But I did add things about the reports on the legislative updates. I wanted to make sure that things that were mentioned in my report from the last time I spoke to the board were also captured in this report, so that those who are just tracking maybe my reports on legislative updates would see in my subsequent reports that I have at least addressed those things for consistency's sake. So it's nice that Ryan was able to present a much more in-depth report out on this report, so I'm not going to bother with it. It's probably longer. I wanted to speak about this. So on the next page, we have another report that was reported out onto the legislature late last year regarding the PEB Medicare retiree benefits survey and reports and options. I'm not going to spend much time on this as well because the boards have been doing a lot of work on this now and into the board season, and I think they've already been made aware of a lot of the work that was done on here, and that there will be some more information coming up about that later in this meeting as well. So after that,
Ellen will take care of that shortly.
Yep, thank you. And then the last report to just also touch on is one that I had mentioned last year that was sent up to the legislature mid last summer. That was from DOH's Sunrise review regarding fertility benefits and conceptualizing what would a commercial benefit plan package look like for benefit commercial plans to offer on a fertility benefit in the state of Washington. This was something that has been looked at by the legislature. I don't think anything's moving with it this session. I haven't seen it. I think there was some stuff that had been introduced and looked at, but the costs have just been prohibitive for it to move forward. And so not a topic you will see come up in my further presentation. Moving on, bills analyzed by our division this year. Suffice to say, we're moving really quick this session. First cutoff already occurred yesterday. And so I really only get to talk to you all once during the session as it's actually in progress, and that's today. The next time I get a chance to speak with you, session will be over. And unlike a lot of other years where I actually come to you 3 or 4 times during the midst of session, this is the only time I'll speak to you in the middle of session. So these numbers are already outdated by a lot. We've done 81 analyses so far. We've had 30 fiscal notes, which is quite a bit of fiscal note analyses so far, even before we've hit our fiscal cutoff, which I think we've already got probably half dozen fiscal analyses that are in the pipeline, with the fiscal cutoff coming on Monday, which just seems like it is coming extraordinarily quickly this year for some reason. Just a very solid session, even though it's still the same 60 days as all the other short sessions, but it just seems like it's coming fast this year. Next slide, please. Our funnel is very empty because, as you can see, the cutoff dates have only just barely been starting to hit us. Suffice to say, we just have a couple of bills that we've been looking at that are high priority for the ERB division, which is to say the bills that are having a significant impact on the PEB or SEB programs, which is only a couple this year. And I'm going to touch on those in just a second. And I'll make sure I note for you all which ones have actually made it out of the meeting yesterday and where those statuses are in the how a bill becomes law process. Next slide, please. So we did have one piece of agency requested legislation that we did get introduced through the governor's office and introduced by Senator Robinson this year. And this is actually the short title of it, which I think is kind of hilarious. This is Senate Bill 1694. Let's see if I can do it in one breath. 1 second. Aligning statutory language concerning the retired state employee and retired or disabled school employee health insurance subsidy with the historical interpretation and implementation of the relevant subsidy language in the operating budget. That is the short title of the legislation. I think it's actually longer than the actual legislation itself. It is really just making sure there's alignment with the historical language that's been used in the budget, language regarding the subsidy for retirees, and the language that's sat in the statute regarding the subsidy for retirees for a long time as well. The way, the budgetary language for the subsidy kind of gets tweaked every year as different legislators come in and adjust the budget. They've used language a little differently over the years since the subsidy language has been in there for many, I think for some decades now. And so there's been kind of a historical practice of that subsidy just used to cover the benefits that are made available to retirees through this PEB program, even though the language in the statute says it's for pharmacy benefits. So we're aligning that language to make sure there's not any ambiguity or disagreement between the practice that has occurred between the budgetary language and what exists in statute. It is not doing anything that eliminates, adds, or otherwise changes those plan options or plan designs. It doesn't change your authority to offer or otherwise compel you to change those plan designs that are offered to retirees. It's really just aligning that historical practice with the statutory language to make sure there's not any confusion between that, especially in light of any potential changes that the board may make to any of the Medicare portfolio offering. Let me just pause there and see, Dave, is there anything else you'd like to add to that? Or if there's any questions from the board regarding that?
The main difference between the budget language and the statute is the budget language has always used the phrase health insurance. The statute generally refers to prescription coverage. Those are not the same things. Health involves more than drugs. It usually traditionally means medical and drugs. And so that's what this is really just clarifying and protecting retirees' access to the way the subsidy has always been applied in its calculation process. And this bill is already on the Senate floor calendar.
Okay, moving on. I'll get into a little bit more of the other specific legislation that it's not coming from us, but we're still watching very closely. Specific to the PEB and SEB programs, there's House Bill 2125 concerning the eligibility for contingent faculty at community and technical colleges. This expands some of the eligibility for the part-time or faculty at community technical colleges to allow for them to include some of the additional hours like preparation hours or holiday pay or other things where they're in pay status but is not necessarily directly tied to their instructional hours. So allowing them to have a little bit more hours for consideration in them being able to attain benefits eligibility. This has made it out of the committee, policy committee with the House, and has moved on to appropriations, and we'll see where it lands after Monday. Moving on, we've got a few bills related to regarding retirees. 2013 is a bill that was introduced by Department of Retirement Systems last year, paying state retirement benefits until the end of the month in which the retiree or beneficiary dies. This is meant to resolve a number of issues administratively for DRS, but primarily on the PEB side is to ensure that in the instance when a retiree dies and they have their PEB benefits being paid by a automatic deduction through their DRS sends an automatic payment to the PEB program for the premiums for their PEB retiree benefits. There's a clawback that occurs by DRS in that month of death, so that the prorated amount of that benefit from DRS goes to the retirees, however it's set up on the DRS's that retirees account, whether it goes to their survivors or however it's set up in the account. But DRS claws that back and prorates it. A lot of times that results in maybe that account not being brought up to current. We don't prorate benefits on our end, and so sometimes that means that account might go unpaid, which is not a great thing when we have retirees who pass away in that last month of death. Might end up with an account that is in arrears. It may result in the account being retroactively terminated, which is not a great thing, assuming there's probably a good amount of care that was offered. So having that account paid in full would allow for us to be able to have that premium covered. Now, another bill that's been introduced that's at the bottom of that list, 2481, would have that same sort of impact to resolve that on at least the HCA PEB side of things. 2481 waiving the health benefit premiums in the Public Employee Benefits Board. That is accomplishing the same thing, but just on the PEB side of things. It's not doing anything on DRS's end. It's merely saying, okay, in the month of death, HCA, you can waive the premium for the retiree who passed away. So that way, when DRS comes and claws that back, there's no reason that we will then waive that required premium for the retiree. So then they have their coverage, and DRS can claw that back and return the prorated amount to whoever would be the beneficiary of that account. I'm not totally familiar with how DRS does it, but at least from our side of things, we wouldn't be worrying about trying to go and collect that last month of premium, and their account is good. Our accounting side would be much happier not having to go after trying to contact the estate of the decedent and trying to get that. Both of those bills are currently in appropriations as well.
So it is suggested by the way Appropriations Committee has acted that they are likely to act on 2481 and not 2013. Which is, it is unfortunate. They are not mutually exclusive ideas. You could pass both of those bills at the same time, and there's many people who believe that the policy of both of them is a worthy policy. I testified on behalf of the agency in support of both bills, but it does seem like the most likely path forward is that the 2481 appears like it will be scheduled for coming out of appropriations, but not 2013 at this point.
Then I'll speak on a little bit of a different topic, but similar. House Bill 2188, Senate Bill 6139, changing the health insurance subsidy rate for retired state employees and retired or disabled school employees. This is coming from the governor's office and is part of what the governor's budget proposed, which is increasing the subsidization amounts for raising it from 50 to 60% of the subsidization rate. So you may recall, for retirees, it's I think $183 or 50% of the premium, whichever is less.
Yep.
And so now it would raise it from the $183 or whatever that subsidy amount would be, or 60%, whichever is less. So it would help increase that amount that would be covered for retirees. And that's what that legislation is. And that is an appropriations as well.
Yeah, ways and means.
Yeah. So both of them are moving forward. So like we'll continue to see that one of those. Moving on. Faster medical service cost sharing. We have House Bill 1957. This doesn't do anything immediately, but what this is doing is saying, okay, we're looking at a lot of things going on in the federal government, a lot of action being taken still to try and overturn parts of or the entirety of the Affordable Care Act. 1957 takes the language that exists in the Affordable Care Act that relates to the essential health benefits that were part of the provision that said if you want to have a qualified health plan, the qualified health plan has to cover the essential health benefits as articulated in this statute or in this federal regulation that says here are the benefits you have to cover, and then every year there's going to be recommendations coming from organizations like the USPSTF, the United States Preventative Task Force. There's organizations that are looked to and say, hey, if you recommend that these should be essential health benefits that are covered, these have to be covered by the qualified health plan. Now, in state statute, if this were to pass 1957, it would codify in state statute so that if the federal regulations of the ACA for essential health benefits are overturned, we have it codified in state statute that would require all of our health plans to continue to cover those same required essential health benefits, and then would continue to have them updated per the recommendations from the same organizations that are currently looked at for the updated essential health benefit requirements. So kind of neat things. It doesn't have any immediate impact, but it would have the impact of preserving those required essential health benefits in the event that the Affordable Care Act or this part of the Affordable Care Act was overturned. And that is currently in rules, so it's made it past the Finance Committee, and then and the rule is ready to be heard at any time on the floor of the House. Then House Bill 2285, which actually didn't make it out of committee, but Senate Bill 5986 didn't make it out of committee, which is a protecting consumers from out-of-network healthcare service charges, furthering the work that has been done by our legislature in the past few years to help further expand the protections for consumers regarding out-of-network service charges. And right now my mind is slipping on specifically what this is doing, but I think regardless. Oh, ground ambulance. Okay, great. So we're continuing to expand the definition of what is going to be, how we're going to help balance the interest of out-of-network service charges, where the members really don't have any ability to control or make any choices that would otherwise allow them to say, hey, I want to make sure I'm steered towards in-network service providers as opposed to out-of-network. It's kind of like the example I always think of is the anesthesiologist. You don't really get to pick your anesthesiologist before you go in because likely you're going to be getting ready to go under. You're like, wait a second, I'd like to check if you're in network, and then you're out before you have a chance. So that one's moving forward. That one's in Ways and Means currently. And we look at pharmacy. I don't need to go over the House Bill 1884 or 5814 for metastatic cancer drug coverage because neither of those have moved forward out of the policy committee. House Bill 1979, reducing the cost of inhalers and EpiPens, auto injectors. It's reducing the cost of EpiPens, auto injectors for $35 and inhalers for $35 as well. That is moving forward. That is currently on the floor of the House. Kind of mirrors a lot like the diabetic medication cap on cost for $35, and that is on the floor of the House currently. Senate Bill 5776, this is accessing emergency supply of insulin. This actually requires the Healthcare Authority to have a supply of emergency insulin that can be purchased by anybody that has need for insulin to purchase a 30-day supply for $10 on an emergency basis. If something happens, you lose your coverage or you lose your supply or something happens, it's kind of a last resort. You can come to the Healthcare Authority and for a pretty nominal amount, come get a 30-day supply of emergency insulin to help cover your basis for it. And it has the Healthcare Authority at large, not PEB and SEB, but our agency as a whole to come and help cover that, set up a program that can help make that accessible. Senate Bill 6127, increasing access to HIV PEP drugs, increasing that legislation is moving forward. It is currently on the floor as well with the Senate for further consideration. And then the last bill I have 6182, providing commercial coverage, just having all of our insurance coverages for diabetes or drugs to treat obesity, particularly those related to the semaglutides like Ozempic and those ones that you see a lot of the advertisements for. I mean, I see them a lot. I guess Facebook knows me a little bit if they see me. But that actually has died. The costs on it were pretty substantial, which I think is probably why it's not moving forward. And I have to continue to see that in years to come. But where prescription drug coverage for treatment of obesity is going to land in years to follow. More conversation. That's the end. I'd happy to take any questions. Let's see, Dave, did I do?
Great. I didn't say 2 o'clock, but I was hoping you'd be done by 5.
Is there did I have a moment for a personal privilege? Sure. I just wanted to, well, yeah, could I take a moment for one personal privilege? I just wanted to acknowledge it's February 1st and it is the start of Black History Month. And I found a really great book on the history of Black people in Thurston County. And there's a really interesting story about a gentleman named Avis Dennis, who was the first Black person to graduate from the University of Washington with an advanced degree in engineering, who also happened to be the first person of color to get hired by the state of Washington with an advanced degree in engineering. He worked for the Division of Tolls and Bridges after he served in World War II. That was a pretty neat thing. He lived here. He lived after he had been stationed here at Fort Lewis. He lived here and died here in 2000 after having worked in the state for 40 some odd years, almost in the same division, bounced around a little bit, worked in Tacoma and Seattle, but lived almost his entire life after his service in World War II here. So Avis Dennis and his legacy that he leaves here in Washington. I always think it's kind of fun to learn little new things about things, especially as we kick off Black History Month. So thank you for that
And we
opportunity to
opened
share.
with our equity theme, so thank you. If you'll get the name of the book, we'll get it and circulate that. to board
Yeah, it's
members.
literally
That's right.
Blacks in Thurston County, 1940 to 1975. Great title. Thank you.
Thanks to both of you. All right, we are moving on to procurement and benefit planning cycles. John Parton, who is our benefits strategy and design section manager in our employees and retirees benefits division, is here to remind us of the procurement benefit planning cycles for the PEB program. John's online virtually. John, hello. And the materials are behind tab 9. Over to you, John.
Thank you, Chair Birch. Hello, everyone. As Chair Birch mentioned, oversee the groups that work on the benefit planning cycle in particular, but want to briefly touch base with everyone and a few reminders about these two different cycles and how they're different and the same. So we'll run through that fairly quickly and then try to leave the bulk of the time that we have in this presentation for the board to give input as to what types of benefits you believe we should be focusing on. So if we go to the next slide, please. Start with kind of how we develop benefit designs and different parties that can influence that. We like to start here at the board, obviously, given your connection to the constituents that you represent, and that's why we solicit your input at the beginning of the cycle each year. Although there are many opportunities throughout the year for these various stakeholders to provide inputs. And so I've listed them out here, not to belabor the point, but what's in the middle is kind of the deciding factor, right? The piggy banks, it's the money. If there's funding to support supplying a benefit or providing a benefit, that's what really drives these processes. And you'll see it when we look through the processes briefly, that it's integral. That part of the budget development has to be there to support the things that we do. And if it's not, then it doesn't mean that the idea dies and withers on the vine. It just, we come back with it, we keep working on it and trying to find ways to make it relevant and more useful and hopefully more cost effective. So if we go to the next slide, please. We'll see the first of those two cycles, the renewal cycle, contract renewal cycle. The component pieces of these two processes are very similar. We're generating ideas, we're developing those ideas, we're submitting proposals for funding consideration in the budgets, and we're getting inputs from the legislature, sometimes from the board members, and from the federal government, right? But generally we follow this process, and it takes, for both processes, about 18 to 24 months. And it's because of that, getting the ideas, developing them, and then putting them through that budget consideration process. That's what takes the time with these. And so that's one of the things I really want folks to come away from, is that there's a reason it takes us some time to get from idea generation to actual implementation. And this just kind of details the component pieces of that process. But again, 18 to 24 months from inception. Now, this one is a year earlier in implementation plans. That's one of the things I hope folks come away from, is that for the procurement cycle, the renewal cycle, what we're talking about now would be for a 1/1/2025 implementation date. So we really started on these in the summer of last year as we were wrapping up last year's board season. So if we go to the next slide, we'll look at the benefit planning cycle. again, very similar constructs, but one of the two real differences I want folks to come away from this one, because it's a year farther out into the future, and I'll talk about why that is in just one moment. We're looking at implementation dates of 1/1/2026. And one of the key differences between these two processes, the one we just saw in the procurement renewal cycle, by definition, it's a renewal, right? We've already got a relationship with the payer or the vendor who's offering that benefit. And so there's not as protracted of a process to go through, whether it's a full procurement or it's getting a vendor reviewed for inclusion in one of our existing relationships. It's a little more complex and takes a little bit more time because we're starting literally most times from ground zero. And there's some contracting work that has to happen there, et cetera, from, full contract negotiation as opposed to we're renewing and making changes to an existing contract. So key difference there, and that's why we have this difference in the implementation dates. But origination, consideration and development, the budget process, and then going through to implementation is identical, but those implementation dates are a year apart. So I'll pause there. There's a lot of information in those two overviews. I know some of you have heard it several times. And before we go to that question slide, any questions about the process themselves before we have a little bit of conversation about your ideas from the board members that we should be paying attention to this year? Okay.
Getting any signals, John? No questions.
Okay, then yeah, the real crux of what my teams and I are looking for are your inputs from the board. What modifications or additions, whatever it might be, you believe we should be paying attention to based on what you're seeing and hearing from your constituents. So I'll open it up for input then.
This is the time of year that we can throw out ideas to ask staff to go forward and examine and bring back more information. Kayla, I see your hand up.
Yeah, so kind of three things that have been on my mind, all kind of equity and accessibility related. One is around kind of partnering to figure out how we can get more like at-home testing and screening, just thinking especially about our workforce with jobs where they're not able to leave or they have to take leave because they don't have the flexibility. Kind of more around behavioral health, specifically around kind of on-demand 24/7 care, recognizing that a lot of times when people have a behavioral health episode, it's like in the middle of the night when things are closed. And so trying to figure out how we get more accessibility to that. And then exploring the concept of health navigators to help people who don't know how to navigate the healthcare system, that one-on-one support.
Thank you for those. John, I'm sure you captured those.
Yep, I did. Thank you.
Tom, go ahead. You're up next. You're unmuted.
Yes, and perhaps this is not, I'm not quite sure where to ask this question, whether the venue would be in actually the next presentation or with John. But last year we heard quite a bit about that CMS is going to be able to negotiate Medicare drug prices with 10 categories of drugs or 10 specific drugs. I remember that Eliquis is one of them. Has there been any kind of analysis done of what kind of impact that would be on the cost of our prescription drugs as it factors into whatever plan we end up with?
John, I can answer that one if you'd like.
Sure.
So Luke will go over this to some extent in the next presentation, but one of the differences between the pharmacy benefit that's in UMP Classic Medicare today is that it does not benefit from the Inflation Reduction Act price negotiations that CMS will do on those 10 drugs or any future drugs. However, a benefit if the board proceeded with the idea that or option that's being presented in a few minutes to a Part D formulary, then there would be that Part D formulary is subject to and is impacted by future price negotiations by CMS. So the easy answer is that today's structure of UMP, there is no specific cost analysis because the Inflation Reduction Act doesn't apply to creditable drug formats like UMP Classic Medicare has today. And we'll kind of hold the rest of that for Luke in an hour-ish.
Thank you. Go ahead, Elliot, you're next.
Thank you. You can, whoever answers can wait till the next presentation, but I thought I'd follow up on what Tom said. Another aspect of this is merely a question, is that you have the Prescription Drug Affordability Board. And thank goodness we have Michael Tunick here, who's counsel to that as well. I see that as perhaps helping lower drug costs also. And might there be a benefit from being able to coordinate with them?
So we will take that recommendation that John and Dave continue to monitor. Kind of, are there next policy steps with reducing drug costs? I don't believe PEBB will have actionable steps in the next 12 months, but it's because getting data continues to be such a big pursuit. But Dave will add that to the list of things.
So Elliot, maybe long-term, but there's not any short-term glide paths for leveraging the Prescription Drug Affordability Board at this point. But we can put that on the radar for describing some more. That isn't part of our next presentation either because we're.
Yeah. But I would like it on the radar. Thank you.
Perfect.
Dave, I would just ask that you and John continue to closely monitor the hospital at home advances and what that might mean for also commensurate home care or other types of home community-based services that would need to wrap around those shifts. So just something for us to keep our eyes on to see if there's some additional services that we could have as alternatives or options. What else? This is our time. New benefit ideas.
You can give ideas at any point. Now's a particularly great point in the cycles, but anytime you can give an idea and it will just insert it where it fits in the flow.
Yeah, and just to tag on to that, Dave, anyone feel free to email me with those ideas at any time. My team and I are always open to hearing those and taking a look at things. We certainly don't have a corner on all the great ideas, right? So we're happy to hear what folks are seeing or thinking.
And John and Dave, I know you were both listening carefully to the equity and DEI presentations, but anything more we could be doing to advance? And I can't point to a specific benefit or a concept, but I know there is a lot of innovation starting in this area. So I hope that's just an area we will really continue to think about. So can
We're working on having personal mics like we used to.
So I am mute, so I'm not sure what I'm saying is relevant to what's being said here, but some more work that we're doing, research that we're looking at is looking at school nurses and the extent to which they're supported in situations of active shooters. What I mean by that is that they're the key players that are looked on when that issue arises. However, they're not aware about how to address, there's not a playbook, a toolkit, in terms of how they proceed. And I think a lot of school districts are not sure either. They're still working out the details. I don't know if it's all working, but I do know that a lot of school nurses feel that they are not guided enough in terms of what to do in those situations. And so I just wanted that to be, it's open, but certainly under consideration.
Well, I mean, you could frame it under, is there some sort of gun violence benefit that we could provide to public employees that Seb would pick up? But I'm not, I mean, that is interesting in the social realm of things that are shifting. Also, are there any other efforts being made in climate change? So in these very socially volatile areas, what what are we thinking about doing to add more benefits or support? So can't think of any yet, but the direct funding to school nurses and education is a different avenue. It doesn't necessarily, I mean, we could think about it through employee assistance or, so if this is the kind of stuff we just give to Dave and John and say, you guys go figure out, innovate, and see if there's anything that we can purchase or to layer into our benefit design. Harry, you got anything?
Not today.
Okay.
Okay, on that note, I'll add one more then, if you're gonna, just, and like the idea of financial wellness connected to and things around, specifically like thinking about new employees or employees with lower income and debt and around kind of same day pay or opportunity to get advanced pay. As, I don't know if that would fall into this type of benefit, but.
So I think, Dave, I would bucket that as what more could we do around a supportive employment? How do we help move our families that are not in livable wage households? What sort of extra financial counseling or extra coaching could they get to develop kind of a path towards a more successful livable household? Which is a great idea.
Thought I had was maybe there were some ideas that aren't necessarily relevant through the PEB benefits determination kind of role, but maybe could cross into the smart health ad where something doesn't fit here, the idea fit on smart health. That makes sense. You know, maybe the financial wellness might be some areas there, some notions, some ideas that could then be platformed over on smart health and be made available to people. That's a 25, 30,000 people. I don't know what the stats are on that.
We'll have a presentation on that next month.
Right.
Because that's
And I also have responsibility for that team, John. Sorry, I didn't mean to cut you off. So we do cross-pollinate the ideas between those two groups pretty frequently. So yeah, it's a great call out.
All right, I think we've given you some things to ideate on, John and Dave. So with that, thank you, John. We are gonna take a quick break to
Come back
stretch.
at 2:25, that's 6 minutes.
Back.
We'll only be 10 minutes behind that. And we're gonna stick to 6 minutes this
We're
time,
gonna keep galloping along.
because I know that we have retirees who
All right, we are gonna go ahead and get started again. For those of you that might have just joined, this is the all-day PEB board retreat. And we are now gonna move into our next agenda item. The PEB retiree Medicare benefits legislative report summary and the 2025 UMP plan option. Our very own Ellen Wolfhagen is our retiree benefits manager in the Employees and Retirees Benefit Division. Molly Christie, our fiscal analyst in the Financial Services Division, and Luke Dearden, our clinical pharmacist from the Clinical Quality and Care Transformation Division, are coming together today to give us a summary of the PEB retiree Medicare benefits legislative report, and to also provide some information regarding a UMP retiree plan option for the upcoming year to respond to that plan's rising premiums. Materials for this presentation are behind tab 10. And I do want to remind folks that we will be taking public comment after this 90 minutes of presentation. So please, if you're here to provide public comment, wait patiently. We will be getting to you. Ellen, I believe I am turning it over to you to begin. Welcome.
Thank you, Chair Birch. I appreciate that. And the board, as Chair Birch said, I'm Ellen Wolfhagen, the Retiree Benefits Manager in ERB. So next slide, please. Today, we're going to talk about the December 2023 legislative report and also introducing an option for reducing UMP Classic Medicare premiums for 2025. We'll go over the structure of that, the finances, and clinical insights. As sort of a preview of things, one of the questions that we have is, does the board want to move to a resolution to begin considering this for the March 21st meeting? So that's the bottom line here. Next slide. Just to give you some background on the retiree engagement updates in the past year, 2023 was very busy for us. We had listening sessions, webinars. I created a inbox for emails. We set up a retiree engagement webpage that includes frequently asked questions and common myths. We've always had some retiree-specific newsletters, especially during the open enrollment period, but we're also looking at creating retiree-specific editions during the year so that we can have more information. This is something that we learned about during the listening sessions, that retirees felt the newsletters had a lot of information that was not pertinent to them. We updated the format for the retiree enrollment guide to make it a little bit easier to understand. As you heard from Alyssa, there were more benefit fairs this year. There was much more HCA representation. And then I also wanted to point out that both Dave and I did DRS podcasts, as well as Kelsey Pelly did one on the FSA and DCAP program. Next slide. So the legislative report was part of the engrossed substitute Senate Bill 5187, 2023. And we were asked to gather member feedback and provide an analysis of government self-insured plans with benefits that are equal to or richer and with more affordable premiums than the Uniform Medical Plan Classic Medicare. Next slide. In terms of member feedback, we had these listening sessions. There were 24 sessions from February through May. We had 3 public forums. We had a total attendance of 225 participants. It was a mix of online and in-person sessions. I will just note that the online was much more highly attended than the in-person sessions. Most members had very positive things to say about their plan and also identified 1 or more challenges. I'm going to go into some specifics in a minute. And the summary notes for each session are included in the legislative report appendix, and the report itself is also available.
Just want to highlight that appendix to the report, the very next to last page, is a list of hyperlinks, and all of those are hyperlinks. A variety of people have asked where additional information is. There's about 400 additional pages of content if you go into the appendix and just click the different hyperlinks. Over 200 pages are the summary notes of the listening sessions themselves. There's a Milliman analysis that many people have found particularly interesting. All of that is embodied within the roughly 80-page substantive analysis of the report, but that appendix is quite robust and you access all of those materials via the hyperlinks in the reports appendix.
Thanks. In terms of the specific feedback, what we heard on Kaiser Permanente was that the plans offer good coverage for an affordable price, but provider availability is limited and wait times to see a provider, as you've heard before, can be long. For Premier Plan F and G, and again, Plan F is closed to new enrollments, so Plan G is the current plan. Members appreciate the coverage affordability. It is our least expensive plan in terms of premiums, but they wish that the plan covered additional benefits, especially gym memberships, hearing aids, and naturopathy. For the United Healthcare Medicare Advantage Part D plans, MAPD plans, members like the affordability of it. And they like having some of the additional benefits, for example, massage and gym membership, but there was frustration with customer service and pharmacy copay costs. I do want to note that January 1, 2023 was when we switched the MAPD plans from co-insurance, which is a percentage for pharmacy benefits, to copay, which is a flat dollar amount. So there was a lot of churn in that area. And then on the Uniform Medical Plan, members spoke highly about the quality of the coverage and customer service, but they feel the plan's costly, although a lot of members expressed that the coverage is worth the cost. Some specific, next slide, please. Some specific UMP feedback. We heard loud and clear, preserve UMP Classic Medicare as a plan option, but don't reduce any benefits. However, do what you can to reduce the premium, which is currently $523.94 per month for each person. We are asked to retain or increase the state-provided explicit subsidy of $183 or 50% of the premium, whichever is less, as Kate expressed. And as you know, this is in the governor's proposed budget. It is something that's under consideration right now. And also we heard work to get federal subsidies for UMP, similar to those that are available for Medicare Advantage plans. And just a note, those federal subsidies are also available for Part D plans. Next slide. In terms of the analysis of the 50 states government plan offerings. First of all, I want to note, these are only the plans that were looked at that are available for public employee retirees. So some states don't have any coverage for public employees, retirees. And what we found is that there is a wide variety in terms of plan costs, in terms of benefits, in terms of plan options, which is structures of plans, what kinds of things are offered. No other state was found to have benefits equal to or richer than UMP Classic Medicare with lower premiums.
Sorry, can you repeat that?
Yes, no other state was found to have benefits that are equal to or richer than UMP Classic Medicare with lower premiums. So there might have been plans that have benefits that are equal to or richer, but they cost a lot.
Can I ask a clarifying question on that? Is that just like a straight up cost, or is that accounting for like lower cost of living in other states? Like
The straight up premium cost. There are 6 states altogether. Let's see if I can get the math right. There are 6 states altogether that have coordination of benefit plans that are similar to the UMP Classic Medicare. 4 states besides Washington, so 5 of the 6, have pharmacy coverage. Of those 5, 3 offer Part D coverage, and that's Montana, Virginia, and Wyoming. Mississippi, which also has a coordination of benefits plan, does not cover pharmacy at all, and Florida is the remaining state.
That, like Washington, has credit. As you're about to go into, sorry.
That's okay.
I forgot the sliding system.
So here you can see that in terms of the pharmacy coverage, Florida is creditable, as is Washington State. Montana, Virginia, and Wyoming have Part D coverage, and Mississippi has none. We also looked at vision hardware and hearing aids, which are benefits that are in UMP Classic and from which we've heard a lot of positive feedback. And you will see that they're not covered for most of the plans. And what is covered is usually included in the medical coverage. It's also worth noting in the far right column that there are very few states, just Washington and Wyoming, that actually have a contribution to the retirees' premium.
Oh, just quick one on Mississippi. I don't like to be like that, but so they basically what they do is cover medical and say, Part D, you gotta go get it out.
Correct.
Right.
Correct. You're on your own for buying.
It could be, for a lot of people, less than maybe in a publicly provided plan.
It could be, but it means that there's wide variability in the plans that people are obtaining. Next slide. So in the report, we looked at strategies to lower the UMP Medicare premium. The goal was to retain UMP Classic Medicare as a self-insured plan option, but lowering the monthly premium. The levers that are available to the PEB board are shifting the creditable prescription drug coverage to a self-insured Part D employer plan, which would receive federal subsidies and manufacturer discounts, which would significantly offset claim costs. Or we could reduce coverage levels, which would increase member cost sharing. So that's a way of shifting the responsibility with payments. The legislature has the authority to change the Medicare explicit subsidy, as was pointed out earlier. However, significant investments would be necessary to achieve affordability for a greater share of PEB retirees.
Carolyn, I apologize to interrupt you, but you say significant investments. Do we have a range there? I mean, are we talking a couple 100,000? Are we talking millions?
Tens of millions, if not starting to get into the range of 100 million or more.
100 million or more. Okay, I wanted to understand the magnitude of what that significant investment was. Thank you.
I'm going to use the word significant later, and it's not that same significant, so I just want to point that out. That's the big significance. Okay. The report looks at pharmacy and medical coverage options. We evaluated several pharmacy and medical alternatives to determine potential premium impacts. Option one is a change in pharmacy benefit design that would have shifted some of the cost share more to the members and less to the plan. It was discussed in April of 2023 at the board session, and it had very minimal impacts on premium itself. Option two would be a transition to a Part D plan that has significant, smaller than $100 million, premium impacts. And that's being presented today for further discussion and direction. And then option three would be making a change to the medical benefit. As you know, in UMP Classic Medicare, Medicare pays primary on medical, the plan pays secondary, and it's a coordination of benefits plan. There could be potential tweaks to that design that could be explored further with direction from the board.
And briefly, I'll just say, people may wonder, well, the rest of this presentation really focuses on option two. Why just option two? As preview of coming attractions in here, we know and have discussed for years about how the drug component of UMP Classic Medicare has been what is driving pieces. So option two is focused on pharmacy. And as we were looking at the Milliman preliminary analysis of the potential magnitude of the financial impacts of that type of switch to a Part D, it represented a potentially large cost opportunity, whereas the medical piece just simply isn't as large. It doesn't mean that we can't have a conversation about option three at some point. It doesn't mean that that is off the table in any way, shape, or form if people want to have that conversation, but to try to provide and be responsive to the immediate relief that retirees are seeking. This seemed on its face at first to represent the best opportunity to balance all of the interest. And that's really why the focus is on that for the board conversation right now.
Ellie, go ahead.
Yes, I just thought to refresh people's recollection, what does creditable prescription drug cover? What is it? And how is that different from a self-insured plan, Part D? Not
So-
everyone knows this off the top of their head.
That's a great question. Thank you for reminding us to bring everybody to the same level. So first of all, creditable drug coverage means that it is at least as good as Part D in terms of being economical and efficient in terms of coverage of different types of drugs. But it is not a Part D plan. So Part D, and I'll go into this in a little bit, or Molly will, on how Medicare works with pharmacy. But Part D was created to provide pharmacy coverage because traditional Medicare, which is Medicare Part A and Medicare Part B, does not have any pharmacy coverage at all.
Right.
So if you don't have pharmacy coverage, you need something, and the creditable drug coverage was created to inspire employers to have drug coverage at least as good as what's available under Medicare, which is the Part D plan. Whether a Part D plan is self-insured or fully insured is a question of the funding of it, not the design of it, and really doesn't make any difference. Does that answer your question, Elliot?
Yes, thank you. I know that everybody doesn't work with these terms all the time.
Absolutely. Okay, next slide, please. So as Dave just said, the reason that we're looking at option 2 is it offers the potential for the greatest premium savings for members. It would take advantage of the federal subsidies, which is something that we heard people were very interested in, and the drug discounts that are coming as part of the Inflation Reduction Act and the negotiations that CMS is engaging in. It would provide coverage that is like the current coverage offered through UMP's current creditable drug coverage. It would have the least disruption to members. But there is a very short decision-making timeline if the board decides to move forward for 2025. So I just want to point out that if the board doesn't do anything or decides not to go in this direction, in 2025, we have already predicted that there will be premium increases again. So this is a way to put a speed bump in that process to keep the trend going in a different way. Next slide, please. So Part D, as I said, is regulated by Medicare. MODA, which is the current administrator of UMP Classic's pharmacy benefit, would still be the administrator. The Part D would be embedded in a single UMP Classic Medicare offering. So UMP Classic would become UMP Classic coordination of benefits in terms of medical with a Part D pharmacy plan. Medical coverage would not be changed at all, and the member experience would be virtually the same. And Luke is going to talk more about that in a few minutes. Next slide. As I said, there's a very short timeline on this, and this slide is the details about the decision-making timeline. So the presentation is today. We will engage in public education and member feedback opportunities throughout February and hope to have board discussion and perhaps a resolution being introduced at the March 21st meeting. Board vote would have to be no later than the April 11th meeting in order to meet the deadlines for required filings with CMS. All Part D plans have to be filed with CMS and approved by them, and the time frame for that is late spring. We also need the time to do rate setting and to be able to finish implementation so that we could actually stand up the plan for a January 1st start date.
Alan, I'm just going to add in, I know that this will feel like a very aggressive timeline, And I just want to reinforce that this is not an idea that that the agency is trying to rush or force upon anyone. We're really just acknowledging that in order to have an impact on 2025, this is the time. If the board isn't ready for that, or wants additional information, that's certainly the choice that is before the board as well. It just simply, 2025 would be a very similar experience from a premium standpoint to what UMP Classic Medicare retirees have experienced for the last couple of years. I thought it was really important to me since last board season that when we came back to the board, that we had something that we could present to you where you could have the ability to take action for 2025. I did not want to come back here at the board retreat and say, got nothing for you for 2025. The best we can do is 2026. This is an option for you for 2025. And I do believe I said one of my parting words in July was the agency is not going to make any decisions. We're going to keep doing what is necessary to keep options on the table. That included helping the governor's office have language in the supplemental budget that at the point in time we thought that the RDS might still be available would give this board authority and things like that. So no decisions have been made. The decision is squarely in your court. But the acknowledgement that after April 11th, it's no longer a 2025 question. That then becomes a 2026 question.
Expected timeline, get the approval, if that's the right word, CMS.
So an important part about this, the reason that this is even available to be an option, because in many instances, there are a lot of stars that have aligned to make this option even available for 2025, is the fact that we would be still using MOTA as the administrator for the pharmacy benefit. And MOTA has experience with Part D formularies such that in order to do one of these types of plans, many times, well, you do have to have CMS approval for them. And what we'll be able to do in this instance is leverage one of MOTA's prior filed CMS. They have to go through kind of an annual renewal, but once you've set it up and you're modifying an existing thing, that's an easier glide path than getting the initial approval for Part D formulary, a Part D EGWP through them. And so we'd be able to leverage one of the existing filings, but that has a spring timeline. And I'm not sure exactly which the pieces are, but I just know that we can't have a decision from the board after April 11th and MOTA be able to hit those timelines in order to have CMS approval so that we would feel confident that when the board would then theoretically pass rates in June, July, that we would have everything aligned so that we could load it into benefit 24/7 for people to be able to make those elections of enrollment and it go live in January. It's a very short timeline, but it's only really possible because it's leveraging one of those existing types of setups that MOTA has already gotten pre-clearance in prior years from CMS.
If we board decide to go that route, we have to go dual tracks, one with the traditional way we've done it in the past and this other, just in case. I mean, is it possible it could get derailed after April 11th?
Extraordinarily unlikely. I can never say impossible, but we would not anticipate that we would do a rate build with the existing structure and the new structure. We would be all in on the new structure. Okay.
Maybe you answered this with the easier path to modification, but if we were to vote and choose now, how long would we be kind of stuck with that decision?
That's a great question. Ellen, do you want to?
Well, it's a strong word.
Or sorry, yeah,
Would be, I believe, we would give staff the direction to move forward. We would still go through a very extensive public involvement process, and then staff would develop a resolution. Then we would take action no later than April 11th.
And then I was taking from your question, if in April there was a board vote and there was a shift in 2025, then how long are we with that decision?
So every year, the Part D details, if you will, could be tweaked. But we would be creating a Part D plan and we would stick with that unless there was another option that came in front of the board and some different direction.
Okay. I was just thinking
sorry. Elliot, your hand is up. I cut you off.
Yeah, just a quick question. Is MOTA, the administrator, the same thing as a pharmacy benefit manager?
So I can answer that question. This is
This is Luke Dearden, a pharmacist. And I work with MODA a lot on the current UMP plan. MODA does perform some functions of a pharmacy benefit manager. However, they subcontract with another organization called Navitus that performs more traditional functions of a PBM, like pharmacy network contracting, point of sale claims processing and stuff like that. Whereas MODA has, customer service. They have the clinicians who review prior authorization requests, and they help us implement various clinical programs. So that was kind of a long answer to your question, but hopefully I answered that question.
Thank you very, very much.
Let's do a quick check for other questions. This will be, Ellen's not going anywhere, but she's gonna hand the microphone effectively over to Molly for the next piece.
I'm gonna just
Oh, soon.
a couple of things. One is Dave mentioned EGWIP, and I just want to be mindful of not everybody having the same acronym understanding. So an EGWIP is an employer group waiver plan. What that means is PEB is an employer group, like a union, if you will. And CMS allows employers to negotiate different benefits, different structures, different cost shares, for example, within the structure of a Part D plan. So they can work with one of the companies that provides the Part D coverage, but is as part of the employer group waiver, there are some flexibilities that are built in that wouldn't otherwise exist on the commercial market. And currently, we have a lot of people in Plan F or Plan G. They are going to the commercial market and they are buying, if you will, off-the-shelf Part D plans. The plan option that we are discussing here is an employer group waiver, so it would be a little bit different than that. And with that, I'm going to turn it over to Molly.
Thanks, Ellen. I'm Molly Christie. I work in our finance section for PEBB. And some of what you might see in my slides is it's covering some of these things again, but I think it's probably not a bad thing to hear it a few times because it is a little bit complicated. So I'm going to go over some of the financial insights. A lot of what I'm covering is touched on in the legislative report. So if you're looking for more detail, I would look first at the legislative report and then at the analysis that Milliman completed that's in the appendix. So before we dive into the details, I was going to do this quick review of traditional or original Medicare. You can switch to the next slide. Thanks. The terms are interchangeable. So when you say traditional Medicare, it also means original Medicare. And it only covers medical services. So Part A is hospital and inpatient services. Part B is doctor's visits, some vaccines if you're receiving them at the doctor's office, and then things like DME, durable medical equipment. There's no drug coverage in original Medicare. So even our Medigap plans, as Ellen mentioned, those pay the member cost sharing under traditional Medicare. So it's typically 20% that Medicare doesn't cover. But those plans don't include prescription drug coverage. Interestingly, they used to, but they are no longer permitted to do that. And so on the next slide, Medicare Part D was created as part of the Medicare Modernization Act of 2003 to provide optional prescription drug coverage for Medicare beneficiaries. And the plans were offered starting in 2006. And because they're technically a Medicare benefit, they have to be approved by CMS. Medicare prescription drug plans are offered by private insurance companies. Sorry, next slide. Or pharmacy benefit managers, as Luke kind of described, and sometimes PBMs will have subcontracts with other PBMs, but they have to contract with CMS. And coverage through Part D, prescription drug coverage in general, is optional, but it's offered to everyone on Medicare. So Medicare beneficiaries can search for plans through the CMS website. We call this the individual market. That's the commercial market that Ellen was mentioning. You go on, you say where you live, and it tells you what plans are available in your area and what the cost of those plans are. In general, for Part D, you can't have other pharmacy coverage and also enroll in a Part D plan. So for example, and this varies a lot, there's a lot of detail on the CMS website around, you know, how Part D works with other coverage. But if we're talking about UMP, we have creditable prescription drug coverage. So that means that our drug coverage is at least as generous as Part D. If you want to think of it in terms of actuarial value, you can think of it kind of like that. If you look at the total value of the plan in terms of what the member pays and what the plan pays, it has to be at least equivalent to that. And so since our plan offers creditable drug coverage, our members cannot also go enroll in a Part D plan. They would be either kicked off of the Part D plan or kicked off of UMP. You'll hear the term the standard defined benefit or the standard defined Part D benefit. And this is determined by CMS and it establishes the big plan design features. So like enrollee cost sharing, the coinsurance, deductible, max out of pocket. You've heard of like the donut hole and all of these things. Those are all established under the standard design. And the Part D plans, the off-the-shelf Part D plans typically just stick to that design. But there are plans that can enhance that design. They can offer lower member cost sharing, so you pay less when you go to the pharmacy. You can get extra drugs covered that are over-the-counter drugs, and those are like enhanced plans. When we talk about an enhanced plan, that's what we mean. Typically, I mean, almost always, those plans will have higher premiums than a standard Part D plan. So you can go on the individual market and find a standard Part D plan that's at $0 or maybe $35. They can be relatively low in premium, but that's based on that standard benefit. So there's going to be a higher cost sharing. And I just one more point on this, because Part D is a Medicare benefit, and I'm going to touch on this a few times. The plans receive federal subsidies and manufacturer discounts that cover a significant portion of costs. And this is what's historically helped keep premiums stable, even though drug costs are rising. So CMS has a reinsurance subsidy that covers really high catastrophic drug claims. Drug manufacturers are paying a piece of it, so that keeps those premiums that you see much lower.
Real quick, staying on slide 18 for a moment. I think the board knows we published the board materials earlier in the week on Monday. And Ellen and I have already received a question that I think is best inserted some insights right here on the slide. For people who have read the legislative report or go and read the legislative report and then look at these materials, you may go, well, is the idea an option that's being presented to the board the standard benefit, an enhanced benefit, or both of those benefits? And the short answer is, from here on out, we are describing a single option that falls under the bucket of an enhanced benefit. And the reality and reason why that is what is being brought to the board as an option is it makes it aligned as close as possible to UMP Classic Medicare today. We could have brought you two options, a standard option, I'll call that half a UMP loaf, or we could bring you a 99% UMP loaf. We saw no value in confusing the issue and conversation for everyone by saying, do you want something that has very different benefits, what we heard loud and clear during the listening sessions, the same or better, or something that is close as possible to UMP Classic Medicare today? So for everyone who looks at this and then looks at the report and goes, we're talking standard enhanced, we're talking an enhanced benefit that is as close to UMP Classic as possible. Back to you.
Thank you. Okay, next slide. So as Ellen mentioned, when we refer to an EGWP, this is an employer group waiver plan, and it's offered exclusively to retirees under a group policy. So the waiver part of it means that it doesn't have to be offered to all Medicare beneficiaries. An employer can choose to only offer it to their retirees. They can be self-funded or fully insured. So again, like UMP is a self-funded benefit where the state bears the risk or HCA bears the risk for the claims. So we could do that, and that's what we're proposing under this benefit, or it can be fully insured, such as under our United plan that has a Part D benefit, and that entire plan is a fully insured plan. And typically employer group plans have enhanced benefits. So they typically have lower member cost sharing than most Part D plans on the individual market. And that's an employer decision that you know, because this is a retiree benefit, that they typically try and enhance the coverage. Compared to creditable drug coverage, a self-insured EGWP can have very similar coverage with significantly lower premium. So when Dave was mentioning earlier, you know, one of the reasons why we're only presenting this option is because it offers significant premium savings. It also does that without cost shifting like the other option. So this is essentially offering very similar coverage to what we already have, but it's taking advantage of some different funding sources in order to keep it lower. So that's the protection against really high drug costs through federal reinsurance. That's the CMS direct subsidy, manufacturer discounts, those types of things, and then even more under the IRA.
Inflation Reduction Act.
Yeah, the Inflation Reduction. Thank you. And then later in the presentation, Luke will share some of the benefit design and formulary differences between what we currently have under creditable coverage and Part D. And in some instances, there's more coverage, and in some instances, it's just different. So, of course, the big question is, you know, when we talk about premium savings, is how much could members save? And I'll walk through the preliminary analysis that we reference in the legislative report next. So for the legislative report, we asked Milliman to look at the potential retiree premium savings if UMP Medicare transitioned just the prescription drug benefit from creditable drug coverage to a self-insured Part D employer group plan. And we assumed that there was no change in medical coverage and no change in the explicit subsidy. And based on those assumptions and some others that are described in that report, Milliman projected that retirees could experience significant monthly premium savings compared to what they may pay without any change to UMP. So when I say that, I mean that the savings estimates that are in the report are compared to the projected premium for that year. So they projected out through, I think, 2027. What we have here is 2025 because we're talking about 2025. So the savings estimates are compared to the projected 2025 premium for UMP without any changes. And that is expected to experience another large increase similar to what we've seen in the last few years. So next slide. So what does potentially significant mean? In some instances, it means hundreds of millions of dollars. In this instance, Milliman's analysis used historical UMP experience. So they completed this in 2023. They used historical UMP experience under an industry standard Part D structure. So they kind of took what they know about how members in our plan utilize benefits, and they put that under a Part D structure that's typical for the industry. And then they estimated what the costs would be. And so they estimated the potential for just over $200 in per retiree monthly premium savings. And again, this is compared to what the UMP premium could be in 2025, in both cases after the subsidy is applied. So after that $183 is already applied. It's important though, you know, it's a great number. We love the number, but we don't want to get fixated on this specific number because this was a preliminary analysis. And so the key takeaway from Milliman is this is the direction and magnitude of potential savings that we can expect. So we expect premium costs to go down and we expect it to be a material decrease. Exactly what that number will look like is we haven't determined yet. We have to do a lot of refinement. We have to update the specific plan design. So this is the formulary, which will be very close to UMP with some differences in the specific drugs that are covered, cost sharing, the pharmacy network. Luke will go into this in detail. We need to update enrollment. So we know that members, we did see a shift out of UMP again this year because the premiums are so high. So we have to update enrollment, claims experience, and other projection factors. And that would all be built into the rate. And then there are also final rules that Ellen mentioned, Part D. So CMS comes out with final rules on new methodology each year relating to Medicare Advantage, so Part D and Part C and Part D. And they just came out with the advance notice yesterday. The advance notice essentially says, this is what we think we're going to do, heads up. give us any feedback you have, and then a few months later, they say, okay, we've finalized, this is what we're actually gonna do. Usually, there's not much of a change between the advance notice and the final notice, but sometimes there is, so we would need to wait for those final rules. And then there are also some final rules related to the Inflation Reduction Act that could have material impacts on payment methodology for Part D. So our plan is to present more refined saving estimates at the next board meeting with some of these updates. These won't be final rates, so it will still be another number that gets us closer to the final number. But that final number will still be on our typical rate building timeline, which is May, June. We have to get final run out and, we need these final rules and to update some additional projection factors that we just can't do right now.
Molly, I need to restate this to you and tell me if I have it right.
Okay.
Our federal partners are signaling certain permissions, but those rules will not be finalized. We know that if we do nothing, our premiums are likely to go up.
Yes.
We have an opportunity to try to save some money on the pharmacy side, but net, it sounds like at best, we might be able to hold steady so that we don't have cost increases to our seniors. Is that correct? Is that what I'm hearing you?
Not quite. So if we do nothing, we're anticipating that premiums will go up in a similar magnitude to what we've seen the last couple of years.
So premiums over here.
Yeah.
Health piece go up.
If we shift the prescription coverage to Part D, we think that the premiums would be, after all is said and done, after the subsidy, $200 less. But I don't know where the net.
Well, I wanna be careful because I hear you kind of saying we might be able to help our retirees by reducing.
Yeah.
By 200, and if their premiums were going up and we're just holding, if they're gonna be going up anyway, but now we get them, obviously some gain by bringing their drug, we get the same or better drug coverage.
Yeah.
It kind of nets out, so at best, we would be holding so that we weren't increasing.
I don't think that that's the most. I don't think net steady is the best outcome.
Okay.
Lower actual net reduction is a possibility. That's a decent possibility, a good possibility. I want to reinforce, we can't get fixated on the number $200.
That's what
But the directionality of what we know today and where things and refinements are going is not that everything would net out to status quo, but net to actual lower premiums that retirees experience on a month-to-month basis in 2025.
I do feel
Great, I
confident
just
there
wanna
will
be
be a
really careful that we
Yeah.
aren't, that, there's just so many moving parts here that have to happen with Milliman, with our federal rules and this approval process, but it sounds like you all are bringing forward a significant proposal that you're asking us for permission to keep studying, keep detailing while we move forward, because otherwise, come April 11th, we do nothing, premiums are going up.
Yeah.
Status quo, no action, nothing, premiums will go up. With action for 2025, the net effect we anticipate should be lower. It's the question of the magnitude of that net lowering, but all signs in that change world to a Part D are lower after accounting for what would have otherwise been the increase with no action.
You may have covered this earlier, and I apologize for being out. Would this be available to Medicare Supplement Part Plan G? It wouldn't be, okay.
No, it would still be embedded, kind of like today. So even today, the pharmacy benefit is through MODA and the medical benefit is through Regents. It would be the same. It would just be MODA has a
I get a lot of
contract with
requests
Cigna.
for,
Yeah,
wish we had Part D separate.
like a separate Part D. Yeah, that's not part of this.
That
proposal.
conversation can happen In the future, we were trying to be squarely focused on the problem before us, which is the integrated, embedded UMP Classic Medicare costs.
Kayla and then Harry.
Yeah, so I might be missing something, but if today the question is, should we keep studying this? Why wouldn't we say yes? Or like, what's the downside to not, like, aside from you might be wasting your time?
There's I'll call it small number of prescriptions and member impacts that Luke's gonna describe. And that's really the largest type of thing on the con pile is there are some members with some prescriptions, but it is not in any way, shape, or form the vast majority. The vast majority of individuals see no difference other than lower premiums and lower out-of-pocket expenses when they pick up drugs. It does sound too good to be true. That's really, I think the spirit of your question is, how is this possible? And it's because of leveraging those different federal subsidies. It comes with, you've got to follow a Part D formulary that CMS has approved.
Yeah, but we're not voting today, so it's more just the question of like, why wouldn't we say, keep going forward and studying this, even if there is a potential downside to pursuing Part D? I guess that's the question.
And I think we wanted to be very deferential to this entire conversation, knowing the backdrop of how we got to where we are today was a journey with the retiree community that started in summer of 2022 with a very different proposal that no longer exists, and I won't even describe it anymore. And so that in that space, we wanted to make sure that we were continuing to present an option to the board. And I almost hesitate, your use of study downplays where we are. You know, we have things in motion, and if you're like, actually, this is the worst thing since sliced bread, please don't bring this back, then we would pull the plug on a lot of different work streams. But we wanted to make sure that we were understanding and not overstepping and appearing to have made a decision on behalf of everyone in this instance.
Yeah, I had just two questions. In the first one, if it's can't be answered, it's too complicated, take it offline, you and I can get together, whatever. Had to do with how Milliman arrived at the $200. Did he do it based on actual claims history, or is it some other process?
That's a good question. They did it based on our actual UMP claims history.
That's the answer I was hoping.
Yeah, and then they have a tool where we have a different tier structure. We have kind of a unique tier structure for our current drug coverage. And so they had to take the utilization that's under that tier structure with those cost shares and then transfer that into the Part D tier structure, which is different. And that is based on kind of an industry standard and supported by like several million lives and a lot of experience supporting that. So they had to do it. It was like a formulary transfer analysis, and then it gave us
the key for me was that they did it off the claims basis. And the other question I had has to go back to the assumption about the ongoing use and authorization of explicit subsidy. And my concern, interest would be at some point the legislature, whoever said, hey, you got this great savings over here, guys. We'll split it with you. We'll take $100 back here. You know, and so is that assumption valid for?
Larry, it's like you've worked in state government before. Sometimes that does happen. The legislature does do things like that.
The reason why I planted that out here is it could happen. You got this great savings, and then you guys took it away when actually it was somebody else took it away. So I think it's safe to say this assumption is for 2025. But beyond that, it's fair game, I suppose. Thanks.
That is wise counsel.
right.
And I do believe we have Tom and Elliot's hands raised. So why don't we start with Tom?
So I just want to summarize here. If we do nothing, if we ignore switching to this option, we would anticipate that our rates would go up again in some way as they have for the last 2 years. But in addition to that, if I'm understanding this correctly, we would also no longer qualify for the federal retiree drug subsidy, which also would have a negative impact on our subscriber dues.
The loss of the RDS would not have a direct impact on member premiums. The RDS goes into the state general fund, so it's there's an indirect path, but it's not built into our rates. But you are correct that the premiums, we are expecting that the premiums will increase in a similar magnitude as we've seen.
Right, but Dave also said that money that's generated from that would no longer be there. So that money, even though, as you say, goes into the general fund, that money would not be going into the general fund, correct?
Correct.
And that would just make the legislature and governor's office budget proposals $20 million harder to solve.
Okay.
General state operating budget, not specific to PEB Medicare premiums, or they could choose to select it in any given way, whether that's a reduction of some idea somewhere that exists somewhere else, or not funding a new enhancement somewhere, or launching a new program, that it doesn't have a direct path to immediately impact the premiums that a PEB retiree pays for a Medicare product.
And then the other piece of that, and I know I'm sounding a little bit like a dog with a bone here, but we have talked about the CMS being able to negotiate certain drug prices. If we were to switch to this option, the projected decrease in subscriber dues do not yet factor in the ability of CMS to negotiate downward the price of 10 specific drugs. And in each subsequent year, if I understand the way that law works, there will be 5 more drugs added to it. So over the course of the next 3 years, there would be another 15 drugs added to the 10 that will be in the initial projection, so that those negotiated drug prices that CMS is able to negotiate would depress downward some of the costs of drugs, prescription drugs.
Yeah, Tom, this is Luke. You are correct. The potential for savings that results from the Inflation Reduction Act drug price negotiation hasn't been factored into any of these estimates. The first negotiated prices go into effect 2026. And then, like you said, it increases to 15 drugs in 2027 and 15 drugs in 2028. And then I believe it's 20 drugs after that. So everything you said is correct.
And that's what we mean kind of by, I'm going to coin a new phrase, protective pressure. That protective pressure of the downward pressure, as you were describing, Tom, exists in a Part D world, but not in the current credible coverage.
Right.
Okay, thank you.
Elliot?
Yes, Dave, correct me if I'm wrong, but someone asked, well, couldn't you study this for another year? What would we have to lose? I guess what I'm seeing is the potential for lower, let's see if I say this right, net premiums. And presuming for the moment that the explicit subsidy would be lost, as drug prices have gone up, and this is what HCA has shown in previous presentations, as these drug prices go up, the effect of the explicit subsidy is less and less over the years. So to me, what it looks like is that members would be paying more for their drugs because premiums would keep going up. And so it appears to me that they're going to lose money.
I don't think I have anything to correct. You started with that. Am I correct, Dave? And I think you are correct in what you've described. And to your main question, what is the risk of studying for another year? Premiums would go up similarly to the magnitude that they have in each of the last years. We will likely then have an additional several thousand members who have an inability to afford this higher premium that then would leave UMP Classic Medicare and further exacerbate or accelerate the premium challenges of this plan. If the board were to act to move to a Part D, we have all of these downward and sometimes protective pressures built into future years that could help stabilize UMP Classic Medicare from its current trajectory, and may even be able to be more affordable, that those individuals who want to return could consider returning back into UMP Classic Medicare, which is a theme that we also heard in a listening session. So I think that's the extra context I can add, and Molly wants to refine or add.
Well, I wanna make sure, I thought I heard you say that members would pay more under the Part D, either pay more out of pocket when they get their drugs, or that they would pay more in premium. So I wanna just make sure, because Luke will go into this, but overall, we're not anticipating that there would be a higher cost to members on average under Part D. There would be lower premiums.
And I think that's correct, and if I misunderstood Elliot, I thought you were opining in a world in which things stay exactly the same.
Correct.
I think we need to hear from Luke about where this next section, so we have more definitive information, and then we'll come back to more conversation. Does that sound good?
One more slide for Molly, though.
Oh, sorry,
I mean, I think we've covered it pretty extensively. This kind of is just hitting on those subsidies again. So under Part D, we would be receiving different subsidies for the plan that offset claims costs and reduce premiums. But regardless, we're not looking like we're gonna get our DSP.
Hi, Luke.
All right, great.
Man of the hour.
Yeah, it's a pleasure to be here today, and today I want to continue on with this presentation by really going into more detail about what members could expect switching from the UMP current formulary to the Part D formulary option. And this is the outline of my portion of the presentation. I'll spend most of the time talking about the Part D formulary option. And then I'll spend a little bit of time talking about the Part D pharmacy network and how it compares to the current UMP pharmacy network. So next slide. First, back to the basics though. I wanted to refresh everybody on what a formulary actually is. So it's a long list of drugs or products covered by a health plan, typically separated into several tiers with different cost shares. And to give you an idea of the scope, the current UMP preferred drug list covers approximately 2,300 products, so a pretty long list. It's really important, though, to realize when you talk about formularies or preferred drug lists, is that they're living documents and they change very frequently, often weekly, due to market changes and other clinical factors. And some examples of these factors are new drugs coming to the market, new generics, drug recalls, or just general drug price changes that require attention. So this means that even under the same plan, limited member disruption is inevitable throughout a standard plan year. There's not much we can do to get zero disruption. Next slide. So now that I covered formularies in general, I wanted to talk a little bit more about Medicare Part D. Medicare Part D is required to provide comprehensive prescription drug coverage. At least 2 drugs from each therapeutic class must be covered under a Part D formulary, although oftentimes it's more than that. I also wanted to point out here, which Tom has already brought to our attention, is that the Part D plan will benefit from drug price negotiations per the Inflation Reduction Act. The current UMP plan would not benefit from those drug price negotiations. So the second bullet point here is that substantially all drugs in a protected drug class must be covered by a Part D plan. And I believe this board has seen these protected drug classes before. They're listed on the table on this slide. For drugs not covered by Medicare Part D plans, covered therapeutic alternatives are required. And to remind everybody, a therapeutic alternative is a drug that is not chemically identical to the requested drug, but is very similar in safety and effectiveness. And I'll note here too that switching to a therapeutic alternative does require a new prescription from your doctor. That's not just related to Part D plans, that's true in general. And then an exception process must be available for members who have already tried or cannot use covered alternatives. So that's similar to how to UMP as well. Next slide. So moving on to specifics about the benefit design for the Part D plan option. I wanted to point out here that the Part D prescription deductible would be the same as the UMP current prescription deductible, which is $100 per member. And also that deductible does not apply to most generic medications and vaccines. So very similar to UMP there. Similarly, the Part D out-of-pocket max for prescription drugs would be the same as the current UMP out-of-pocket max. That's $2,000 per member. And related to the Part D plan, that $2,000 is because of that Inflation Reduction Act, which will go into effect 2025. Next slide. So continuing on with the cost share structure, this table outlines the cost share differences between UMP and the Part D option, which is in that third column there. The far right column shows the percentage of prescriptions for UMP in plan year 2023 that were dispensed according to each one of those categories. So I want to point out 4 main points on this slide, so bear with me here.
And real quickly, people don't have to worry about writing down these points because they'll be summarized on the next slide, but Luke's gonna make them while the slide's up. So
Yeah,
don't worry about grabbing your pens too tight.
Great, yeah, great point. So the first point, which you may have noticed immediately, is that for most generic medications, members would pay $0 for under the Part D option. You can that could be a big deal for many Medicare members. Many are taking 5, 10, or even more generic medications simultaneously. So that could add up to some savings. And you'll also see on the far right column there that accounts for approximately 90% of prescription drugs dispensed, at least in UMP for 2023. The second point I wanted to bring up is on the preferred brand row. There would be a significant cost advantage for members who fill a preferred brand product under the Part D option compared to UMP. They would have an opportunity to save approximately $35 per month, which, you know, that's a couple of Netflix subscriptions. It's $420 a year in addition to potential premium savings. The third point here is that members would pay $15 more under the Part D option for preferred specialty medications. You can see on that table, only about 3% of UMP Medicare members used a specialty medication in 2023. And it accounts for just a little bit over 1% of total prescription volume. Not to minimize that they may have to pay more for specialty medication, but it does affect a minority of members. And then finally, and this is an important point, under the Part D formulary, most non-preferred products are still covered. Although they are likely subject to prior authorization, under UMP, non-preferred products are not covered at all. So to be coverable, they have to go through an exception process, which often requires a prior authorization and trial of all preferred alternatives on the preferred drug list. So one could argue that actually for these non-covered and or non-preferred products, this Part D option has greater access. Next slide. Yeah, this is the summary slide. So were there any questions about those points that I just laid out?
Let me ask you, like Eliquis and Entresto, what are they considered under this formulary?
Yeah, I'm actually getting to that in a couple of slides, but yeah, they're considered preferred brand products. So those are opportunities for savings.
Elliot has her hand up.
Go ahead.
Yes, how do you define a preferred brand? Who decides what's preferred and how?
So that, are you asking specifically related to the Part D plan? Or
Yes, to the proposed Part D plan.
yeah, so first off, Part D formularies have to be reviewed by CMS and approved. But how certain drugs are made preferred, it goes through a similar process as UMP, where it would go through a pharmacy and therapeutics committee. The evidence would be reviewed and then the cost would be reviewed and compared to other similar drugs. And the most cost-effective option would be preferred. And like I said, Part D plans are required to have at least 2 drugs covered in each category. Oftentimes, it's more than 2 drugs, so it's not just like one drug in each category is your only option.
Okay. Thank you.
All right. So the next slide, positive impact. So as I just mentioned, there are several positive impacts of this Part D option. I just mentioned that, or at least alluded to, that the Part D formulary is actually more expansive than the current UMP preferred drug list. And cancer drugs are an excellent example of that, where CMS requires Part D plans to cover substantially all oncology drugs, which does improve access to those drugs compared to the current UMP. The second one, and I touched on this as well, is there's improved cost savings on non-specialty preferred brand medications, which would benefit approximately 12,000 Medicare members. Those numbers are as of 2023. Most would save $35 per month for each non-specialty brand medication billed. So if they happen to fill 2 of those on a regular basis, that would be $70 per month. And John, to your point, the top drugs in this category are Eliquis, Ozempic, Jardiance, Xarelto, Farxiga, and Entresto.
See them on TV every night.
Yeah, you probably know them better than I do. And then another thing that's, it's not really an advantage compared to UMP because UMP also offers this, but this plan would offer preventive vaccines without cost. So they'd continue to be available without cost. Next slide. Another big advantage of the Part D plan is that several commonly used OTC products would be covered. For context, almost all over-the-counter products are currently excluded under UMP. The Part D plan includes a bonus or wrap drug list that provides coverage of many commonly used OTC products, including multivitamins and supplements, heartburn products like omeprazole, tobacco cessation products, some cough medicines, and then COVID-19 tests. And the cost share of these would be based on applicable tier. So generics would likely be covered at $0. Next slide. So summarizing really the benefit design, I pulled the top used drugs for UMP Medicare in 2023. For context, 87% of UMP Medicare prescription drug utilizers use at least one of these medications listed on either this slide or the next slide. And this accounts for 52% of total Medicare utilization by day supply. The green rows represent a positive cost share impact for members. And then the non-highlighted or white/gray rows represent a neutral / no cost impact. You can see on this slide, most of it is green. Most of these are generic drugs available at a $0 cost share under the Part D plan. I want to point out again, row number 8, which is Eliquis, the most commonly used brand name drug in the Medicare population. As of 2023, over 5,000 members were using that product, and those members could appreciate a $35 per month savings in cost share.
Just to drive that home, Luke, you just said per month, so this is a 30-day supply.
That's correct, yeah.
So every 30 days, every single PEB Medicare retiree in UMP Classic that takes any of the 13 drugs on this slide would end up the same or better every time they pick up a drug. Every single time for each of these drugs. In 10 of these 13, they end up better. And the other 3, they end up the same. Every single month.
Correct, yes. Next slide is very similar. It rounds out our top 25. Again, most of these are generic medications available at $0 cost share under the Part D plan. I wanted to point out line number 24, which is Basaglar QuickPen. That's UMP's preferred long-acting insulin product. Under the Part D plan, members would need to switch to Lantus, another long-acting insulin product. Basaglar and Lantus have the same active ingredient, insulin glargine. However, the cost share would be $10 per 30-day supply, so that is the same. And I'm gonna actually be talking about Basaglar and Lantus in an upcoming slide.
Go ahead, Tom.
Well, I think you're probably going to discuss what I was going to say, Luke, but I will tell you that I have a friend of mine whose daughter is type 1 diabetic, and I wanted to know about that switch. And actually, she was taking Lantus, and she gets her health insurance through her father, and they had to switch to Basaglar, and there was absolutely no problem, she said, whatsoever. So I just thought I'd throw that in.
Yeah, thank you, Tom. I would expect the same thing. So thanks for bringing that example to our attention.
And so not to continue beating this drum, but on this slide, there are, I believe, 1, 2, 3, 4, 5, 6, 7, 8, 9 rows that are green. Every single month, any PEB Medicare retiree on UMP Classic Medicare, every single month would end up having a lower out-of-pocket. Actually, they would have no out-of-pocket expense compared to what they have today. Is that right, Luke?
Yep, and I have made this point earlier, but it's really incredible that you can sum up over 52% of Medicare drug utilization in 2 slides. Just throwing that out there, it's over half by day supply. So yeah, I guess next slide.
I just wanna do a time check, cause at 3:45, we gotta open for public comment. Okay.
All right. So there's been a lot of interest historically from the board and also members of the public about step therapy. So I wanted to briefly talk about that. Step therapy is when a plan requires trial of a different medication prior to covering the requested medication. All plans employ step therapy as a method to ensure the most cost-effective medication is tried first, including UMP. The Part D plan employs step therapy significantly less frequently than UMP. That's an important point. And then similar to UMP, if a member demonstrates they have previously tried the step medications or unable to try them, they would be approved for the requested medication. And that's similar to how UMP handles it today. Next slide. So similarly about prior authorization, PA is also used by all plans, including UMP. It ensures medications are being used effectively, number 1, and directs members to the most cost-effective medication, number 2. PAs typically expire after 6 months to 1 year and require renewal for continued medication coverage, even if you're staying on the same plan. And nearly all drugs that require PA under the Part D plan are either not covered by UMP or also require PA by UMP. So very similar. Finally, moving to the exception process. So if a member's PA is denied or their drug is denied due to step therapy or something, they're welcome to go through the exception process, which is similar between the Part D plan and the current UMP plan. Both require review by a clinician. The turnaround time is 72 hours for standard requests, and both allow for opportunity to further appeal. For non-formulary requests, the Part D plan would require trial of 2 formulary alternatives. Conversely, UMP requires trial of all formulary alternatives, which oftentimes is a lot more than 2. So that's an advantage for the Part D plan as well. If a member is unable to get the requested medication, they are able to get a 30-day transition bill within their first 90 days of enrollment, and that just facilitates continuity of care if they need, for example, a new prescription or something. It gives them an extra 30 days. Next slide. Yeah, this slide. So as we get close to the end here, I wanted to share an analysis that was performed to estimate the impact if members move from the current UMP PDL to the Part D formulary. And to note, this is a preliminary estimate as of October 2023. It doesn't account for future drug or enrollment changes. For example, Alyssa shared earlier today about how a certain number of members moved out of the UMP Medicare plan, so this doesn't account for that. But as of 2023, 39,647 members would have been able to continue all of their medications on the Part D plan. At the time, that was 92% of members, and it accounted for 98.2% of prescriptions. 3,832 members would have may have had to switch at least one of their medications to an alternative, and that accounted for 1.8% of prescriptions. Next slide. The medication with the largest impact in this analysis was Basaglar. Basaglar, as I said, is UMP's preferred insulin glargine product. Covered by Part D instead is Lantus and Toujeo, both also insulin glargine. At the time, that would have impacted about 1,800 members, which is about 75% of total insulin users. I'll say it again, Basaglar and Lantus have the same active ingredient. Each product is administered in the same way, most commonly via an insulin pen device at the same dose. Really, the primary impact here, as I mentioned before, is that members would be required to get a new prescription for Lantus from their prescriber. However, we would notify members of that prior to go live. Oh, it's also important to note that Lantus used to be preferred under UMP, I think, pre-2018. So many of these members may have experience with Lantus already. Next slide. So the second impact here is inhalers. This affected at the time 691 members, which is only about 9% of inhaler users under the UMP Medicare plan. However, there are some differences. For example, Spiriva hand inhaler or tiotropium is covered by UMP. Instead, Spiriva Respimat, which is also tiotropium, same ingredient, different inhaler type, is covered under the Part D plan. Incruz Ellipta is also covered by the Part D plan, which is a similar ingredient with the same inhaler type as Spiriva hand inhaler. Moving to Qvar, a similar situation where there are similar inhaler types and ingredients available under Part D plan, and then fluticasone salmeterol, covered by UMP. There are some alternatives covered by Part D as well. In general, there would be either an inhaler with the same active ingredient in a different inhaler type available, or the same inhaler type with a similar active ingredient that's available. Next slide. So this is the final slide for this analysis, and it involves other or miscellaneous products. These mainly involve changes to dosage form. In most cases, the member would have an alternative with the same exact ingredient. A couple examples are listed here. For example, the fluoxetine and venlafaxine ER tablets are covered by UMP. The Part D plan covers the capsule version of those products, which is available in the same strengths. And then the second example here is Desinide, which is a corticosteroid product. The cream and lotion are covered under UMP. The ointment is covered by Part D, but there are other corticosteroid creams and lotions available as well. And next slide.
Just to be clear, the last three slides that you went over were really the more comprehensive parts of that 1.8% of total scripts that you highlighted before you went into the 3 examples. So just to tie that together.
Yep, exactly.
If you could do your slide on pharmacy network. that'd be
Yeah, last slide. In general, the Part D pharmacy network would be very similar to UMP's current pharmacy networks. Members could continue to fill at the same mail order pharmacies, so the postal prescriptive services and Costco mail order. In 2023, 118 UMP members filled at least one prescription at a pharmacy that is not in the current Part D network. However, 10 members who currently travel less than 10 miles to a pharmacy network may have to travel more than 10 miles under the Part D plan. I'll note here that it's still early. MODA continues efforts in contracting more pharmacies to the Part D network, so it's highly likely or possible that this number will actually shrink prior to 2025. And that's the end of this presentation. I'll happy to answer any questions.
And Luke, that 118 members was out of 43 to 44,000.
Yeah, correct. About 44,000.
Thank you all for this very thorough presentation. I think, Dave, if you want to go to the next slide. And for those waiting for public comment, we are just going to finish this topic and we'll be right with you.
Yep. This is the same slide that Ellen, I think, presented much earlier. But we just wanted to bring it back to remind people what this timeline is. Again, it's not that there is a requirement to do anything. But if the board wants something to act for or implement for 2025, a decision would need to be on no later than April 11th. That's 2 board meetings away. We have a strong tradition of introducing resolutions at the meeting, at least the meeting before any action is taken. We have not begun working on a resolution, and we just want to know, do you want us to bring you a resolution with additional refinements on finances and other questions that have come up, as well as stakeholder feedback that we receive from engagements that are planned throughout the month of February?
I certainly appreciate that you all have done this level of diligence. I think it's really important that we get public comment. However, I think it's very likely after we have public comment that we will be directing you to start drafting a resolution. Again, everything is draft. We're not taking action till April, but I think we should continue to prepare to move in this direction. And I'm just wondering if we need further discussion or if there's any board members that disagree with the staff continuing to work this topic. Looks like everybody's in agreement. Thank you all.
Nice job.
Yeah, very nice job. Thank you all. And
I would say this is a lot of hard work in the last 9 months. And it's something that really does seem to address a wide range of concerns in a way that I think people thought may not be possible. And that's not to minimize the number of impacts that would happen for a very small part of the entire population, but the magnitude of potential good for the tens of thousands of members who are in or could return is very significant.
Dave and staff, you guys did a great job. We are going to pivot now to public comment. This is the portion of our meeting where we open up the floor for public comment. If there's anyone on Zoom that wants to provide public comments, staff is going to alert me. Yes, there are hands. I'd like to first gather that list of speakers so we can effectively manage the time allowed for public comment. And if you are virtual, you're, I think, already acknowledging you're putting up your hand so that you can speak. First, I'll ask, is there anyone here in the room that would like to offer the board any public comments? Not, I think Ellen is just going to the bathroom. Had to make sure we were all awake to get you to laugh. All right, so. Kezzy, do you want to start giving me the list and we'll go?
So we have eight people that would like to provide public comment. We will start with Carol Dotledge.
Great, and I would ask for those of you weighing in, if you could identify yourself, who you are representing, and limit your comments to about 2 minutes to the full board. Go ahead, Carol, you're our first presenter. And who is on deck?
After Carol, we will have Linnea.
Okay, and Linnea, if you'll be getting ready to come off as Carol is finished. Go ahead, Carol. Good to see you.
Thank you. It's good to see you. I just have a question because I just simply don't understand. Why are we losing our drug subsidy? Why is the state not getting their $21 million? I didn't, that was unclear to me. So that's my one question. And my second question is, there were examples of drugs given where people would have to change over, but during the earlier part of the program, there was a discussion that some drugs would be negatively impacted, and I didn't know, I wanted an example of a specific drug that would be so affected. And then my third comment, if I may, is that I'm not here alone. I'm with Diane Rauschenberg, who would also like an opportunity at some point to speak. Thank you.
Dave, can you speak? Molly, can you come back up, please, and respond to the question regarding why are we losing the 21 million, the RDSD?
Yeah, so there are two moving pieces to this. One of them is that the value of our plan, we have to show that it's at least as generous as the standard Part D benefit. And as our premiums go up, the value goes down essentially because the members are paying more, and so the generosity of the benefit in a sense is a little bit lower. And at the same time, there are a lot of changes happening to the standard Part D benefit that are making it, from a member perspective, a more generous benefit. There is now a maximum out of pocket limit of $2,000, which did not exist before, so that lowered member cost sharing. And there are some other changes. The donut, they've got rid of the donut hole. So those changes enhance the Part D benefit, and our premium increases kind of reduce the generosity of our benefit, and therefore we're not passing the test showing that we're at least as generous as Part D. And that, that may have happened regardless of the changes under the IRA. But that definitely pushed the timeline forward for us.
Thank you.
Did you want to comment quickly on any of the examples or refer her to the handout?
Yeah, sure. You want me to?
Yes, could you come up closer to the microphone? Linnea, we're gonna get to you next, and Diana, we are gonna put you in the queue, okay?
Yeah, thank you for your question. I outlined several specific examples in my presentation. One of them was Basaglar, the insulin. There were several inhalers that I mentioned that would require switching to similar inhalers.
So those are the most serious negative impacts?
Yeah, that's correct. I did my best to outline, to be fully transparent with everybody and outline some of Dave told me not to call them negative changes, but yes, correct.
Negative is in the eye of the beholder. If somebody had Lantus before and is going back to it, they might not see that as negative. It is a switch.
Thank you for that. All right.
I thought there was something more serious than that. Thank you.
Thank you for those comments. I'd like to move now to Linnea Mulder, if you'll unmute Linnea, and Diana, we'll come back to you. You're in the queue. So Linnea, you're next, and Matt Gershon, you are on deck to be third. Go ahead, Linnea. You'll introduce yourself and who you're with.
Hi, my name is Linnea Mulder, and I'm a UWMC retiree. Thank you to Claire, to Director Birch and members of the board for the opportunity to speak. These are Luke questions, which I think he basically answered, but just to clarify, if a person has already tried and failed covered alternatives and an exception is granted under UMP, or a person has an approved pre-auth through UMP, barring formulary changes, would that pre-authorization and exception process need to be restarted, switching to the Medicare to the new Medicare D part, understanding that usually it has to be done annually anyway. And then for the very small amount of people that might be affected by changes, what will HCA do to support those members with those changes? And then just a kind of a personal comment. I have a daughter with type 1 diabetes and a friend with type 1 diabetes, and I asked them about the insulin changes, and they both thought it was fine. Thank you very much.
All right, so yeah, thank you for your question. Regarding your first question about if they had been approved, step therapy under UMP or an approved PA under UMP, would they have to go through that process again? The answer is yes, they would. It is a new plan. It's a totally new plan, so we're not able to just grandfather members over. However, I will say that at least related to step therapy, that member should have records, and they'll certainly have, UMP claims data that shows they have stepped through the appropriate medications. So it might not be automatically approved through the Part D plan, but MODA should have access to information showing that, yeah, they've stepped through these medications and they should be able to get on, the medication they've been currently taking through the Part D plan. And similar with prior authorization too, they'll have to go through a PA process under Part D. But to your point, they have to go through reauthorizations anyway on an annual basis for UMP. The second question was, can you?
HCA support when they're changes in the formulary.
Yeah, so it would be handled similar to how we handle situations that come up among UMP when a member gets disrupted. We send them communications and so they can be prepared and know what to do. And that's generally how we handle, these types of disruptions.
Thank you very much.
Thank you, Linnea. Thank you for that, Luke. I just want to remind members of the public, if there are things staff don't have answer for, we'll get them for future meetings, because this is all information coming to us. We don't have everything completely worked out.
And Chair Birch, what I'll just say is, we usually don't engage in question and answer, but at the same time, this is such an expedited timeline. We recognize that on such an important issue, that where we can answer now, especially, I think many of us recognize many of our commenters are some of the most engaged members with various parts of the retiree community, that if we can answer your questions now, we're more than happy to.
Please, we're trying to set the expectation. We might not be able to answer all the questions, especially with this lineup of folks wanting to speak. Matt Grisham, you are next, and then Fred Yancey, you are on deck. Go ahead, Matt.
Yes, thank you, Chair Birch. I appreciate the opportunity to comment. I'm Matt Groshong. I am a member of RPEC. I am not representing the organization. First of all, I want to sincerely thank the staff that has obviously put this on a super fast track. I can't imagine the amount of work that's gone into this by across the organization. I really appreciate it. I think this is from what I can see, and I've read all the materials, I'm a nerd that reads certificates of coverage. This looks good, and I appreciate that. My concern is not in the plan itself, but in how it's rolled out. There are people who are subscribers who are not on the internet. There are subscribers who do not use email. There are subscribers who, even if they're on the internet, they're not technologically capable of attending one of the town halls. So that leaves good old US mail. And so I'm not expecting a response, though I would appreciate one right now. But what is the plan to reach everyone who's a current subscriber on this so that there are no surprises, so that in April, this is approved and then people find out about it as a surprise. And that would be the worst possible outcome. And I'm sincerely hoping that you have a plan and act towards making sure that everybody knows what's going on. Thank you.
Matt, thank you for your comment and your concern. I will just assure you that this still would have to go through a lengthy approval process. And so this wouldn't begin until 2025.
I can respond at a high level, Matt. Anytime we make a policy change, and by we, I mean the royal we, whether it's the state, the board, the agency, I say we because the agency has to administer all changes. Many of those changes, there is never a 100% awareness rate. We will strive to get as much information out as possible, but even in the policy development process, the goal is never, 100% would never be achieved. One thing that the agency did learn about with retiree engagement in particular in the past 18 months, we have put together, and I think we glossed over this a little bit, but in the month of February, we are going to do a variety of outreach in a way that we haven't done before when a policy is coming before the board. And we will do, as you noted, a lot of them are internet based. Ellen will do a webinar next week that's going to be recorded and put online that will go through a level of detail about this, very similar to today's presentation, and build on questions that we've been hearing. We're going to push out that piece. Again, that is electronic based. The February newsletter that is now retiree specific, it's already at the printer, so there's not more content that can be in it, but it does acknowledge and direct people that there is this conversation that is happening at the board and how to find more information. You're correct that it is primarily online, but that newsletter will get to people based on a print communication. We will be doing town halls. 3 of those right now are scheduled to be virtual and 1 in person. The 1 in person was selected for Olympia because that's where the vast majority of our public sector retirees are. We recognize that that's not a perfect scenario. We did receive a letter from some stakeholders, including RPEC and the Medicare Coalition that we've been working with over the past 18 months that had some suggestions for ways to refine if that expedited stakeholdering process that we've envisioned for February couldn't be expanded to other months. And as I've tried to highlight before, we could have a whole year of stakeholder, it's just then it would be a 2026 pattern. So we are going to try to do as much outreach as we can. It's in a way we haven't done before. Will it hit everyone? Absolutely not. If a decision is made, we're going to be doing everything we can to make sure people who are absolutely directly impacted get those individual notifications, like when a formulary is switched, and we would be on a path to be able to work on describing that while rates are still being developed. We'd be able to have a 6-month communication plan, not just about open enrollment. So I hope that's helpful context. It may not reach everyone. It is more than we've been able to do before, and I think it's hopefully a good gesture and process that we're developing, knowing the importance of this particular topic.
Thank you, Dave. I'd like to move on now to Amy. I'm sorry, Fred Yancey, you're up, and then Amy Porter, you are on deck. Go ahead, Fred, if you'll identify yourself and your affiliation. Fred, if you're speaking, we can't hear you.
I'm still hitting my buttons.
Now we got you, Fred. Go ahead.
Okay, thank you. This is Fred Yancey on behalf of the Washington State School retirees. First of all, my thanks to the staff for all the excellent work in gathering information and presenting it today, and certainly my thanks to the board for enduring a long day of lots of information. Appreciate it. I'm excited with the idea of Plan D, and I think our members will be too. But I certainly hope that in the future, when the rate projections are being discussed and, you know, and kind of even preliminary showing, that they would also have a column showing the addition, the net effect of what the waiver, the subsidy does. In other words, you know, we all know the subsidy is 183, maybe 193, but let's say 183 or 50%, whatever is less. So I envision some sort of chart that shows here's the premium projected, here's the subsidy applied, and here's the, you know, the premium that will be charged. You know, I would like to see that data because I know the premium, as rates change, as the premiums change, the subsidy changes as well. I hope that was clear, you know, but anyway, again, thank you for your work. Appreciate it.
Thank you, Fred, and I can assure you our great fiscal team back there, our CFO and Tanya and everybody are taking note. They will have those visualizations in the future as we have that information.
Thank you very much.
Amy, I'd like you to open up your mic, and then next is Aruna Bhuta. Amy, go ahead.
Yes, good afternoon, Chair Birch and members of the board. I too also want to commend staff and the presenters for a very fact-filled and informative day with certainly new insights for the challenges ahead for all of our healthcare. I particularly want to urge the public outreach to be two-way and interactive. I would go so far as, rather than a webinar, that these be workshops, if that's possible, or workshops in the for the town halls, so that people have some opportunity for feedback and answers, as well as questions. Possibly an FAQ. Would also suggest some kind of one-pager that says, here is what the plan would look like for the almost 37,000 subscribers for 25, and that would include the medical information, the coordination of benefits, the continuing dental and hearing aids, and just to be clear as to what's exactly there. So an itemization, and then the fact of how the pharmaceutical plan would work as the Part D, E, G, W, E. All of these are going to be new things for people, and I think it needs to be crystal clear. That would have to do with 25. With 26, I heard the call for new services or suggestions, and just a non-itemized thing. Ideas for the 26 procurement might be household insurance, household and multi-generational insurance. They might include long-term care, fitness and nutritional services, massage and alternative medicine, elder care assistance, and I hope you won't laugh, but pet insurance. Thank you for your time, and again, for all your work.
Amy, for the record, could you just please state your full name and your...
Yes, and again, my name is Amy Fortier. I live in Sequim. I am a member of RPEC, but I'm speaking on my own behalf in this case.
Thank you.
And thank you again.
Thank you very much for that input. Aruna Bhuta, if you would open up your mic, introduce yourself and your affiliation, and then Sharon with an iPad, you're going to be up next. I don't know your last name. I apologize. Go ahead.
Aruna Bhuta from Spokane, Washington. I'm a member of RPEC, but I'm just talking as an individual. I also want to commend the staff for very informative presentation so that it's very clear as to how this is going to impact the enrollees. My main concern is the people who are on Uniform Medical Plan most of them are very sick and have been on it for a long time. And also too, they are more older population than younger retirees. And so the information that you give needs to be very clear in a simple language so that they can understand. They're afraid of change. And that is, what we need to be clear. And I'm glad Dev mentioned that we are going to begin this in February, explaining things, but it is going to continue for 6 months before, and it's not just going to restart in November, because this two-way communication, needs to continue. And also too many people are not even familiar with various terms that we are using in this discussion. And so even, sort of simple explanation of each word that, formulary and step therapy and all, if that can be explained as clearly as possible so that there'll be less fear of unknown. More we make the process transparent, easier it is going to be for people to make the decision to move forward, which will be beneficial to everybody. Thank you for your time. Bye-bye.
Thank you for your comments, Aruna. Sharon, if you are on, if you could open up your mic and identify yourself, and Christine Clark, you are on deck.
Yes, I have, can you hear? You
Yes.
can hear me?
You identify yourself.
Oh, I'm Sharon Etheridge. I'm Secretary of Chapter 13 in Spokane, Washington. Also, I'm a very passionate uniform medical subscriber. So my question is, I think we said there was no donut hole. And another word that strikes fear in my heart is like Medicare Advantage. If Medicare doesn't cover it, Medicare Advantage does not. So I'm wondering if that type of thing applies to Medicare Part D with this Medicare Part D that's going along with uniform. And the other question I have is we talk about saving $200 on our medical premium, but what is that Part D going to cost? Prescriptions by the chart look like they're going to be quite cheap, but if you're paying out $300 for that and save $200 on your premium for the medical part, you're not ahead. And how long, it seems like it's too fast. We don't have any hard, fast figures.
Thank you, Sharon. Again, I've asked Ellen to come up to the table to respond, but we aren't taking action. We are simply hearing the presentation from the staff, and we are calendaring this for future board discussion. So Sharon, I'd like Ellen to respond to your specific questions. We're not taking action today. Go ahead.
So but I don't understand what you mean you're not taking action. When I asked that question about.
We received guidance from our staff about a possible proposal. And so
I listened to it.
Yes, and so we are merely signaling to the staff to go and continue to work this proposal and prepare to bring it back to the board. We've also signaled to them, they have shared with us that they're going to be doing a lot of work in the month of February with stakeholders to do outreach and whatnot. So we are trying to better understand as the rules are finalizing from the federal government. We're trying to get all the information in and try to better understand what the financial modeling looks like and what are all the implications. But because we are hearing such significant positive direction, we're encouraging the staff to keep developing this proposal and bring it back to the full board for possible action in upcoming months. But Ellen, would you like to talk a little bit more specifically about the donut hole question?
So first of all, the Inflation Reduction Act would eliminate the donut hole in 2026, I believe, for all Part D plans. And our plan as an employer group waiver plan would also eliminate the donut hole. The donut hole is a point where Medicare retirees would pay more for their prescriptions when they reach a certain level of what they have contributed as their payments up until the catastrophic phase. All of that is going to be phased out by CMS over the next year or so. In terms of the Part D premium or payments, that would be embedded. When we talk about the savings to the UMP premium, that would include the Part D piece. So there would not be an additional cost for the Part D coverage that would be included in the premium. And that is projected to be a significant savings over the current UMP premium, which also includes prescription drug coverage.
Thank you, Ellen. And again, Sharon, staff are just bringing forward information. They're gathering, they're informing the board. They wanted to say to the board, do you want us to keep, working this proposal? And we have said, yes, we want you to bring back more information, more definitive visuals, and begin to talk to the stakeholder community. So this will be many more weeks and months in the making before a final decision is taken by this board.
But it's still an iffy thing if you're a uniform subscriber about things like cost, you know, and I could ask these questions at the benefits fair, but uniform was not represented in Spokane or anywhere, I don't think, around the state. So
Sharon,
I'll wait.
This is Dave. I'll just that we definitely have uniform medical plan, both HCA staff and regents and MODA present at the benefits fair, so we can work on some clarification.
Excuse me, but I asked the PEB gentleman that was at the head table, and he said they chose not to be here. That was an empty table.
We will follow up on that. That
Thank
doesn't
you.
match my expectations or understanding, but we'll definitely follow up on that. I just want to reinforce that the premium that is being talked about includes the pharmacy coverage, but we're talking about that net downward pressure of a significant amount of money per month. Everyone who signs up for UMP Classic Medicare under this idea, if it were adopted, would have medical and pharmacy coverage that has many pros that Luke highlighted, and they would pay less premium.
Okay, thank you.
Okay, I'd like to have Christine Clark open up her mic. You're next, and then Tony Long, you are on deck to speak after. And Christine, if you'll identify yourself and who you're affiliated with. Welcome. Oh, Christine, you're muted. We cannot hear you. Try again, maybe me. We still cannot hear you, Christine. Christine, we can see you, but we cannot hear you. What we will do, Christine, maybe you could sign off and sign back in. And then we'll move to Tony, and then we'll watch for you to come back on, and staff will let me know. Let's try to reactivate your sound that way, okay? All right. Okay, sorry about that, Christine. I'm not sure. Tony Long, why don't you go ahead and open up your mic and give us your comments and feedback, and then also Diane Rosenberg, you are on deck.
Okay. Thank you very much for the opportunity to respond. And thank you, as the others have, for all the hard work that's gone into this. And I've read the presentation.
Your name and affiliation, please.
Oh, I'm sorry. Thank you. Tony Long, and I am a member of RPAC, but I'm speaking for myself. And I've been a uniform medical plan enrollee for since I retired, but also before retirement. And I'm very happy with that plan, except like other people with the rising premiums. My concerns are twofold. One, I have no concerns about the actual content of the plan as it affects me. But one concern is the ability to reach people throughout the state. Some retirees are a particularly challenging group, I think, because of their sometimes having lesser computer skills. But I'm concerned about the 1.8%, what is it, 3,832 people who will see their medications affected, at least one, if not more. And is there any way with, I don't know if HIPAA prevents this, any way to get word to those enrollees and to reach out and people speak with them about what the actual impact will be for them, so they can fully understand, because they may not, you know, maybe an older group within the retiree group, and they may not, you know, pick up on how just everything that's happening. It's so complex, as you know. And that's all I have to say. Thank you,
Tony, for that feedback and your comments. I think staff have answered that before about the extensive outreach that they intend to begin in February, and then it will be coming back to this board, and lots of strategies about outreach. Diane Rosenberg, I think you were on with Carol Dotlich. Could you go ahead and open up there you go, your mic, and then Sue Hendrickson, you are on deck for next. Go ahead, Diane, if you'll identify yourself and your affiliation, please.
Hi, my name is Diane Rauschenberg, BERG, and I'm with Carol Dotledge, and I'm an RPEC member, but I'm basically speaking for myself. Number one, I want to thank the board so much for all your hard work. I have to say I worked for the state for 40 years, and my first few years of work, I had Blue Cross, and after that, I picked uniform, and I never changed, so I've had it for over 40 years. I have to say this is wonderful insurance. I'm so grateful and thankful for what you did for us, but I'm really concerned about things that are coming up as far as some of the changes that the vendors might be partaking. The one that I know it's in a negotiation right now, but the challenge for me, I've had the doctors and the care from that vendor for over 10 years. And if they don't reach an agreement with this vendor, that means I will have to change all my doctors and all the care that I've been getting for 10 years. My husband and I both, we've been married 58 years. We're both close to 80 years old. And as you said, you're going to be having these meetings, and most of them are going to be in Olympia. But the challenge is a lot of the PERS 1 retirees that are choosing this wonderful plan do not have the ability to come to Olympia. And they really, I do believe that it would be very beneficial for you to hear. I know I went to the one that we had last year when some of these changes were coming up, and there was a huge group of people that came and had many comments for the Public Employee Benefit Board, and we were kind of hard on people, but I do appreciate all your hard work. I really think the town halls and notifying as many people as possible. As I said, I'm kind of technically challenged. That's why I'm here with Carol, because I'm not really that good with the computer myself. But I do want to thank you again, and I do pray that I'm going to be able to keep this program, and I know how hard you're working to cut costs for us, and I want to thank you very much for your hard work. And I still want to continue with this program, and I know, as they say, it's one of the more expensive insurance plans that we have, but it's absolutely the best. I have to say that, and I want to thank you for your time. Have a great afternoon. Thank you.
Diane, thank you for your comments. Congratulations on 58 years of wedded bliss. And I think your first comment, though, was related to Regents and multi-care. Is that correct?
That's correct.
And that did not come before the board, but that issue is about contractual contracting that is not resolved. So thank you, Diane. We are monitoring that, and we appreciate that, and we appreciate your feedback about outreach and communication.
I'll just want to highlight on whenever there's provider network negotiations that are happening and termination letters go out, like advance notice of a pending termination, the timeline for those is required by the Office of Insurance Commissioner. The actual termination date right now for that particular agreement is February 29th, so 4 weeks away from now. And I am very aware that the two parties are still in active negotiations. And there are many times when such notification letter goes out that there is a rescission by the time the final day is upon us. So there's a lot of monitoring going on about that situation, just as there has been for other provider network disputes that have had similar letters that have gone out in the past year. So we're definitely aware of that one and doing what we can to keep aware and keep people apprised of the status.
Thank you, Dave. All right, Sue Henriksen, you are next to speak. If you'll open up your mic, identify yourself, your affiliation, and then Christine Clark, we're going to circle back to you and see if you've resolved your mic issues. So Sue Henriksen.
Yes, my name is Sue Henriksen, and I'm a member of RPEC, and speaking for myself, I heard that the donut hole was going away for Part D in 2026. If the board decides to go to Part D, enhanced Part D, will that donut hole be in effect, or does the enhanced Part D that you're looking at get rid of a donut hole?
Ellen is coming to the table to answer that question about, I believe the donut hole sunsets in 26. It eliminates, but let us come back with a cleaner visualization and more information, because it's my understanding the CMS rules have not finalized. Molly looks like she has a preliminary answer, but again, Molly, do you want to weigh in just a little bit?
Yeah, so technically the donut hole sunsetted in 2020. It was a period where within the defined standard benefit, members had to pay 100% of drug costs. They were paying fully out of pocket, and that went away in 2020. It slowly closed between 2011 and 2020. But there are other changes to member out of pocket costs under the IRA.
We will be coming back in March with more information, and it seems very clear that we'll have some slides about the donut or non-donut hole.
Fitting that we serve donuts.
Okay, thank you.
Good. So we will be answering that question with kind of more refinement in future meetings. All right.
Okay, thank you very much.
Thank you. Thank you for your patience. Christine Clark, if you are on again and have sound, we'd love to hear your comments. Christine Clark.
On and she's unmuted, but
Christine, you are on. And just for a little coaching, if you look down in the left bottom of your screen, there's a little microphone with likely a red arrow. If you can take that red arrow off of it, you might be able to have sound.
she's unmuted.
Christine, you are unmuted, but we cannot hear you.
Christine, if I can make a friendly suggestion, there's an email that you could send some information to. It's PEB, PEBB, no, what?
HCA PEB Medicare.
HCA PEB, PEBB Medicare at hca.wa.gov. And if you want to submit some comments there, we'll make sure, or if there are questions, then we'll be able to answer those questions. I just want to give you another way to communicate since we're having some technical issues in being able to hear you today.
All right, we have heard from members of the public. Aruna, I think your hand is raised again. I don't know if you're asking for a second comment or if you've just not put your hand down.
No, it is for second comment. Thank you for giving me a chance again. I have just observed that whenever we have any health benefit fairs or any information at the time of open enrollment, there is greater push for United Healthcare's MAPD plan, but not for as much for the Medicare supplement plan that we have through Premera. Is there a reason? Is there any benefit to the state or to healthcare authority with United Healthcare plan offering versus Medigap plan? Thank you.
Aruna, I'd love to follow up with you. We try to be very agnostic as much as possible. So about plan selection. So I'd love to discuss with you the ways in which you're seeing that there's a preference in communications, because my expectation is to root that stuff out. And so I'd love to follow up with you on that. So I'll reach out to you.
And Aruna, I'll be very clear. There is not, to my knowledge, any sort of contractual financial relationship between any of the entities that are marketing to our members across any lines of our business. We remain very neutral and encourage them all to make their best case for why members should select them. So, all right, I don't see any other hands up. I see staff saying we are done. So at this point, I am closing public comment. Dave, I would like you to help take us into our end game here. Dave is going to preview to us the 2024 PEB board preview. And as everybody knows, Dave is our director of the Employees and Retirees Benefits Division. He's going to provide us with that preview of the coming attractions for this board's season. His update is verbal, so there are no printed materials. Yeah, so Dave, go ahead and tell us what we can anticipate to be seeing.
Great. Well, over the next 6 months, a variety of different topics. Some of them you're probably aware of, some of them you might have forgotten about, and some you probably have no idea yet. So I'll cover maybe a little bit of all of that. Hearing the interest in the UMP Classic Medicare Part D piece, we will bring more information back and a resolution for introduction in March. I'm keeping an eye on that April 11th date for a decision, AKA action, also known as voting, for those various thesauruses out there for what that means. about a direction on UMP Classic Medicare so that we can then roll into rate season. It's been mentioned a couple of times today about the standalone vision benefit. That's a policy decision that was made that is the direction it's going. It is the way the benefit will be structured for non-Medicare and employees to have a standalone vision benefit. But we have some resolutions that will need to come your way for the final implementation aspects of that. And I know all of you will be really excited, but we get to revisit those dual enrollment resolutions because they all have references to specific plans. So we'll be bringing a variety of resolutions back to you next meeting, actually introducing those in March as well. We also have some changes around the eligibility and who can enroll in the high deductible health plans. There's some financial nuances that are going on there that we have a recommendation we need to make to you about how to proceed on the who can enroll in that plan going forward. And then of course, as we get later in the season, rate development. And I know everyone is going to be very curious about how things are going given last year's rate development process. I want to reassure all of you that I think we took just the month of August off, and then we were right back into the conversations with our carriers, including Kaiser Permanente, about the future rate development processes. So those are just a few key aspects. Just highlighting for next board meeting, we will have the results of the legislative session, which will then be over. Information again about the next steps and donut hole information and resolutions and other things that we learn from the stakeholdering over the next month on the Part D option before you. And then again, we'll once again get to revisit dual enrollment. And that's all I have. So I'm really impressed that we got all of this done with only 7 minutes over.
So Dave, thank you so much. I'd like to go ahead and close out our meeting. I neglected at the beginning of our meeting, though, to draw attention to this being February being Black History Month. Kate was kind enough, where did he go, to share this book with me about the Black history here in Thurston County. So I do want to just ask all of you to pay particular attention to all the celebrations that are going on this month. We have now concluded our 2024 board season retreat. I hope you all have found this as full, energetic, and exciting about our future directions and the work that has been done. Dave, you and your team, all of you out there do a remarkable job modernizing, staying on top of things. You've heard time and time again today in the presentations. We're very unique in this nation for the way we use our purchasing power, our alignment, and really our move towards kind of better social and justice issues. So I really want to thank you for all that you all do all the time. It's really remarkable. Our first meeting of the regular board season will occur March 21, 2024. We will have the same format of attendance in person or via Zoom. We really love when you guys come join us. So please try to make the trek to Olympia and be here in person if you can. We also get it, though, that circumstances do occur. And we thank our board members that are online virtually as well. So thank you all. Been a very productive day. Dave, any final comments before we adjourn?
Did all mine before.
Okay, good. All right, this meeting is adjourned. Thank you all. Be safe on your travels home.